Moving on, I'd now like to welcome Dr. Jaideep Herbert, Head of INACSL North India RIG, to unveil the theme.
Thank you, Joshua. A very good morning to ladies and gentlemen. It's my pleasure to unveil the theme for this conference. It's a first international conference in India for nursing simulation. You all know about the theme of the conference. The day that the brochure has released, you all see that what's the theme of the conference. That is the transforming brain power to hand power.
And while we have the anthem, let's use our left hand and put it on our right collar.
Knowledge, we ignite, harnessing our minds to shine the light.
Jana Gana Mana Adhinayak Jaya He Bharat Bhagya Vidhata.
I bring greetings from the Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India.
Good morning. How's the Josh? That doesn't sound like hi. How's the Josh? Okay, that sounds better. So I call it that's a night shift crisis, you know. This is actually a series.
A presentation, not concern, a comment. So many things are there which we can do as nurses. So many things are there which can be taught to them when they are working.
Everybody can run in the same day and we can finish it off. Similarly, we calculate 1 hour of, 1 hour of simulation equivalent to 2 hours of clinical practice.
It's true that, nurses are expected, not only nurses, in fact, everyone who steps into the world of healthcare, especially in the private corporate.
I think the underlying thing is the cost. I mean, you can't expect private corporate players like us, Apollo. You can still go ahead and then buy a simulator and then make people train. Like for example, a simulation trainer.
I think it's very interesting, and congratulations for your first Congress in India, because I think it's going to be challenging and will bring a bright future.
As welcoming you all for this panel discussion, the topic for the panel discussion is from classroom to bedside, aligning nursing education with clinical expectations. But
friends, contrary to your expectations, I'm not going to list what they don't have.
I can understand what they are feeling, and their comments are not wrong. But I'm not going to take it as well, because the academicians or the private sector need to really work hard.
Gen Z. I mean, so when we talk about Gen Z, I have 2 sons. I look at my son, and especially my younger son. Both the sons, have got almost 7 years of difference.
Okay, so it's working now. So this is just an interface which we are using on Google Chrome. So no software designed by us or by anyone. You can just use your own phone, open a Chrome, and you can start using the software.
For that insightful presentation. Although Dr. Desiree is not physically present here, we extended our deep gratitude to her virtually for enlightening us with her expertise on INACSL healthcare simulation standards of best practice.
So before moving forward, I want to ask you 2 questions. The first question is, to run a simulation scenario, in the learner perspective, whether knowledge and skill should be clear or not.
We observed and we had lot of challenges that because of critical thinking beyond that level and the decision making is very, very poor right now.
Thank you, ma'am. Actually, this topic, this hearing should not be it should not be a debate. Right amount of technicality, right amount of, actually it will be synonymous for critical thinking and decision making.
The best simulation training is when you will integrate technical skills, decision making and critical thinking together.
Sometimes transformation is more important than innovation. और मैं इस पॉइंट से बहुत ज़्यादा मतलब मोटिवेट हुई हूँ क्योंकि हम लोग इस प्लेटफॉर्म में हैं जो हम लोग को इतना अच्छा लर्निंग का मौका दे रहा है. हम बहुत सारी चीज़ें सीख पा रहे हैं और मैं छत्तीसगढ़ से आई हूँ, सो मैं तो बहुत खुश हूँ सुबह से. ये मतलब आप लोग का प्रोग्राम कॉन्फ्रेंस अटेंड किया, इतनी अच्छी अपॉर्चुनिटी मिली मुझे. थैंक यू सो मच. आप लोग ऐसा प्लेटफॉर्म प्लीज़ और लाइए. तो हम जैसे बच्चे जो है मेरे छत्तीसगढ़ से जो आए हैं उन लोग बहुत ज़्यादा एंथुजियाज्म हो गए, सब देख के बहुत खुश हैं.
Thank you, Jaideep sir. This is like simulation we have seen just with Jaideep sir earlier, but now we have learned deeply, like with all the international experts, sir, ma'am, and like how to create moulage, how to create sessions, how to do briefings, and all the national and international experts.
I am Professor Dorvin Das from St. Francis College of Nursing, Indore, and since morning we are listening, and in that two more points I want to talk about that. Still that we are not clear about the skill learning and the simulation. So it touched to me that how it can be differentiate between the skill learning and the simulation, and also that we have to just balance between the services and the education. How we can manage these two things that it can be help or going to help to the students. So it's our responsibility that how we can manage, and still we are moving and going to do this. So this is my learning of today's. Thank you.
I'd request you all to settle into your seats as we're going to be starting shortly. Distinguished guests, esteemed colleagues, and fellow healthcare simulation experts, good morning and welcome to SiMCON 2025, the premier conference for the International Nursing Association of Clinical Simulation and Learning. It is my distinct pleasure to welcome you all to this gathering and here amongst the brightest minds in clinical simulation and nursing education. As we come together for today and tomorrow, we stand at the intersection of tradition and innovation. The landscape of healthcare education continues to evolve, and simulation-based learning remains at the forefront of this transformation. Here at SiMCON 2025, we celebrate the power of simulation to bridge the gap between theory and practice, preparing the next generation of healthcare professionals for the challenges that lie ahead. This year's conference brings together educators, researchers, practitioners, and innovators from around the globe. The wealth of knowledge, experience, and insights within these walls is truly remarkable. Over the coming days, today and tomorrow, you will have the opportunity to engage in thought-provoking discussions, witness groundbreaking presentations, and participate in hands-on workshops that showcase the latest advances in simulation technology and methodology. INACSL has long been the beacon of excellence in clinical simulation, and this conference represents our ongoing commitment to advancing the science of healthcare simulation. The presentations, workshops, and networking opportunities ahead of you have been carefully curated to inspire innovation, foster collaboration, and elevate the standards of simulation-based education. I encourage you to make the most of your time here. Connect with each other and your colleagues, share your experiences, and embrace the opportunities for learning in this arena. The connections you make and the insights you gain here will ripple through your institutions and impact the future of healthcare education. On behalf of INACSL and the entire organizing committee, I, your host Joshua Nath, thank you for your presence and participation. Your dedication to excellence in healthcare simulation is what makes this community truly exceptional. Let's begin this journey of discovery and innovation together. Thank you and welcome to SiMCON 2025. Let's give a round of applause. Now, to briefly tell about the purpose of this conference, SiMCON 2025, serves as a global platform for healthcare simulation professionals to advance the science and practice of clinical education. The objective here is to bring together educators, researchers, and practitioners to share cutting-edge simulation methodologies, explore innovative technologies, and establish best practices in nursing education. Through expert presentations, hands-on workshops, and collaborative discussions, participants will enhance their skills in designing, implementing, and evaluating simulation-based learning experiences. The conference aims to elevate the quality of healthcare education and ultimately improve patient care outcomes through excellence in simulation-based learning. I would now request you all to stand as we play India's national anthem. Jana Gana Mana Adhinayak Jaya He Bharat Bhagya Vidhata. Request you all to kindly take your seats as we embrace the spirit of patriotism after participating in this thought-provoking national anthem. Now, I want to welcome INACSL President Dr. Ashley Franklin. She's an Associate Professor of Nursing, Texas Christian University, USA, a team leader in healthcare simulation standards of best practice, an educational researcher, and an adult medical surgical nurse. Let's welcome her with a round of applause as she virtually greets us this gathering.
Simulation and learning. My name is Ashley Franklin, and I'm happy to bring you greetings on behalf of our 3,300 members around the globe. I so wish that I could be with you and partner to grow INACSL together. Since I can't be there, I want to tell you about our great organization and some of the offerings that you might participate in. INACSL was founded about 20 years ago, and over that time, we've sought to live out our core values of discovery, diversity, and collaboration. Networking with INACSL members is my favorite part of our organization. And as we sit together, we learn together and we learn from one another to improve the quality of healthcare simulation that nursing students and practicing nurses experience around the world. INACSL's mission is to be the global leader in the art and science of healthcare simulation through excellence in nursing education, research, and practice. And we are best known for professional development activities and education offerings. So I'd like to tell you what we have planned for 2025. Just like you have gathered together for Professional Development Conference, INACSL hosts several synchronous conferences during the year. In June, we'll gather in Denver, Colorado, in the USA for a 4-day professional development extravaganza, and we're so excited. INACSL offers other synchronous activities in combination with simulation professional organizations. Each May, we offer a Women in Leadership day-long virtual symposium, and we would love for you to join us for that activity that lasts about 4 to 5 hours. We also host best practices workshops that are asynchronous but online, and we host those with the Association of Standardized Patient Educators and the Society for Simulation in Healthcare, and we'd love for you to come and get a taste of what all of those organizations have to offer in our best practice workshop series. That series lasts 4 weeks, and each week you meet for just an hour. So it's a great way to get a dip in the water and learn about the different simulation professional associations. INACSL has a lot of asynchronous professional development opportunities that center around our healthcare simulation standards of best practice. For example, our Cornerstones of Simulation Best Practice program provides a way for you to take a deeper dive into professional integrity as it is applied to simulation, plus learn about the theory and tips for how to facilitate simulation pre-briefing, actual scenarios, and debriefing. Our Cornerstone modules will take you about 5 hours to complete altogether. They're a great activity for you to sign up to participate in with friends, to support each other and discuss what you're learning. I also wanted to make sure you knew about our website, which is www.inaxl.org. And it is the hub for a ton of downloadable resources, including our healthcare simulation standards of best practice that are made available for free in our journal and on our website, and also in several languages. The standards came to fruition after a meeting in 2009 and the strategic leadership of our board of directors at the time. And since then, they've been updated now 6 times by teams of international and interprofessional simulation experts and healthcare librarians. Our standards are evidence-based, and in fact, this June and July, we expect to have a release of updates for 4 standards related to professional integrity, pre-briefing, facilitation, and debriefing. On our website, you can download PDF copies of the standards and the accompanying infographics, which are a visual representation that look great simulation center or in an academic school building, just to remind you of the important criteria to facilitate quality healthcare simulation. On our website, you can also sign up to participate in discussion boards and have the discussion board email you when there's new content that you've notified it you wanted to read. It's a great way to communicate asynchronously and find like-minded simulationists and solve problems together. INACSL is very active on social media. We use LinkedIn for our monthly organization newsletter called the President's Message, and I would invite you to subscribe to that. We also use Facebook to talk about events going on that are hosted on our website. For example, Facebook is where we post the registration for the Fireside Chat series, which is part of our membership committee's effort to engage members around the globe. Facebook is also where we announce the release of our podcast called Let's Talk Sim, which is hosted on Spotify. So I hope you'll join us on both social media platforms to keep informed of what's going on in our great organization. INACSL is launching an international community of practice in 2025, and it's meant to be a place where our members can learn from and with each other about raising the quality of healthcare simulation around the globe. We envision that the international community of practice is kind of a grassroots effort where leaders identify education topics that are most important to them, have a place to talk about operationalizing best practices for simulation in the context of their country and government and area of practice, either a healthcare setting or maybe an education setting. And we want the international community of practice to be a way that members can share resources asynchronously over platforms like Google Drive and Dropbox and even WhatsApp to ask questions and get answers real time without having to be limited by time zone changes or internet access. INACSL offers international pricing tiers, so I hope that you'll look into joining INACSL, also joining the North India RIG, which doesn't cost any additional money, and joining the international community of practice as well. 2025 is the final year in our strategic plan, and I wanted to make sure you knew about the pillars of our strategic plan. We have worked so hard to foster international relationships, and one of the areas of growth has been in regional interest groups. As of January of 2025, we have 13 regional interest groups with INACSL members from around the world. Another part of our strategic plan has been expanding partnerships, both with industry and with other professional organizations, like the Society in Europe for Simulation Applied to Medicine, the Association for Simulated Practice in Healthcare that's in the United Kingdom, and the Association for Standardized Patient Educators that's in North America, along with the Society for Simulation in Healthcare. We are so grateful for the relationships and mentoring that happens across simulation societies to elevate nursing around the globe. And the final part of our strategic plan has been to increase research funding, and we've accomplished that by partnering with our industry, vendors who provide products and access to software for our members to engage in important research that advances the science of simulation. I know that you're going to have a great time at SiMCON, the first ever conference in India. I wish that I could be with you in person to share meals with you, to fellowship, to learn from you, and to experience parts of your culture. because I know you're doing great work and you're helping one another, which is what INACSL is all about. Because I can't be with you, I just have to say best wishes. I know you're going to learn a lot, and I look forward to hearing about the lifelong mentoring relationships and collaboration and the improved experiences for nursing students and practicing nurses in North India and around the globe. Thank you to members of the INACSL international community who have traveled to New Delhi to experience SiMCON with you and to lead sessions about simulation in person, implementing virtual simulation, and using serious games to help your learners improve their critical thinking, communication skills, and psychomotor skills as well. Again, please accept my apologies for not being there in person. I look forward to seeing the highlights of your great conference. Have a wonderful week.
Yes, can we give a round of applause for Dr. Ashley? Now we move on to the next setting of celebration, and this will be in the form of lamp lighting. Now for this, I would like to call on stage our dignitaries, Dr. Deepika, Dr. Jack, Dr. Pedro, Dr. Marianne, Dr. Captain Usha Banerjee, Ms. Thania, and Mr. Jonathan for the lamp lighting ceremony. To talk about the importance of lamp lighting in the tradition of Florence Nightingale, the lady with the lamp, the ceremonial lighting of the lamp symbolizes the illumination of knowledge and the external flame of the nursing profession's commitment to care and healing. This ritual at SiMCON 2025 not only honors our rich heritage, but also signifies the dawn of new insights and innovations in clinical simulation education that will light the path forward for future generations of healthcare professionally. I would now request our dignitaries to go back to their seats. Moving on, I'd now like to welcome Dr. Jaideep Herbert, Head of INACSL North India RIG, to unveil the theme.
Thank you, Joshua. A very good morning to ladies and gentlemen. It's my pleasure to unveil the theme for this conference. It's a first international conference in India for nursing simulation. You all know about the theme of the conference. The day that the brochure has released, you all see that what's the theme of the conference. That is the transforming brain power to hand power. It's a great enthusiasm to unveil the theme of the SiMCON. That's the transforming brain power to hand power. The theme reflects our commitment, which bridging the gap between the knowledge and practice. And that's the simulation which bridges the gap between the knowledge and practice. In today's complex of the healthcare industry, you all know that how that the practices and the healthcare practices are keep growing and growing. To meet those standards, it's very much necessary that how and what we learn, we have to translate into our actions. And therefore, this theme has been decided for this conference. This theme embodies our collective vision for the future of nursing education and clinical training. It signifies the journey from knowledge to competency and skills, from theory to practice, and from passive learning to active skills into your mastery. Simulation-based training is not the bridging the gap, but it also connects what we know and how we have to do. This event brings together a powerful mix of academicians here, experts, simulation experts, nurses, nursing educators, faculties from the nursing colleges, nursing students, MSc nursing students, and of course the global simulation experts from Spain, Canada, Thailand, and USA are among us. Do not miss any single session, because they are going to discuss with you all these things which they have the knowledge, which they are here to pass on to you. By fostering our collaboration between educators and practitioners, a simulation specialist, we are creating the holistic approach for overall learning, which helps you in your real practice. We are honored to have renowned experts from across the globe, and they will be with us for next 2 days. Many of you have experienced them during the pre-conference session, and I hope that you will enjoy these 2 days with them. We also have a lot of the new technologies in simulation. During the break times, you can enjoy and see into the exhibition area, and you will learn a lot of the simulation techniques. The of this 2 days conference will be like that in the morning today, you all learned with the expert what it is simulation, how you have to use the simulation. And then tomorrow you will learn how to implement those simulation standards which you learned today in your nursing curriculum and in your nursing education. I encourage all of you to make the most of every session and engage with the speakers, network with the peers, and immerse yourself with the incredible learning experience with the SiMCON. Thank you so much.
Thank you so much, Dr. Jaideep. Now, we have reached the time for the conference anthem, and this is where I would request you all to stand for the conference anthem.
SiMCON anthem करके music.
And while we have the anthem, let's use our left hand and put it on our right collar.
Of knowledge we ignite, harnessing our minds to shine the light. From theory to action, we pave the way, transforming brain power every day. From mind to hands we make it real, touch of hope, a will to heal. With every skill we gain we stand, transforming brain power into hand. Nurses united, strong and free, together we shape our destiny. We stand on the edge of simulation, building futures with dedication. Each pulse, each breath, alive to save. With every choice we grow more brave. Together we rise, transforming the land, from brain power to healing hands.
request you all to take your seats. And now, we're going to get ready for welcoming our chief guest and also receive the keynote address by her. And I want to first introduce our chief guest, Dr. Deepika Khaka. It is my privilege to introduce our distinguished speaker, Dr. Deepika Cecil Khaka, a luminary in nursing education. And nursing education and research. With over 3 decades of exemplary service at AIIMS Delhi and currently serving as nursing advisor, Dr. Khaka brings an extraordinary wealth of experience to our conference. Her academic excellence is reflected in her comprehensive educational background from Delhi University and in numerous prestigious recognitions, including fellowships at New York University and UCLA, a recipient of National Health Icon WHO Diamond Jubilee Year Award and the TNAI Nursing Excellence Award. She has made significant contributions to nursing education and research globally. Dr. Khaka's impact on the field is evidenced by her impressive portfolio of 71 indexed publications, supervision of 60 graduate students, and leadership in multiple international research projects. As an author, consultant and expert community member for prestigious organizations including the WHO and Clinton Foundation, she continues to shape the future of nursing education and practice. Please join me in welcoming Dr. Khaka. Come, Dr. Khaka.
Well, thank you, Joshua, for those kind words of introduction. Good morning to all of you, esteemed guests, colleagues from international world, my dear delegates. I bring greetings from the Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India. It brings me great pleasure and honor to be amongst you all today at this very important topic of simulation, transforming brain power to hand power. In the words of Confucius, I quote, "I hear and I forget, I see and I remember, I do and I understand." Now, this very beautifully reflects the essence of simulation-based learning. And it is an absolute pleasure and honor and privilege to be present amongst you all this SiMCON 2025. And it's always great to be part of the milestone that this is your first international simulation conference. We all know that nurses are the backbone of the healthcare delivery system, and nurses play a pivotal role in the quality of healthcare which is delivered. So it makes it imperative that the training we give to our student nurses should be in a wholesome manner, that when they graduate or they pass out, they are job ready with the necessary knowledge, skills, competency which are expected out of a young graduate who is passing out of any nursing institution. We all know our country is very populated. We have a huge burden of population which we have. So to combat that, we have more than 5,000 nursing institutions in which more than 3 lakh graduates are coming out per annum. Now we have to also understand that as educators, as academicians, as students, as policymakers, as people in the industry, we have to see to it that the quality of the graduates which are coming out of our nursing institutions is a great concern and of paramount importance. So as educators, as students, we have to see that the necessary skills, dexterity, precision which is expected out of our graduates should be there once they pass out. According to the WHO, 1 in every 8 nurse leaves her country of origin and goes and practices or works outside. Now, when we talk about quality, we don't just need quality for our nurses who are migrating to greener pastures. We also need quality for our domestic use, where nurses are coming and serving our own country. We all know that when a person accesses a healthcare, person's life, this is nothing more valuable or more precious than a human life. And in healthcare, we are dealing with human lives. So quality should be the norm. It is not optional. It is an ingrained norm that the quality of services we offer to anybody who's accessing our healthcare services should be of the best quality. The excellence should be there in delivery of our healthcare services. So in order to deliver quality services, there are some prerequisites like the quality of services. How we can improve is that there are many researches which support this, that the research consistently shows that simulation-based learning enhances clinical competence, critical thinking and decision making. Therefore, simulation ensures standardization in training, allowing every nurse to experience and master core competencies. I had an opportunity in one of our meetings to meet Tor Lardel. Lardel, we all know, is a big player in simulation, and they provide mannequins. And when I was talking to him, I told him that, is it possible to have a Robin Hood model? Do you know the story of Robin Hood? He used to get from the rich and he used to give to the poor. So I said that, see, our country is a big market, but if you do some cost, alignment and make it a little more pocket friendly for our country, that will be because that would really make a difference in the quality of education which we give, because it will be affordable. Otherwise, sometimes because of the cost implication, the nursing institutions are a little hesitant to have simulation-based learning. I would also like to emphasize this, that simulation does not only mean buying very expensive mannequins, high fidelity, medium or low. They are required, but I remember when I was a postgraduate student, I'm talking about the 90s, the last century. I remember I have done my specialization in psychiatry, and we were taught, like when we were told to counsel a patient, one of us used to become a mock patient, and then we would counsel the patient, and we'll get those necessary confidence, skill in doing it was simulation based learning basically. And so simulation means that we should be, the teacher should be innovative enough to know how best you can teach your students the necessary confidence, skill through simulation. Simulation-based learning is not just a technical expertise, it is also fosters teamwork, communication and leadership. And interdisciplinary simulations where nurses, doctors and allied healthcare professionals train together mirror the real world collaboration and enhance patient safety. The importance of developing a strong, adaptable, resilient healthcare workforce is very important. We know COVID has taught us many lessons. I remember I used to only see, lockdown and all that in Hollywood movies, Hollywood science fiction movies. And when COVID came, all of us started looking like astronauts going to a different planet. Do you remember I don't know whether you have seen or worked, the kind of PPE we were wearing? So this shows that we have to be prepared to face any pandemic. Like they say in the army, they say the soldiers, they always sleep with their boots on. So similarly, as healthcare professionals, we should be ready to combat any emergency, any pandemic, because as per the predictions, these are going to be an ongoing process now. So we should be all geared up and be resilient to take whatever comes our way. We all know that world over there is shortage of nurses, and simulation-based learning in is pivotal in addressing global nursing shortage by providing hands-on and engaging training that can enhance our students' retention, reduce burnout, and attract more professionals, more young people to this noble profession. A well-trained and a well-supported nursing workforce is critical in delivering high-quality healthcare worldwide. Now, when we invest in nursing faculty, we ensure the educators are equipped with the latest simulation methodologies and technologies, and a well-trained nursing faculty can inspire, empower the next generation of nursing professionals, fostering culture of continuous learning and excellence, and simulation can be one of the key components for professional development to pace with the advancements in healthcare. I have been an academician myself, and speaking from experience, I am saying that the teacher should be a role model herself of the excellence she expects from her students. Role model in professionalism, role model in ethical conduct, role model in discipline, role model in knowledge, and role model in the way she carries or he carries herself. Because the impact of a teacher lasts for eternity. So whoever are the faculty who are here, there is a lot of moral responsibility which we face as faculty, that what kind of students are we grooming? What kind of students are we shaping who are the future of tomorrow? Like I was an academician myself, and when my students come and tell me that we have published a meta-analysis or we have been presented in this conference, we got an award, I feel very happy and I feel very proud of them, because in their success I see my success. I also see that I have also in some way contributed to where my student is today. So as teachers, we have to see what legacy are we leaving behind with our students. So importance of collaboration is very important. Like you are here all gathered from all parts of the country, and people have also come from abroad. I welcome the international faculty who are here for this very important cause, that collaborate, learn from each other, learn from the success stories from each other, learn from the mistakes each other have made, and don't repeat those mistakes. So collaboration is the key. Collaborate with the industry leaders, healthcare institutions, policy makers, which are crucial in integrating the simulation-based learning into mainstream nursing education. And by advocating for policies that support simulation training, we drive a systemic change to elevate the standards of healthcare education in India and beyond. So incorporating simulation-based methodologies into nursing curriculum ensures that our healthcare professionals are prepared for challenges ahead. We know recently INC, Indian Nursing Council, has rolled out a competency-based curriculum in 2021, which emphasizes the use of simulation, so in order for skill acquisition of our nursing students. We push the curriculum reforms that recognizes the significance of simulation-based training and provide necessary infrastructure to support its implementation. I would like to congratulate Dr. Jaydeep Herbert and his team, and I commend the International Nursing Association of Clinical Simulation and Learning, North India GRIC, for spearheading this initiative and bringing together experts from all backgrounds all around the world. And this platform should be utilized to inspire new ideas, but also to shape the nursing future and the nursing education practice in our country. I am very sure the SiMCON 2025 is not just a conference. As I said, this is a milestone. This is the first of its kind. I hope that it will gain momentum and the movement towards excellence in nursing education. So commitment to ensure that our nurses are well equipped, our healthcare system is strengthened, and our patients receive the highest standards of care they are supposed to be receiving when they access our healthcare facilities. So let us together join hands, learn, collaborate, innovate, because the stronger we build our nursing workforce, the stronger our healthcare system becomes. I would like to end by a very famous quote of Nelson Mandela. I quote, "Education is the most powerful tool which can use to change the world," unquote. With this, I wish all the delegates, the faculty, the organizers, all the very best. And a conference is always considered successful when the impact is seen in practices. So whatever you learn today in your whatever fields you are working, try to imbibe, try to use simulation-based learning, be it in pre-service education or be it in in-service education. Try to imbibe it into practice. I wish you all the very best. Jai Hind.
Thank you so much, Dr. Deepika, for addressing the gathering. I would request you to be on stage. And now I'd request Captain Dr. Usha Banerjee, Group Nursing Director of Apollo Hospitals, to come on the stage and felicitate Dr. Deepika. Can we have a round of applause, please? Thank you, dear guests. I'd now ask you to take your respective seats. Indeed, when I was listening into Dr. Deepika's keynote address, definitely it gave us an idea of what this conference is all about. And I would request you all, like Dr. Deepika said, that this is a time that our brains have been churned. We've been given a perspective as to what to look forward to, what kind of teachings and what kind of workshops we're going to attend, what kind of slides we're going to see. So I would request you all to be attentive. I would request you all to listen in carefully, because very highly skilled experts and champions of their domain have come to address this wonderful gathering of SiMCON 2025. Now, it's time for the celebrations to go to the next level. It's time for a welcome dance, and I would now like to welcome the group to come on the stage and perform the welcome dance for everyone.
है लक्ष्मी तू, है शीतल तू, है अग्नि तू, तेरे पाँव में है तीनों लोक।
Now, moving on to introduce Captain Dr. Usha Banerjee. I present to you Captain Dr. Usha Banerjee, a distinguished leader whose exemplary career spans military nursing service and healthcare administration at India's premier institutions. From earning the gold medal at Armed Forces Medical College to her current position as Group Director of Nursing at Apollo Hospitals Group, she has consistently demonstrated exceptional leadership. She is a recipient of the President of India's medal and numerous other accolades. Dr. Banerjee has authored 63 research articles and she is a sought-after speaker at international forums. Her expertise in hospital administration and commitment to nursing excellence continues to influence healthcare standards across India. Can we give a round of applause for our guests?
A very warm good morning to each one of you present here. So before I start, I would like to request our speakers to keep their sessions within 20 minutes of time to ensure that it goes in a smooth flow and timely the discussion gets over. It is also my honor to welcome each and everyone present here to this insightful session. As we proceed with this, the rapid evolving landscape of healthcare, new challenges emerge ranging from global pandemics and patient safety concerns to technological advancement and workforce training. The ability to adapt, refine, and also to respond our clinical skills has never been more critical. This is where simulation-based training plays a transformative role. Today, to deliver deeper into this topic, I am delighted to welcome Ms. Thankam with her expertise and experience in this field, addressing emerging healthcare challenges prepared through simulation. All over to you, ma'am.
Thank you, my dear. Thank you. Can I have my slides, please? Thank you. Good morning, everyone. Didn't hear the energy so far, so let's get some energy up there. Good morning. Good morning. How's the Josh? That doesn't sound like hi. How's the Josh? Okay, that sounds better. So once again, thank you very much to Dr. Jaydeep Herbert and the simulation that connects us. And I am young in simulation when compared to Dr. Miriam. Otherwise, I am probably the most senior in nursing. So in simulation, I'm just 12 years old. Isn't it good? From 2012. However, I'm proud that I kept at it, I learned about it, and I practiced. And when I learned about simulation, I realized I had been using the principles of simulation all my life. Because there's only one thing that I always wanted, that when I train, when I teach someone, the learner should get it. And the learner should do it. I think when I was introduced to simulation, when I got certified, I said, aha, without knowing, I was practicing that. I can talk like this without any interruption for a long time to come. Can I have a slide change here? Yes. Thank you. But I need to do justice to the topic. So this is the topic that I have been given. Addressing healthcare challenges prepared through simulation. I'm sure that, thank you Dr. Deepika for setting the context that, you have addressed almost all the aspects of what I'm going to talk. So I hope I should do like this, right? Technology can be trusted to trouble you at the right moment. Oh, okay. Let me check. Okay. So long time ago, long time ago, when most of you were not born, when I was a nursing student, I was told, child, I'm 17 years old. Child, you have to do night shift. I said, what do you mean I will not sleep in the night? She said, yes, because your patients, they don't go home, they stay in the hospital. I cried. I said, I have always slept in the night, so how can I do night? I cried and I worked through night shift. How did I work through night shift? Because my seniors helped me to cope. But I was put into that scenario, real life scenario. I learnt by doing. So I call it that's a night shift crisis, you know. This is actually a series. I took the photo from there. But that's the crisis I faced. And I never liked night shift, but I did a lot of night shifts because patients are always there. So I realized today that the dilemma that many new nurses go through, the kind of experience that they are going to face in the real world, we cannot wait for them to happen to them once they enter the real world. That's where the simulation comes in, that you can give that close to real life experiences in a very safe environment. That is the power of simulation. So I'm here to discuss the challenges that we are facing. So I kind of put them into certain buckets, and I think Dr. Deepika already mentioned about that. We have an increasing patient acuity, and we know that more patients are critically ill, and after COVID, younger ones are getting very critically ill. So we have that burden, and we have older and sicker population because we are living longer. Is it a good thing, bad thing? I don't know. I'm happy. I'm 65. I'm still standing. Good. So we have rise of young patients who have severe illness. I already mentioned. Ma'am mentioned about pandemics, which already we crossed one, and there will be more to come. And simulation definitely is a huge tool, a beneficial tool to train large number of people for crisis management. And I know in US, you do big disaster management with a whole lot of mannequins on the road, and I have seen some of those clips. So that is the high level of simulation, and we also heard from Dr. Deepika that sometimes it is not necessary that you need mannequins. So those who attended the pre-conference the other day, Dr. Miriam took us through virtual simulation. And when I attended that, again I became a learner, and I promised her that I am going to get into Zoom simulation very quickly. And that's my promise, because I always tell myself that when you go somewhere, make sure that you take something with you to action it. So that's my request to all of you. So all of you needs to have some introduction. So may I know how many students are here? Can you please raise your hands? Okay, and how many practicing nurses? There are very few hands, and all this population is sitting in the hospital. So this kind of, tells us maybe there is a misunderstanding that simulation is restricted to academics. Believe me, ladies and gentlemen, the hospitals are where the result of simulation is going to happen. So it is important that more practicing nurses, more practicing leaders need to be here apart from the academician students. And I'm sure we have a lot of academicians here. That's where the story starts. So I think it is heartening to see all of you here on this first, international simulations. Because I believe that if we continue to do the things the same way as we have done before, we should not expect any other result. It is the principle of life, correct? If I take the road to Noida, every day I'll go to only Noida. I can't expect that I'll come to Delhi. Similarly, it is important that we also have to acknowledge our own challenges with nurses themselves. Already Dr. Deepika mentioned That's a good number to know. 1 in 8 nurses from India, they go abroad. And we have a huge population. We are the largest democracy in the world, and we have many colleges, lot of nurses, but still we are short of nurses. 4 lakh nurses we are short. High attrition. And I am very sure that, all the services people sitting here, Mr. Vinod from Vedanta, Usha from Apollo, they will tell me that what are their pain areas. And they do have a major challenge of upskilling nurses, the young nurses who come into the services. It is very difficult to onboard them. So what happens? You have younger in charges who are in charge of young nurses. So what happens? We don't have experience, and they are trying to train or coach the younger nurses. So there is always an experience gap. How do you give all that experience to someone? Especially if the new nurse who is coming has got hardly any experience, not exposed to situations. Simulation is the answer where you can expose them to such situations even before they hit the war ground. I call it war ground when they reach the hospital. So non-standardization of the curriculum, I would say it is not non-standardization, it is the non-standardized way the curriculum is being executed. We have an excellent curriculum, but how are we executing? If it was standardized, so when Usha or Vinod or any of the nurse leaders sitting here, when they interview the nurses, they should get similar outcomes, but we don't get them. So obviously there is a need to do that, that's a challenge. So obviously all of this is happening because lack of clinical exposure, and they do not have experiential learning. My request to all the academicians sitting here is, please be creative to give an experience to your students, so that when they actually come to the hospital, they have the right attitude of learning. They have the right attitude of caring. That's where it starts. We all know about the KSA, the knowledge, the skills and the attitude. You can give knowledge, you can give skills, but how do you build attitude? And I think simulation is one way of building that attitude. You put them into scenarios, you discuss about behaviors, critical thinking. It has got a whole lot of advantage to do that, but I should restrict, also think about my timer. Who will give me timer? 5 minutes before? You will let me know? Ting tong, otherwise I can go on forever. So the answer is, traditional classroom learning is no longer enough. All of you agree? Yes? My son, who is an engineer, he did engineering 4 years. So when he came out of the engineering, so I said, how was the college? So he said, in the entire 4 years, I only loved 1 lecture. I said, that's it. I said, why? Because the experience was too good. The faculty had lot of things to share. They had lot of experience to share. They had stories to share. The rest, he said, I could read the slide. Why they should read from the slide? The faculty will come with lot of slides, put everything, and then you start reading. Then he said, I can read. Why is he reading it to me? I sent him to a coaching class. He dropped. I lost 1 lakh. Again, same thing. He said he will put something on the slide and he will say, please copy it from the board. So I couldn't do anything. That is the current generation. So what is required is to give an experience to the learners. It doesn't matter whether they are in the academic institutions or where they are in the hospital. Whether we are doing induction, whether we are doing onboarding, call all the right names. But if we don't execute them in an experiential manner, then the results are going to be suboptimal and we can continue to complain. But I am very optimistic. Today we are having a conference, international conference on simulation, with international faculty sitting here, with representation from INACSL, and the conference is from INACSL, thanks to the rig of North India. Thanks, Jaideep, for that. That is big, good story. So let's clap for that great hope. I hope you are not just clapping because I asked you to clap. I hope you are really feeling good about it, that you came here. Yes? You can go and tell somebody else you missed, you should have been there. Yes? Will you promise me to do that? Yes. Go and tell others. My God, what you missed. Yeah? Okay. So obviously nurses need hands-on experience in real life scenarios. We cannot afford. Now in corporate world, there is another challenge. Patients don't like young nurses and students to come and touch and practice and work on them. When I started getting into simulation, I met one of the doctors. We were talking about simulation. So doctors told me, because of them I cannot tell that in Hindi, you will not understand. So the doctor said, Madam, why we need simulation? We see hundreds of patients every day. So we learn. I said, in that hundreds, one or two may just die because somebody made a wrong step or a wrong intervention. He just looked at me. We are a big populous country. I said, thank you for your time. I think we shouldn't be talking simulation here, because if somebody is okay with one or two lives being lost because we are in the process of learning. My question to each one of you, would you like that one patient be your father, your mother, your brother, your sister? Would you like that? No. So we have a responsibility not to harm any patient. And simulation is a great way of making mistake and learning, but you have not harmed anyone. So students who are sitting here, who are going to be faculty tomorrow, you can practice. It is not rocket science. Help is out there. There are many people who can guide you, train you, handhold you to learn the technique of simulation. It is just that you have to have the right intent inside. The passion that you show here has to come into action. That's very important. So simulation can bridge the gap between theory and practice. That much though all of you know for sure. That's a repetition the whole day, and on Saturdays, Monday and Tuesday we are going to talk about brain power to hand power. So it's very important. Patient will not ask you, what's your degree? From where did you study? Are you a gold medalist or a silver medalist or bronze medalist? The patient only wants to be healed without any complication and go home in the time that we have given. And complications should not set in. We should not harm someone by mistake. So obviously we want to prevent all the preventable harm. I think this quote has been already shared by Dr. Deepika. For any simulation, this is a very famous quote that will come in. You do and you will remember. So patient will always remember how you made him or her feel. So that means how you talk to the patient, how you handle the patient, how did you do your procedure. Skills are very important, yes, critical. But you can have the best skills in the world and you can be totally ignorant and make a wrong decision with the patient when something is happening to the patient. So it is very important, and medicine, nursing is ever growing, and the diagnosis is never ending. The medication list is never ending. You can't learn everything. It's not possible. But wherever you are working, we are responsible to educate ourselves and be a safe nurse to our patient. So what is simulation-based learning? And I am very sure all of you know a training approach where nurses practice in a controlled but realistic environment. That means you create an environment as close to the real world as possible before handling actual patients. Do you think that will increase the confidence of the nurses? Yes? If you get a chance to be in a situation, very simple, You are in a very controlled patient environment, and you go in there and you find patient is sweating, and he's cold and he's telling, I'm feeling very hungry. But you have to decide what to do for the patient, right? And somebody is watching what kind of decision you are doing, what are you intervening, and then you get a chance to reflect. The simulation can tell you that you took the wrong thing and he just became unconscious. He went into hypoglycemic coma. Then you have to do the next step. But maybe the faculty will say, okay, we stop here and let's talk. What happened here? Why did the patient become unconscious? You get a moment to talk about it. But in real world, if you taken that step and patient became unconscious, somebody will throw you out on the side. The RRT team will come and take over, and they will do everything, and after that you will be called to somebody's office to say, how come you did not recognize, you don't know even hypoglycemia? What did you learn in your college? Which college did you study? All this time, then again the student or the young nurse will lose confidence. So I don't know anything. I will harm patient every day. So 2-3 results. One result, I don't want to be in this hospital, I'll go to the neighbor hospital. Has not learned anything, go to the neighbor hospital, again fail to recognize hypoglycemia. Then harm one more patient. So this is how it can happen, and we can create a very unsafe environment. Believe me, ladies and gentlemen, if WHO says 1 in 20 patients get harmed, and if we put that hoarding outside the hospitals, would you like to enter that hospital? This is what WHO says, 1 in 20 patients can be harmed, so please bear with us. But pay the bill and take a risk. Will you do that? Obviously you won't do that. So if you make a mistake and do not correct it, this is a real mistake. This again Confucius, centuries ago. And simulation is one way of allowing you to do the mistake, look at it, reflect on it, and then learn that what could have prevented this from happening. And believe me, all of us, we know that the mistakes that we made in our life, we never forget. Anybody? Anybody forgot any mistake that you made in your professional career? I still remember where I gave 0.5 milligram of digoxin to my patient instead of 0.25. And I know how much of, crying and everything. Nothing happened to my patient, but I was all over the place saying that I made a mistake. Then the doctor has to really counsel and say, your patient is okay. You only came and told, you yourself reported, that's something good. So I'm a very big proponent of medication safety, where I say your self-check. 2-3 times that you self-check your medication is very, very critical. And it's not time consuming if you do it the right way. This can be simulated easily in a safe environment, not with the patient. So all the safety aspects where your rigor in behaviors, safe practices is very critical. If those practices are not practiced, then it will not come to you. Anything that you learned, you may be able to remember, but you may not be able to do. So in an interview, when I get a student who has done med-surg and cardiothoracic specialty, so I will definitely ask, oh, you know about coronary circulation? Oh yes ma'am, very nicely she will tell me all the coronary, how the MI happens and everything. I said, okay, very good, fantastic. So I'll say, okay, you are posted in ER, a patient walks in, he has driven himself and he comes in and says, I just came in to check because my left arm is aching. And I don't know, is it hot? I'm feeling a bit sweaty. I said, what will you do? What do you think? What's happening to the patient? And she will be failing to say that this patient could be experiencing a cardiac event. This is what I am going to do. So most of them will end up saying, I will call the doctor. I said, oh wow, thank you very much. Anybody can call the doctor, even a front office can call a doctor, right? But as nurses, we have to do initially something to the patient. How do you learn? What are those initial things that you should do? Suppose this was 5 minutes, so I should go. All right. Suppose this was done for under simulation. You can simulate all kinds of high acuity codes, sepsis, I mean, this is only few, examples. You can have complex decision making through simulation. You can give a scenario where they can think and they can make the decisions. And communicating under stress, it's very, very difficult for nurses to even have a normal communication. Even when a patient gets admitted, how to give orientation to a patient, it's a normal communication, even that's a challenge. That itself is getting trained in corporate hospitals. But it's so easy to dovetail all these during the years of, learning in the college. That's why it's very important. The academicians and the service people need to discuss and say, what are those scenarios that we can build in first year, second year, third year, fourth year? Not only clinical, even normal scenarios. We struggle with nurses who will not communicate, forget about the difficult conversation, even normal conversations. I'm sure when COVID came, a lot of people did simulation because you train people how to wear the PPE completely, right? So it continues. It was so surprising that suddenly we became very aware of all the infection control practices which was anyway existing even before. There was nothing, no new discovery of isolation during COVID. It is just that suddenly everyone realized, oh, I have to do my hand hygiene. Even the doctor started doing hand hygiene. Fear of my life, not somebody else's life, fear of my life. But that was an eye-opener for all of us. Team coordination and leadership. When I got trained, this is what they emphasized on. How do you come together as a multidisciplinary team and manage something? And this is an everyday scenario in a hospital. Unfortunately, in India, we have medical colleges, nursing colleges existing together with a simulation lab, but they will not come together to create team multidisciplinary team simulations, and it is very, very important. If we can do that, it can give us huge results, because we do have many other problems related to team coordination and collaboration. So since the bell is ringing, and I think I kind of touched upon all this, better picture of the learner, academicians will come to know your students far better when you put them into simulation. And the trainers who are in the hospitals, when you put them into simulation, you will understand your nurses better. You can give effective feedback and evaluation. The impact, of course, something is going wrong, it's going up and down. Okay. So all these are evidences, and there are hundreds of it if you look at it in the web. What are the impact and outcomes that you can get? So what are the barriers that we can have? I would start from down. In India, resistance to change is the problem. At every level, it doesn't matter, it is just the management or the faculty or the academicians or the trainers. We all have this anthem, in my time, in our time. So I am the one who should be talking like that because I am 65, but I have stopped talking about that. I just reverse and say I am till 16, I am still learning. So that resistance to change also could be from the management, because they are thinking, what's the ROI? So for the leaders and academicians, it's important to show the evidence. Do pilots, show them the cost effectiveness. And for that, you need to do the faculty training. That's important, to find the right set of people to train the faculty, because in the last 12 years, I have met a lot of simulation so-called experts, and when you start talking to them, they are thinking because they did some BLS, so that is simulation. That's the beginning and end of it. That's not the beginning and end of it. And that field is growing. Every day new things are coming up in simulation. So we could be far behind all of you experts in the western part of the world, and even you're from Thailand, right? Yeah, I know that Thailand services are far ahead when it comes to, I have met some simulation people from Thailand and Taiwan when I visited Malaysia. So I know that you people use that technology even better than us. But we are not far behind, are we? So we have started on a good note. So, and I hope at least all of you have decided that we are going to take the challenge. And yes, we definitely need low-cost simulation models and platforms. And thank you, Miriam, for showing that it is possible. And now it is up to us to take this forward. And I am definitely going to work on that. So call to action, ladies and gentlemen, simulation integrated nursing education across India. When I say education is not limited to colleges and schools, education is happening within the healthcare delivery systems also, because no doctor, no nurse can ever say that I have finished all my studies. You just can't, because you just have to continue to do that. So what can you do when it comes to simulation? Advocate for simulation in your institution. Participate in the right training programs. I would always say, right, it's very important to know, and then share the success stories and drive change. And here, transform fear into action. I like that, because young nurses are afraid to touch the patient. Let's take that fear out of them. So you can answer this question. In your experience, anything happened where you wished, oh my God, I wish I had this before? Yes, I had those moments. But I was lucky to have well-experienced nurses just beside me to guide and mentor me. But today, that is not the case. You may not have the luck to have such senior people around you to guide and teach you. So maybe, I hope that I have got your attention to agree that we do have challenges, and simulation is definitely one of the solid solutions that we have in our hands. Are we ready? Yes. Okay. So thank you very much. The second bell did not come. I hope I am on time. Yeah, I am on time. Thank you very much. And maybe if there are questions after the Captain Dr. Usha Banerjee finishes, maybe we can take questions. Thank you.
Thank you, ma'am, for your engaging session. Now, moving ahead, the floor is open for discussion.
Let her finish and then we can.
Okay, now let's keep this momentum going. So, as ma'am already mentioned, that healthcare itself plays a very crucial role, and the patient's experience remains at the heart of everything that we do. However, understanding the true challenges that the patient faces physically, emotionally, or even psychologically requires more than just clinical knowledge. It demands empathy, perspective, and hands-on experience that goes beyond any textbooks. To explore this topic, I am honored to introduce Captain Dr. Usha Banerjee, who will provide deeper insights into it.
Namaste, good morning. At the outset, I feel very honored to be here, and I thank Dr. Jaideep for giving me this privilege. To all our international speakers, a heartfelt welcome to our beautiful country. India truly brands itself as Incredible India. And over the last 2 decades, our country has solidified its status as a geopolitical nation. And we feel proud as Indians that one of the industries that has contributed to this meteoric growth story of our country is healthcare. And each of us feel extremely delighted and proud that we have arrived here today to be placed prominently amongst the world's map as a global healthcare destination. And as India inches itself to become one of the largest economies of the world and celebrate its 100 years of freedom, I'm sure each of you seated here as youngsters will feel more proud when the tricolor will fly high in these blue skies, and we will be proud to be an Indian citizen. Yes? On that note, though we have come so far amidst this cacophony of medical jargon, evidence-based practices, clinical trials where we are able to provide care with robotic precision and mathematical accuracy, and we do some pioneering, innovative, groundbreaking, first of its kind clinical work in our country, we must understand, each one of us seated here, whether you're a student or you're a practicing nurse, that it is so very important for us to hear the patient's voice. It is a consumer-driven industry, and we are in the vortex of this consumerism. Yes? And for many of us seated here, we represent the private corporate healthcare ecosystem where every single patient pays for our salary. And they pay not just for clinical outcomes, they pay for experience, and they pay for value for money. And I'm so glad, Dr. Jaideep, that you have given me a topic which is about patient experience. We all speak about simulation enhancing education, but there's so much that simulation can offer in terms of enhancing the patient's experience, and I'm here to talk about that. And I'm a true believer that if we invest in leveraging technology and we invest and harness the power and potential of simulation, we are going to have a seismic shift. We can break traditional barriers and we can actually leapfrog into the future, saying we have arrived as a country which speaks about digital India and healthcare for all. On that note, before I really get into the shoes of the patient, I must share a little secret here. When the organizers called Ms. Tangam to deliver her address first, she looked at me and she said, "Oh, aren't you going to be the first speaker?" And I said, "Yes, I thought I'm going to be the first speaker." So ladies and gentlemen, as always, Tangam is first. And she said, and unfortunately, she said everything that I wanted to speak. So I don't know, it's a boon or a bane. Maybe I don't repeat what she said and I skip the slides and I save some time. And so here I am. We all know, as healthcare leaders, unfortunately, there are not many seated here from the leadership position. Many of them are from academics, but I have my colleague and my dear friend Vinod seated here, and I don't see many others. We wake up every single day to the challenge of attrition. We wake up every single day to potential to errors. And we, as administrators, unfortunately, though we boast of a great curriculum in our country, face the challenges of actually going back to basics and teaching our nurses every single thing from starting an IV cannulation to the big picture that we speak about. So I feel the potential to harness simulation is what we need to talk about today. So walking in the shoes of our patients and addressing their challenges through simulation is not merely a conceptual exercise. It's an immersive recalibration of perspective, compelling healthcare professionals to experience the patient's vulnerabilities, anxieties, and the systemic failures which our patients navigate through every single day. So what do patients experience while they are at the hospital? A range of emotions, a range of interactions, and physical experiences during these healthcare encounters. Let me talk about some of the common challenges that our patients face that can actually negatively affect their experience. I realize this every day. In my KRA and in my PMS, patient satisfaction scores a huge weightage. And I think it is very important for teachers who have students aspire to work in the best hospitals in the country, and even if they don't, to be taught patient experience. And what do patients actually go through? Today, achieving true patient-centered healthcare is fraught with complex systemic, operational, and humanistic challenges. Honestly, you heard Tangam say that even basic communication between a patient and a nurse is challenging. And look at the plethora of encounters that the nurses have to make in order to address these communication challenges. And we are so fragmented in our healthcare delivery. One of the biggest problems is communication. And I think simulation plays a big role here when we talk about how people can communicate, not just as an individual, but as teams to the patient. This proliferation of ambiguous directives, these medical vernacular that exists today, and this discordant information streams, they actually precipitate a huge amount of challenge for our patients, and they actually erode trust, treatment adherence, and patient engagement. Today we know when a patient is admitted in a hospital, he does not get admitted under one consultant. There are multiple doctors that look after the patient. It is so important for us to reconcile the patient's medication, treatment plan, the prognosis, and the future directives by working as a team. And this is one of the biggest challenges that patients face, and I'm sure we can address this through simulation. Inadequate pain management. I don't know how many of us learned actually to poke needles or put in Ryle's tubes and be catheterized to experience the pain that our patients might undergo while being subjected to simple procedures. Simulation can do that. It can actually mimic those real life scenarios for us to learn the quantum of pain that a patient might experience. The fragmented care and lack of coordination. We see this every single day, and I think many of my times I'll go through my CSAT scores and the patients complain that there was lack of coordination. Somebody said something, somebody understood something, and ultimately something else was delivered. We don't prepare our students to understand how important it is to ensure that care does not remain fragmented. Emotional and psychological distress. I notice this every single day. Invariably, whatever emotional distress patients undergo, while we encounter them, we are insensitive. We really do not have empathy towards that particular patient's emotional distress. And I think simulation plays an important role, especially when patients are diagnosed with diseases that are debilitating, life-threatening, and patients go through an array of emotions, which only simulation can create and emulate and teach our nurses to experience that particular anxiety in that moment, which can be different for different patients. Financial barriers and lack of transparency. I don't know how often do we actually teach our nurses to understand how important it is to deliver the billing and the whole aspect of being in the hospital, because you are the center point of care. Everything that happens around the patient has to be addressed by the nurse. And ladies and gentlemen, in our country, where we understand that there is huge out-of-pocket expenditure by our patients, sometimes even pushing them to the brink of poverty, we must understand that this is a sensitive area of patient experience and must be learned through real-time scenarios. How do we address those conversations? How do we prepare patients to understand what would their potential billing and financial aspects be, and how to be prepared for that particular situation. Long waiting times. I think this is a constant encounter that we see in our patients' life while they are in the hospital, whether it is for diagnostics or it is waiting for treatment or waiting for a doctor. And a lot of this can be taught through simulation in order to address these challenges that our patients encounter. And I'll come to that when we talk about solutions. All of us are heavily rushed, from the doctors to the nurses to the caregivers to the allied services that provide care. Nobody has time for the patients. And these poor staff interactions are a constant complaint that we receive from our patients, and this can be very well addressed by looking at simulators and solutions that can actually prevent bottlenecks while the patient is in the hospital. And inadequate follow-up care. Every time when there is a discharge, the nurses are expected, the doctors are expected to actually work as a team to provide discharge instructions. And many a times, this doesn't happen. And if it happens, it is inadequate, and thereby patients not adhering to follow-up, to regimens that have been provided, and care at home. Cultural sensitivity and language barriers. I noticed that many nurses whom I hire, I stand testament and I'm loud and clear and candid about this, do not have language proficiency and communication skills. We teach communication. And today you house patients from different countries who have different needs, cultural, religious, and many other needs while they are in the hospital, which is not taught to our nurses and to doctors to be sensitive to such needs. And I'm sure simulation offers a lot of such programs which can be taught right from the time they are in the schools and colleges of nursing. Though we have moved a lot, we've actually leapfrogged into a digital country, but I think it's important for us to calibrate our speed and accelerate our pace in order to harness technology to take away non-value add jobs and ensure that our patients also have access to a lot of simulation so that a lot of work can be done much prior to patients being admitted to hospitals, and that will enable their experience thereafter. And one of the most important challenges in patient experience is limited accessibility and patient-centered services. When a patient lands at the door of the hospital, they are totally unaware of where to go, what to seek, how to seek, and who will address their issues. And I think simulation has got good to offer in that space too. So what's our way forward? We need to have an adaptive healthcare excellence model. Meeting these evolving demands requires each and every caregiver to come together, to be flexible, to be technologically adept, and deeply committed to patient satisfaction and quality of outcomes. So it's not just clinical outcomes and superior enhanced clinical stuff that we talk about, or quality, and today we speak a lot about patient safety, but it's equally important for us right from the day one of our induction into a nursing or a medical program to talk about patient experience. And we need to really master this. In this unforgiving world of healthcare, you know today there is growing litigation, media outcry, and so much more that we face as an organization, even when experiences are not delivered. Clinical outcomes are given. It is patient experience and patient satisfaction that is going to enable us to stay in business, be viable, either thrive or perish. So we all heard about the transformative impact of simulation. We heard Dr. Deepika Khaka talk about it. We had Ms. Tangam reiterate on that. And we all understand that today traditional education does not prepare our nurses to be adept in handling real life scenario. And unfortunately, let me be open here that we hire a lot of nurses from various institutions and they've probably never even seen a clinical setup. Unfortunately, forget about simulation. So where are we today? Into the transformative impact, because it's already said, I think it's important for us to harness high fidelity simulation to elevate care, caregivers, clinical proficiency, communication, and empathetic patient engagement. So, Ms. Tangam spoke about real-time, realistic emergency scenarios. Today, probably we've done a lot of work around using simulators for addressing BLS and code blue situations. But then you can mimic a lot of emergent situations in the ER scenario. You can do a triaging and ensure that patients' conditions are addressed as a team in the ER. Improving communication skills using VR simulators. I don't know how many of you actually want the VR goggles to understand how these simulators can actually run you through patient experiences. You can actually communicate and, like Tangam said, pause, you're doing it wrong, do it this way. Reducing waiting times. You can actually simulate the patient's flow in the entire hospital and you can allocate resources in order to optimize various scheduling processes. So if you use simulators, you can really gain a lot in this space. Pain management. I think today we have fantastic simulators that can actually mimic pain and that can actually tell you whether the patient's pain is being adequately addressed or not. So I think it's very important for us to ensure that this becomes an integral part of our education. We can practice hospital-acquired infections prevention. I think the knowledge on HAIs is very, very poor in today's scenario. And like Tangam said, it existed for years, right from the foundation years of Florence Nightingale. But how do we even protect those lines? How do we ensure there is compliance during insertion, maintenance? It's so important for us to use simulated environments to teach nurses to handle many of the infection-related issues. Reducing errors. I think there's a beautiful book that has come out from our association called Annie, which talks about learning from errors. Every single day we wake up to an error because nurses do not know the consequence of an error. And that needs to be taught in order to ensure experience. Maternal and neonatal care. You can actually mimic various forms of complications during delivery to teach nurses and doctors how to deliver in those situations. And of course, improving teamwork. Every debrief that you have post a simulation exercise will tell you what went wrong. You can even provide psychological support to patients in different scenarios. You can talk about hospital staff can actually use simulation to practice explaining pricing and payment options to patients much before the patients are admitted. And of course, you can use staff interactions and empathy. Cultural sensitivity, as I said, you can have different countries, languages, etc., where can be simulated and nurses and doctors and others can use these as scenarios to provide care to people from different backgrounds. And of course, for patient and family interactions. So, I think you heard Dr. Deepika say that where she's a psychiatric nurse and they had to role model each other in order to understand psychological situations. But today, this can be used in psychiatric situations where you can actually mimic various psychological disorders and psychiatric disorders like anxiety, depression, suicidal ideation, etc. And nurses can learn how to anticipate, how to handle, and how to escalate situations that they encounter. So, now let me talk about how patients can use simulators in order to make their own experience better. Pre-surgical and procedure simulations. We know that patients are often anxious and doctors do not have enough time to explain the whole procedure. And many patients rely on internet and YouTube to understand what the procedure is all about. I think we can have huge amount of investment in terms of enhancing patients' experience and alleviating fear, where patients can use simulators to understand the pre-op steps. Post-surgical mobility, just 30 seconds more. Post-surgical recovery and mobility training is so useful when patients undergo various procedures. Anxiety and phobia exposure, we even see this in movies, these are real today. Patients can actually undergo exposure therapy in a controlled environment. Pregnancy and childbirth simulators, where patients can understand various aspects of childbirth and what kind of complications to anticipate and how can they become an enabler during those situations. For diabetics, it's so important that we give them simulators rather than just teach first time for them to inject on themselves. Virtual tours of hospitals and wayfinding simulators can be there even before you clock an admission for a patient in the hospital. Pain management and distraction during procedures, very useful, especially in pediatrics, where patients can experience immense pain and can be distracted using simulators. Personal rehabilitation programs. You can customize rehab programs, especially for patients with stroke or any debilitating illness. Pre-procedure anxiety reduction with VR. A patient who's scheduled for a different diagnostic procedure or for a therapeutic procedure can get comfortable with the real-time simulator. It's like actually getting into that situation. In pediatric and elderly care, simulators can be used to teach the entire family on what to expect beyond the hospital. Informed consents. We just make patients sign consents without actually, they do not even know what they are up to, what are the complications, what are things to be expected in the operating room, etc. I think simulators come handy in such situations. Challenges of implementation, Ms. Tangam has already said that. Cost, scalability, limited technological infrastructure, resistance, and sustenance, etc. So what's the future direction? I think today we've arrived at a stage where these simulators will become a mandate for us to use in a hospital in order to enhance patient experience. And I'm glad today the medical and nursing education has mandated simulation, but it should go beyond just clinical skills and competencies. It must address patient experience. So for me, walking in the shoes of the patient means that patients can also use simulators to engage in replication of medical procedures, thereby enhancing their confidence and comprehension of therapeutic protocols. So this convergence of medical simulation will profoundly amplify patient experience by refining clinical acumen, clinical skills, clinical intuition, and sharpening the razor's edge of decision making and precision, and will allow nurses, doctors, and other healthcare providers to work as great teams in order to improve the so-called patient experience, which becomes a mandate in a hospital setting today. So let's step into the patient's world. Let us elevate care through immersive simulation, and we cultivate profound empathy and fortify our patients' safety standards along with the experience. Thank you.
Thank you, ma'am, for your insights. Now the floor is open for discussion.
Thank you, Dr. Usha, for that. I was smiling to myself when I was listening to her. You know why? I thought we are writing a manual. I wrote the introductory chapter and she gave the index. And I'm hoping in the coming hours today and tomorrow, we will be deep diving into various aspects of simulation from different experts. Are we all ready for that? Thank you. Thank you for complimenting that. Okay. I had to tell that because I was smiling to myself about the manual. So I had to share that. Yeah? You can ask if anybody has any questions or anything to comment? You get this chance only once, huh? Nobody is behind the mic also.
Good morning, ma'am. I'm here.
Oh,
Here, first row.
Oh, okay.
Yeah.
Very first row.
Maybe I sound a little different today. Myself, Dr. Valyamal Shanmugam from Niman's College of Nursing. I work there as a lecturer, and I have my team here, colleagues around me here. And this question, actually both the session, as you rightly mentioned, it was an introductory and an index thing. And it was very impressive. I have few things because we are into that nearly a 1 year, I think I am into this after being trained in our National Simulation Resource Center. It's been 1 year I have been trained and I'm implementing in my college. And I have faced so many challenges. The first and foremost thing is that I know our syllabus recommends for BSc Nursing simulations required a skill lab, but the intake is around 82 plus, and as you rightly mentioned, there are very few of us being trained and knowing things about simulation. Practically, when we are involved in giving simulation labs, when we take the students for the skills, I found it is a lot of time consuming, and I have made some creative things like making them in batches, and then it's apart from our requirement timing, it's extending. So I just would like to know practically how to go about it, because even I am striving since 1 year to do, I find all trials I have done, and I'm not able to cover completely all the students, and because the works, you understand, like it's like a different classes we have, the hours which is been stipulated hours are not enough actually, and the students to get them onto the track itself takes time when we start doing simulation. And it's very good and nice to know that so many things are there to be stimulated to teach the students actually. But to be in one line, we are finding, myself with the experience with last 1 year, finding it very difficult to fit them into the stipulated hours, because there is a large number of students and very few of us are being trained in that. And there are the subject is so vast, and they have so many subjects to learn in semester wise, and so many practical issues are regarding this. But I could see very nice changes in the students after getting exposed to a simulation session, and when they get into the practical area, I have seen very nicely that was a paper which I presented in the pre-conference, which I could see carrying behavior changes and could see them. Most of the students were like, they were able to do analysis, like patient, how to go into the patient's shoes and get into the real context and all those things. So I just want to know how to make it more practical in our education
So
sector.
I think, thank you, Doctor. I know that she's standing restlessly. So I understand your dilemma completely. I think one of the solution was given by Dr. Miriam. I will just summarize into 2-3 points, because I do consult for a training institute where we are struggling with 120 students per batch, so it's not so easy. So I'm also thinking creatively with them. I don't have a complete answer. But I think we need to be creative to say, if I put one-time effort, how can I multiply the results? So if you can convert one-time effort into a video, then you can flip the classroom, because that's another way of engaging the students, that they do their own stuff and they come back and then discuss. So Dr. Miriam, what she told is definitely a one-time effort, and you can multiply this as many times as possible. And using the students themselves for peer-to-peer teaching and learning and observation. It needs a lot of planning, structure. Once it is done, you will find that you will be able to get more students engaged in the simulation. And we would like to ask our experts sitting there if you can give a bit of your experience to her question.
Can I take 1 minute? Tangam and Usha. Great listening to Usha. I missed Tangam. You as joined late. I think probably we'll answer the question as an academician next panel discussion, probably. But I quite agree with you as an academician that it is very difficult when you have got a sort of a structured program to go through. Semester system is there, you have to finish so many assignments, so many practicals. But it is how we try as teachers. We miss somewhere on the way, that I remember 56 years back as a young clinical instructor, I remember how I did, admission of the patient. We had simulators that time because College of Nursing was the first in country, and so we had the simulators, but that were all low fidelity simulators. But we used our own creativity to see, but we covered in 45 minutes or 50 minutes, whichever hour was there. So we'll discuss about it probably later, but my concern was about Dr. Usha's presentation, not concern, a comment. So many things are there which we can do as nurses. So many things are there which can be taught to them when they are working. Because when they come out from the classroom or when they come out from their training, probably they go through stipulated kind of a structural curriculum. So they may not have so much of time as such to go into critical analysis of each procedure, though the teachers are expected to talk about the critical analysis, do the critical analysis of each procedure, and talk about all behavioral, scientific methods, whichever are applied, which we did as young teachers, and now also we use the same. My concern is only that how much you can balance in the private sector, I'm asking. Government, you forget because the number of patients, even in the private sector, the nurse-patient ratio is not the same what it should be. Because there are so many other things the nurses are expected to do. Like you said, billing, you are also recording, reporting. There is so much of clerical work which I have seen is being done in the private sector, and then we expect them to also think of these kind of things. If you allow them to concentrate only on nursing procedures, nursing care, and take away the billing and sort of handing over time, which I always argue, I had discussion with Vinod and many of the people, probably then they can absorb themselves with what they learned. As an academician, I take all the blame of you people who you are the stakeholders, and I know, but I will definitely defend in my panel discussion that where have we created this difference or where have we created these gaps, and why we are not able to have the work-ready nurses in the clinical area. So, though it was very interesting to listen, but I was thinking, where can we try to absorb these things so that our nurses are able to perform well through the simulation learning, Thank you so much. It was just a comment.
I would like to add only 1 minute. I'm Dr. Julia Lep, and I'm working for Sultan Qaboos University, Sultanate of Oman. In our institution, we have concurrent sessions running in multiple simulation labs, so we can cover a large number of students in a day. Similarly, we have all trained facilitators so that everybody is trained in simulation so that everybody can run in the same day and we can finish it off. Similarly, we calculate 1 hour of, 1 hour of simulation equivalent to 2 hours of clinical practice. Since the nurses are completely immersed into the simulation, so that calculation of hours also will be very helpful. 1:2. Thank you very much.
That's good. That's a good practice. Should I be answering you, ma'am, or was it just a comment? Okay. But just to be honest, I think it's true that, nurses are expected, not only nurses, in fact, everyone who steps into the world of healthcare, especially in the private corporate, are expected to know everything that surrounds the patient. Though there is a movement to take away a lot of non-value add jobs from nurses, and I think all of us have worked towards it. Today, a lot of non-nursing jobs have been taken away from the nurses. Unlike when we were youngsters, we did a lot more, honestly. When I came from an ecosystem that I don't know how many of the elder nurses sitting here even did bed making, right? We all did. Today, nurses don't do that anymore. They don't do a lot of things which we as youngsters did. And also, Yes, I think I stirred up some controversy there. Right. Yes. So, like Tangam said, we are not going to talk about what we did versus what we do today. It's a journey and we want it better for our generations to come. But I said one thing that's very clear. This entire simulation experience for patient journey is not just about nurses, it was teams. My entire conversation revolved around teams, number one. Number two, the nurse stands as the single point of contact. So for her to be knowledgeable about what she needs to even cascade, escalate, or transfer is important. That's the essence of the entire thing. Thank you.
Morning. Morning, wonderful presentation by both of you. I think, there's a huge point, which we keep missing, when we talk about simulators. So, if all these things were so wonderful and fantastic, why is the acceptance, not so great? I think the underlying thing is the cost. You can't expect private corporate players like us, Apollo. You can still go ahead and then buy a simulator and then make people train. Like, for example, a simulation trainer. To train a trainer for simulation, it costs around 25,000 rupees. I think that is something that why I'm raising this is because there are industry players. I see industry players here. I think this, if we really want to be successful in this, I think we'll have to maintain the cost. Yeah, cost advantage. And with the government pushing Atmanirbhar, I think these are some of those things that where there are a lot of talent within India, where we can push and get these things done at the Indian market itself so that the cost comes very low. The other thing is there are a lot of hospitals or educational institutes, they have simulators. But the amount of consumable what you use, it's just a showpiece. Because the kind of consumable what you use on a simulator for a month, cost if you see, and they initially use that and slowly it dies down. And this all boils down to the cost. I think, that is something that which has to be addressed at a government level. And, as a country, we should also see that how do we ensure, because only then the success of simulators would be there.
Okay, thank you so much, everyone. We truly appreciate your time and valuable contribution. So I would like to welcome Dr. Marian, co-founder of CanSim and ex-vice president of INACSL. Please, ma'am, do the honor to come on the stage. Thankam, ma'am, Ms. Thankam, ma'am. Let's give a huge round of applause for our experts.
Okay, can we give another round of applause to all our dignitaries present? Thank you so much for that insightful session. And I think based on that question answer session, I would, it's a thought that came into my mind, which I'm eagerly, wanting to tell our organizers and especially Dr. Jaideep that this question answer session, I think this can be elongated because I think here is something that we are going to get a lot of more insights. And one of the main purposes of actually having the networking sessions and, insightful sessions is something that we will gain out from the question answer sessions that we have. And I think we're going to get more discussions. It's just started. We're going to be heading into our first break. Before that, I just have announcements to make. Not sure if this is visible. Yes. Okay, so we've all got our lanyards, we've all got our passports, and something that's really going to keep this conference engaging, and you can visit all the stalls, all the exhibition areas. Something that we have organized is the stamping on your passport now, and it's in your welcome kits, your welcome bags that you've received, the jute bags, the cloth bags that you've got. You'll have your card there. So do stop by participating company booths listed on the card, then network with the representatives to get a stamp. Visit each exhibitor on the board to fill up the sheet, and after collecting all the stamps, drop off your card in the INACSL booth. Okay, so this is one thing. Once you've got all your small stamps covered, you'll be eligible to enter a prize pool, and from there you get a chance to earn a good reward. Okay, so if you want to chance your arm in winning a prize, definitely fill all the stamps. There's a very engaging exhibition area that we have right outside. You definitely visit that during the break time, during the lunch time, right? And we will go to the next thing now. Yeah, and so we will now break for 15 minutes for a tea break, and after that we'll come back on time, 15 minutes, and we'll come at 12:10 IST. Two basic announcements of giving value to our time, something that I'll talk about. As per our expectations and going just a bit beyond that, we have been a little late in time, and therefore I would urge all participants to adhere to the break timings, be it the tea break or the upcoming lunch break or the evening tea break, because we definitely do not want to shorten the speaker time. The track time that we have, that is of the utmost essence for all of our participants. The dialogue that we will have here, the presentations that the experts are going to provide from here, those are of utmost value. And I would request you, urge you all to adhere to the break times so that our conference time as a whole does not expand. Now I'd request all of you to take your seats and settle in as we move to our next track. And this is going to be track 2. And before we get into the details of track 2, it'll be my honor to introduce the speakers for track 2 that we have lined up for this session. First up, we have Dr. Jack, all the way from Thailand. Please welcome Dr. Jack, the Associate Dean at Pechbari Rajabhat University's Faculty of Nursing Science and Director of SiMCON. As Chair of INACSL, Thailand RIG, he has been instrumental in advancing nursing simulation education through innovative training programs and research initiatives. I'd also like to welcome our dear moderator Nikhil on the stage. After Dr. Jack, it is my great honor to introduce Dr. Jaideep Harbert, a distinguished first rank holder in nursing with expertise in simulation-based education, with a PhD in healthcare simulation and specialized training from George Washington University. He serves as India's expert for World Skills Olympics and executive board member for the World Nursing Conference, USA. A prolific author and curriculum developer, Dr. Herbert has significantly contributed to nursing education through his publications, course development, and leadership in advancing simulation-based healthcare training. Now, it's my great honor to welcome Dr. Pedro. Please welcome Dr. Pedro, a critical care nurse at Hospital Clínic de Barcelona, an academic coordinator for clinical simulation at the University of Barcelona. As a member of the Society for Simulation in Europe's Executive Committee, his research focuses on healthcare workplace dynamics and patient safety. Over to Nikhil.
Thank you, Joshua, for such a warm introduction. Good afternoon, everyone. Hope you all are having a great time. Okay, let me try again. Good afternoon, everyone. I believe you had your tea and coffee, so you are fully refreshed. All right, so it's an honor for me to be here and excited for the opportunity to connect with all of you. So before we dive in, again, I would like to state the time limit to the respected speakers, that each of you will have 20 minutes to enlighten us with your thoughts, and I request that you stick to the allocated time so that we can maintain the session schedule. Thank you. Also, I encourage everyone to stay focused during the session, as at the end you will have the opportunity to ask your questions. Please listen carefully so you can ask relevant and informed questions later on. Okay, so this session is on simulation in healthcare, what it is and what it is not. In the ever-demanding world of healthcare, where precision and decision-making can mean the difference between life and death, training methods must be rigorous, effective, and safe. Simulation has emerged as a powerful tool to enhance learning, refine skills, and improve patient outcomes. But what exactly is healthcare simulation, and what misconceptions surround it? So the first topic under this track is, there is low learning without mistakes utilizing simulation. And to share insights on the same, ladies and gentlemen, please join me in welcoming onto the dais our first speaker for this session, Dr. Jack.
Okay. Good afternoon, everyone. First of all, I would like to thank you, INACSL India League, especially Dr. Jaideep, who invited me to be on this stage. So, at the first speaker, she speak about the mistake in the simulation. So in my section also maybe continue with her talking about the mistake. So today I will have some recommendations how to deal with the mistake, especially with the nursing student. You know, I'm not sure like how many of you have the experience to teach by using simulation-based learning in your setting. How many of you? Oh, okay. Just a few of you, but I think this is a great opportunity for all of you to start to learn about the simulation-based learning. So my topic about there is no learning without mistake utilizing simulation. So all of the information from my presentation based on the evidence-based and some from my experience, I conduct the simulation-based learning with the nursing students. So, can I use the microphone? Because Okay. This is the information from the Global Patient Safety Report by WHO last year. They're talking about the 8 types of patient harm in a hospital globally. You will see that at the second speaker mentioned about the medication error that occur a lot, even in the hospital or during the simulation setting. You know, this one is very important point for my university. We have the rule that during the simulation, if the student provide the mistake medication for the patient, they will fail. Even they provide the perfect procedure for the patient. This one very important that if, I'm not sure in Thailand, we teach the student for medication preparation with 10 R. R stand for right. For example, like patients, like medication, like right, something like that. So the student have to remember or before they provide medication for the patients. And the second one about the diagnostic error, healthcare associated infection, sepsis, patient for patient ulcer, patient identification errors, and unsafe transfusion practice. I think not only this procedure will harmful for the patient. I think every nursing activity, especially with the nursing student, that can cause harm for the patients. So the same in. So sorry, I cannot see the PowerPoint over there. So from the same statement, they mentioned about that to resolve the patient harmful. So the simulation is very benefit. As you know that we use the simulation to enhance clinical skill, knowledge, and attitude. So the students go through the simulation room and they're free to make a mistake, right? And then not only the knowledge, skill, and attitude, the simulation can also provide the student with communication, teamwork, and human factor. So after the patient practice in the simulation-based learning, we would like to see the patient outcome with the safety. However, from this report, only 19% of the country fully incorporate innovative teaching method and simulation into their patient safety curricula. You will see just a few of the country implement for the simulation-based learning in their curricula. So we would like to increase more percentage of the simulation implementations. I would like to share from my experience. In Thailand, we use a lot of the simulation during COVID-19 because the student can hand-on plastic in the hospital. So after COVID-19, Thailand Nursing Midwifery and Council see the importance of the simulation-based learning. After that, they launched the policy for all university, for the nursing school, that we can use the simulation-based learning 50%, replace the clinical hour in the hospital. But I cannot give you in detail because this is not my topic today. If you would like to ask me about this experience, maybe we can talk later. So, as you know that, this one, the report from Berg in 2019, he found that about 61% of human errors are skill-based. This includes the action slip. The action slip, for example, maybe they're reading the long medication name. So this one also will make it harmful for the patient, right? The second one about the memory lapse. Memory lapse, that means maybe they're forgetting to carry out the step of task. For example, if you are a nurse, maybe you will be familiar with the nursing guideline. So we have a lot of the guidelines, but sometimes maybe we cannot follow the correct step. So this one also like a skill-based. On the other hand, you will see that 27% of the mistake is rule-based. So you will see a lot of the rule-based type, for example, wrong rule, bad rule, or violation. So when we're talking about the mistake or error in education, Actually, it will divide it into the early occurrence and also early collection. So I would like to give you some detail about the early occurrence that divided into 4 subtypes. The first one, the early avoidance. For the early avoidance, that means, you are, as I mentioned before, if you use the simulation-based learning, change your role from instructor to facilitator, right? You have to help students to success in the scenario and meet all of the objectives that you set. So for the early avoidance, that means the facilitator give a comprehensive explanation for the student, but they still forgot about the information that you give. And actually in this one, it looks like the direct instruction. So the facilitator will know that what is the common mistake for the student in this scenario. Maybe the facilitator will talk before to avoid the student that make the mistake. So in that strategy is the most common use in nursing education. The second one, the early late, which means no predetermining strategy for eliciting earlier, but they are not prevented. The third one, early induction. The early induction, that means the early is actively promoted. I'm not sure if you have the experience, some facilitator provide the complex scenario without guidance for the student, because they would like to see some mistakes from their student. Okay. The last one, guided earlier. The guided earlier, that means we would like the learner learn by analyzing the example of earlier, and they will know the potential solution in that mistake. Okay. After you know about the early occurrence, we have to collect it. The early collection divided into 2 methods. The first one, self-collected. Maybe the learner know the mistake by themselves and they collect it without external facilitation. Whereas supported collection involved with the external facilitation. For example, educators' feedback or computer-based support is rectified earlier. So maybe this one is quite theory, but I would like you to know about this. Okay. So I would like to ask you questions like, when you conduct the simulation-based learning, how many stages of the simulation-based learning that you implement? How many stages? 3, right? The first one is pre-briefing. The second, scenario, and debriefing. Which stage is the most important one? Debriefing. You are very good. That means I think all of you conduct the simulation-based learning before. And actually, to prevent the mistake from the student, we can do in every stages, right? So, for my experience, before you conduct the simulation-based learning, you have to create safe place environment. Maybe someone know about the psychological safety, how you can make the patient relaxed before they go to the simulation, right? They said that if you create the safe place environment, the student will feel safe. They can extend their comfort zone. So maybe sometimes they're out of their comfort zone. Reflect on and discuss area needed improve and makes mistake without feeling ashamed. So at the pre-briefing stage, actually pre-briefings consist of 2 words, right? Preparation and briefing. For the preparation, that we will provide some guidance, some material for the student maybe 1 week before they go through the scenario. On the day that you conduct the simulation-based learning, we will implement briefing first. During the briefing, you can talk to the student for psychological safety. For example, here you are allowed to make mistake. This is no exam. When you say that no exam or no score, the student will have like, it will feel relaxed, right? And then we have not gathered you to test you on anything. Just practice. And actually, when we're talking about the assessment, the simulation-based learning that we use, it is like a formative assessment. We don't give any score for the student, but we would like them to develop themselves for their practice. Or maybe you can talk to the student that the events within these walls remain within these walls. That means the confidentiality. Everything that we talk or discuss in the simulation room will keep secret, something like that. Then this is from my experience, when you allow the student go to the simulation room to perform the scenario, actually we know that we don't want to disturb the student practice. So we will allow them to practice until the end of the scenario. But if they have mistakes, we have to stop them. From my experience, I will stop the scenario with 2 reasons. The first one, they're out of track. Out of track, that means the student far away from your objective scenario. So we have to stop them, and maybe you give some more guidance for them and allow them to continue the scenario. We hope that the student will succeed for the scenario. The second one, we will stop the scenario because of the harmful situation. For example, the student will make it harmful for your simulators. Or in some cases, especially for the psychiatric nursing, you will a lot of the standardized patient, right? Maybe the student will take the needle to inject the standardized patients. So we have to stop it. Or maybe they will make the harmful to the environment in your simulation room. We have to stop it too. This is my student. They will practice in the simulation room. Okay. The next question, do you will identify mistake in simulation-based learning? Who say yes, please raise your hand. Just maybe 10. Who say no? Who don't raise your hand, that's mean not sure, right? Or both answer, right? So maybe I don't have time to argue a reason why you say yes or no. But this is the reason from my literature review. They say yes because when the student makes mistake and those mistakes not identified or acknowledgeable, students are likely to repeat the same mistake in the future simulation or in the clinical setting. So they recommend you to identify the mistake of the student. But the reason why we don't identify the mistake because care for student well-being and want to make them comfortable and safe. You know, sometimes it's quite difficult when we have the simulation-based learning. We always talk to the facilitator that you have to create positive environment for the student to let them, you know, out of the comfort zone and learn from the simulation. And the second one, making mistake visible could trigger feeling of discord and isolation. Some facilitator aware about the stigma of the student. You know, like for example, in my university, we talk that we don't allow the patient die. Because if the patient die, the experience of the student is bad. So we have to use some technique of the simulation. Maybe you heard about trigger, cluing, or prompting to help the student for the success. But I'm not sure because when I read some paper, they don't have any suggestion that we don't allow the patient pass away during the simulation. The third one, students could agree that their errors are caused by the simulation itself. Maybe some students that, no, I don't make the patient die or I don't make mistake because of the simulator that caused my mistake. So this is a research in 2021. They compare between the productive failure simulation. That means they create the simulation with the failure scenario. Compare with the direct instruction. That means the scenario without any failure, but the student talk to them directly to give the instruction. And actually, they will have the intervention and they collect the data before and after intervention. And they collect for the declarative knowledge, explanatory knowledge, transfer of knowledge. And the result found that after the intervention, the knowledge of the productive failure higher than the direct instruction with significant difference. From this study, they conclude that providing the failure of the simulation can let the student identify their skill and knowledge deficiency, and it can enhance their learning. So, after scenario stage, we will go to the debriefing process, which is the most important stage of the simulation-based learning. And if you see the mistake during the scenario learning, we can talk or discuss about the mistake during debriefing process. So what is the recommendation from this study? So how you talk about mistake. This is very important. And I think the facilitator idea also different, right? And maybe some facilitators said that mistake during the scenario is very benefits and good experience for the student to learn from their mistake, right? It is better than the direct instruction if you do like happen next. But if the mistake occur during the simulation, you can see their action and behavior. And sometimes you can see the correction approach by themselves. Even they cannot correct during the scenario stage. Maybe those mistakes can correct during the debriefing process by their friends or facilitators, right? And the second one, fostering positive aspect to enhance learning. So, some facilitators said that if you can't identify the mistake, and you have to talk that this mistake can occur, and it is happen in the simulation room is better than occur with the real patient or in clinical setting. We have to talk about the solution to correct this mistake. So you have to create the positive environment during the briefing to talking about mistake, right? The third one, create a safe space for learning. As you know that simulation-based learning was not the test, but it is training. It will provide the opportunity for the student to enhance their practical skills. Right? It's different from the test that you have to decide that this student will pass or fail, right? The last one, variability in facilitator responses when addressing mistakes made by students. Some facilitators said that mistakes have to open discussion to let all of the students learn together. And some facilitators said that at the initial stage of the debriefing, maybe they will highlight the mistake occurred during the simulation. Or maybe you can ask the student during the scenario stage, can you recognize the mistake? And maybe some students can recognize their own mistake and they can correct it by themselves, right? And maybe this is my last slide. This is the impact of mistake on learner in simulation-based learning. They will have both negative and positive aspects. The first one, negative feeling, they will feel frustration, guilty, and fear. But for the second one is a positive aspect. They will feel like the comfort of knowledge, knowing that mistake made during stimulation-based learning do not present a list for real patient. It's occur only in the simulation room. And they believe that it will not occur with the real patients. The last one, viewing mistake as positive learning experiences due to the feedback received. Especially the feedback from their friends, may be more friendly than the facilitators. But if their friends cannot recognize or they cannot provide a resolution for the student, maybe that is the responsibility of the facilitators. So, no learning without mistake, no success without failure, learned and improved by simulation-based learning. Thank you very much.
Thank you, Dr. Jack, for such an insightful and engaging session. We truly appreciate the time and effort you took to share your experience. Okay, without a further ado, let's move into the next topic in this session, that is clarification, simulation in healthcare, distinguish between what it is and what it is not. In modern healthcare, education and training, simulation has become an invaluable tool for improving skills, enhancing teamwork, and ultimately ensuring better patient outcome. To clarify the distinctions, explore the true value of simulation in healthcare, and address common myths surrounding its use, it is my absolute honor to welcome onto the dais Dr. Jaideep.
Thank you. Thanks, Nikhil. This hall seems like a movie theater, right? And half of the people are sitting on that balcony, right? They are enjoying from there, some of the people on the front seat, and that's fine. So it's, if you feel like you are in the movie theater, you should watch a movie, right? So let's watch a movie. So thank you. So movie time over, but you can correlate this movie with what I'm going to talk about, right? And with the theme, right? That transforming your brain power to hand power, right? So this is the simple thing. Imagine when somebody asks you, okay, what is BLS? Oh, BLS is this is the stress compression, 30 compressions, 2 ratio, BLS karke dikhao, right? Are you able to do that 5 cycles? No, we cannot. On the real patient, after 2 cycles, you get tired, right? But you know, nobody cares whether you know that theory or not. Can you translate that theory into action? Okay. So in my presentation, I will very quickly just want to talk to you about what is simulation, and whatever the misconceptions we are having, we just have to clarify, because when in the next sessions we dive into more deeper into the simulation, you should understand first that what it is, so it will be easy for you into the next session how to adopt the simulation into your nursing curriculum, in your practices. Until unless you do not know what it is, it will be difficult how to implement. So let's discuss about what it is. So the traditional training and simulation training is very much different. In various aspects. I'm not going to detail about it, but in the traditional training, you cannot replace the thing. Whereas into the simulation, you can replace the thing, because simulation is the replication of reality. Right? If I use this word again and again, and every time in many of the sessions I used to say this word, simulation means that it's a replication of reality. Right? If you are saying the replication of reality, it means you have to replace the same thing, whatever you are seeing into the hospital. You cannot imagine, right? Which sometimes we used to do, right? Okay, in simulation, every student get the performance opportunity, and everybody gets the opportunity to perform and show it back. In traditional training, what we do, in traditional classroom, what we do, we ask everybody, okay, the session is over. Can you tell me the definition? Can you tell me the causes? Can you tell me the sign and symptoms? Can you tell me the management? Oh, wow, the session is over. Whole class, I assume, everybody knows and understand. That's it, not simulation. Everybody has to perform, and then we have to check. So that is the small difference, but you can make it better. So what is simulation? Many people have already talked about it. It is repeatedly practiced, mistakes you can do, you are allowed to do, and it's an educational process. But here I just want to tell you what it is not simulation. Right? What is simulation is okay, but what is not? Simulation is not to do just demonstration and take the written demonstration. That is not simulation, right? That simulation, I keep saying this word, it's a replication of reality. When you say the replication, it means you are giving that the same reality situation to somebody and ask them to do that. It's not only for one procedure to demonstrate and take the re-demonstration. It's not a preparation of demonstration and models and exhibitions. It's not simulation. It's not a chart and poster. Video-based learning, it's also not a simulation. Just watch the videos many times that what is happening, and with the power of observation, you can assume that what is there and how you can understand. But until unless you do not practice it, you cannot do that, right? You watch the movies, right? You just watch the movie here, right? You watch the movies into the theater, but can you do all the actions? No, you cannot do all the actions, right? So that's the video-based learning is also, that's just a power of observation which allows us to recoil everything. Why simulation in nursing is needed? The simulation is needed and is implemented into the 3 areas, that is aviation, healthcare, and military. Why? What is the similarities in 3 industries? Aviation, healthcare, and human life, right? Exactly. These all 3 industries are with the human life. That's why we need the simulation in healthcare. Imagine the people from the army are here, right? They cannot practice, okay, let's try the bomb today in this and let's see whether it bursts or not. Kitne marte hain, is bomb ki effectiveness we can check. Can they do that? No. Pilot can do that? No. Let me just fly today and then we will see whether the flight will land or not. Can you do that? Can you sit with that pilot? If we say, I just completed my aviation course online and I am your pilot today, do you board into that flight? No. So why not our healthcare professionals should practice into the simulation? That's the need of simulation. So we understood what is simulation. Now we understood why simulation is required. So what to why? Particularly for the nursing perspective, we understood what is simulation, why simulation is needed. Remember, simulation is a time to take what you learned in your textbook and now you have to bring into the real life. You all from the nursing background, you all know when you were into the nursing college, you have the one book which called the log book, right? Yes, it is mandatory for all of you to get it signed. Right? Whether you do the procedure or you do not do the procedure, but you have to get it signed, right? Yes? Okay. But think for that. In your nursing career, in 4 years, did you able to see all kind of the patients for all these diseases, not kind of patient, I should say, for all the diseases which you study, medical, surgical, obstetrics, pediatrics, with all the diseases, did you able to see into the patient in reality when you go into the clinical posting? No. Will you able to do all these procedures? No. You sometimes even never see it. But when you go into your real life, You never know what kind of the patient you will be encountered with, right? So where you have to learn? Where you have to learn? You have to learn that in simulation. That's the simulation. What is simulation and why? That bridges the gap, right? That's why the simulation is needed. The people were talking in the morning, the challenge is about that the fresh graduate nurses are coming into for the job, right? What the challenge is. Because not fresh graduate, sometimes even we do not have the exposure for all these patients, but from where we have to learn, right? We cannot play with the patient life. So why simulation? It has already been dealt. Now, what do you have? So now we understood that what is simulation. What do you have? Do you have the skills lab or simulation lab? Look at this photo and you see and tell me. What do you have? A skills lab, right? So there is a difference between the simulation lab and a skills lab, right? Remember, right? As I said to you, please take these words when you go after 2 days. Simulation is the replication of reality. In this photo, here you can see, is this the reality of the hospital? Right? No. In none of the hospital do you see that the posters and charts are hanged into the patient room? No. So if you wanted to teach to the students in the simulation lab, you have to create that the same context as itself in the hospital. Be it the equipments, simulators, consumables, even the light, even I can say the smell, right? That also come under the fidelity, right? The smell, the same smell what they feel in the hospital, that the same smell they should feel into the simulation lab. So they feel, oh, in this way I have to go into the hospital, right? So that's the difference. If you have the skills lab, that is for the skills demonstration. But if you are saying the simulation lab, it should be simulated as a patient room. So difference between the skills and the simulation lab, it's very, by the skills, you know, by the word skills means where you have to just learn the certain skills. You have the task trainers, you will go and you learn the certain skills. But whereas in the simulation, it is giving you the context and the environment and the fidelity of where you see that exactly as like a hospital. So what is fidelity? This certain words which I am using during this session, that is related to that we use into the simulation, right? So fidelity is what? The fidelity is ultimately we say that's the context, environment, everything included into it, which includes the equipment, which includes that the simulators, consumables, psychological impact, environment, smell, the lights, everything include, then we call it's a fidelity, right? So it's appearance. We categorize the simulators according to the different fidelity. But that does not mean on the basis of that the only simulator you cannot categorize high fidelity, low fidelity, and medium fidelity. Be careful. On the basis of the simulator you cannot categorize, right? On the basis of simulator, the simulators are also categorized, but on the basis of their features. But how you can create your whole environment, instead of the high fidelity, you can have the standardized patient. But your room, it's look like a similar like ICU. Your room looks exactly similar like OT. Your room looks similar like patient room. Okay, so that is called the fidelity. So low fidelity simulators are the on which you can have that some single task. So we also called it the task trainers. So when you go into the exhibition, the people might show you the different task trainers. They will use this word. So that means they are showing you the low fidelity. Medium fidelity, where you can do a little bit more advanced procedures on that the mannequins are categorized into the medium fidelity. High fidelity, where you can do that a lot of the things, including that the critical thinking, clinical judgment, where the patient can talk. It does not mean that you should have the high fidelity simulator, right? You can also create your own high fidelity simulation center. But what are the factors affecting the fidelity of simulation? As I said there are the engineering, how you equip. Look, if you set up your room or your simulation lab in this way, and you said this is the simulation lab, can you create the hospital room into this photo? If you ask the students to come, hey, today I will take you to the simulation room and simulation-based training, can they simulate this is the hospital? No. the disconnect is there. They enter and they say, oh, dummy hai, right? कुछ भी करो, आधे को दिखेगा नहीं दिखेगा, मैम एक demonstration करके चली जाएंगी, right? So that immediately you give that the disconnect there, right? So that's not the exact engineering. Psychological environment and the environmental fidelity. How exactly you give? See, look into that photo. You create a similar. It's the dummy is also there, and the dummy is also there. The simulator is also there. The simulator is also here. But look the environment, right? How you put it. When you ask the students to come into this room, they already think, oh, I am going into the similar like the hospital room. So I have to act as similar as like a hospital, right? Then the moulage. Ms. Tanya is here, who is expert in moulage, right? You can meet her during the tea break. Moulage, the word we use when we create something for learners to make it the more physical science. That is the word called moulage. That is the word which we use into the simulation-based training, which helps to the students to how to make it more real, which usually we use it for the emergency, trauma, wounds, sutures, all these things, and you can create it and make it more realistic. So students, they will see it. Sometimes what happens when you deploy the students into the emergency right after their graduation, they never see the patient comes with the amputated hand. The trauma patient, they get feared, right? They get scared because we never give them the exposure that what happens when the patient is having this. So my colleague has already discussed about this structure. Please copy this picture in your mind. This is very important picture, right? That what is the structure of simulation-based learning? This is important, the pre-briefing, simulation scenario, and debriefing. In the next 2 days, we are going to discuss only on this. In the afternoon session, we are going to discuss about pre-briefing and the simulation in real situation. And tomorrow, we will discuss in debriefing. So look at the picture. How small part is pre-briefing, how small part is simulation, but most important part is the debriefing, how your learning convert into, how your scenario turn or translate into the learning. So the key benefits of simulation training is critical thinking, enhanced decision making, all these things you know, but the most important thing is that there is a difference between the skills demonstration and the simulation. And I hope you understood that what is the difference between. So whenever you practice, try to practice it as the simulation-based, right? Sometimes we do that in the college when we do not have the resources, and I always give this example. Whenever we teach any of the procedure, we ask the students to complete the tray from the fundamental lab, right? And we complete the tray, and whatever the resources we don't have into the lab, we ask them to put the chit into that kidney tray, right? This bowl is small. Do you do in reality? Do you do into the reality that when you go into the hospital, in front of the patient, the chit of kidney tray, and ask the patient, assume this is the kidney tray? Do you do? No. So when what happens, if we do not train them in a simulation way, if we do not tell them the different situations, in the reality, when the nurse goes into the reality, if she does not know where is the kidney tray, if she does not get the resources, she has no clue what to do. Right? So that is called the critical thinking and clinical judgment. These are not the big shots, but from the beginning we hear these words. What is critical thinking, clinical judgment? We do not need to have a special class on critical thinking. We do not need to have special sessions on the clinical judgment, right? The critical thinking and clinical judgment, there and there you can train when you demonstrate any procedure. In simulation, when everybody is talking about the mistakes and everybody was talking about that it's a platform where you can do the errors, we have to allow them to think into that way. If this is not there, what you gonna do? If this happened, what you gonna do? If the patient is asking, if you are going with the cannulation to the patient and patient says, no sister, I don't want it, मुझे नहीं लगाना, बहुत दर्द होता है, मैंने अपना हाथ छुपा लिया. What you gonna do? What you have to speak? What is the communication you have to talk? Right? If you will never train them into the what they do into the reality, they say, अभी डॉक्टर को बताती हूँ. Right? सिस्टर को बता देंगे, नहीं लगवाना मत लगवाओ, तुम्हारी दवाई है. You never know. You never allow them to think into the simulation way. Then madam was saying in the morning that every day we face these many challenges. From where the challenges come? Because we never give them the exposure to think into such a way, right? So that's the simulation. So this critical thinking and clinical decision making, clinical judgment, you can just add on into your things through the simulation. That's the simulation. So simulation has the three parts always: technical skills, communication skills, and behavioral skills. When you add these three, then your simulation makes. When you just demonstrate, that's called the clinical skills. But when you complete the three, when you go with the tray, how to communicate with the patient, what to talk to the patient, how you have to put yourself in front of the patient, if the patient refuses what to do, if the injections, by mistake, the injection fall down on the floor, what you gonna do, if the injection leaks, what you gonna do, along with your procedure. If you add these things, never think up, trust me, you will never have the challenges, and we will bring the more and more competent and skilled nursing staff. So there are the different types of simulation training. Today you can have in 2 days, you can have a lot of interaction with the AR and VR. Dr. Adit is here to discuss tomorrow about the AR and VR into the simulation, and he's doing a lot of in the nursing. And task trainers you can see, high fidelity mannequins you can see, scenario-based things you can see. This is just one photograph which talks about how simulation-based learning is more effective than the classroom, e-learning, and rapid micro learning, right? So I do not need to explain because it's a self-explanatory picture. This is our future of nursing. Through simulation, how we have to train to our Gen Z population, right? I can see right now how many of you are on the phone, right? Right? From here I can see. You cannot live without phone, right? So we have to think how we have to prepare our new generation with these technologies and everything, and we have to prepare them for simulation-based training. So as in the beginning, I said, it feels like we are in the theater. Imagine, we all know in the theater, how do we know? We know the story is not real, it is manifested scenario, the characters are not real, it is not a real place, animal cannot talk, right? And how it ends. Sometimes we cry after movie, right? But what happens? Still we believe it is real, right? That's the simulation, right? Trust me, if you train somebody with errors, they will never ever forget in their life. But we have to adopt this methodology, okay? If we miss out this methodology, if we do not do, then what happens into the reality? And in the next panel, our experts will talk about it. They will face these challenges: lack of confidence in practical setting, increased dependency on colleagues, slower adaptation to work environment, risk of error, limited career opportunity, less skills, less jobs, strain on professional relationship, and need the additional training. So are you with me? Can you just take out your phone and scan this code? Can you just take out your phone and scan this code and answer this question? Do you think the simulation-based training should be a mandatory part of the training, nursing education? Yes or no? Yes. So after listening all this, do you think? Can you give the answer right now? But some people, I can see that okay, so this is the feedback of what I said to you, right? If you still think that this is the need of an hour, we have to adopt. And I hope in 2 days you will learn that much so you can go back and then apply it. Thank you so much.
Thank you, Dr. Jaideep. Your insights have given us a lot to think about and will surely help us in our professional growth, better understanding, and future trainings. All right. What an incredible journey so far, isn't it? Yes. Come on, everyone. You can make some noise. Excited? Yes. For the last topic of this session? Great. Okay, the last topic in this track is performance under pressure in simulation. Be prepared, not scared. So let's get ready for an insightful discussion on how to turn pressure into preparedness. Let's give a warm round of applause as I welcome our last speaker of this session, Mr. Pedro Cataxo Sintra.
Okay, so good morning, everyone. First of all, I would like to thank you for the opportunity to be here with you today, especially to Dr. Jaydeep that offered me this wonderful opportunity, and especially for you that it's wonderful to see a full house today. And I think that we have 2 days that we can spend together to share some knowledge and learn from each other. So I think it's very interesting, and congratulations for your first Congress in India, because I think it's going to be challenging and will bring a bright future. So this morning I would like to share with you some thoughts about what is being prepared and not scared when we think about clinical simulation, and especially when we are students, but also when we are facilitators and we need to do the design and implement our programs. So before starting, this is very important, some disclosures and conflicts of interest. First of all, I'm one of the executive members of SESAM. It's a voluntary position, so I have no interest on getting any information or clients for the society. And as well as I'm director and coordinator of academic programs. This is something that involves money, but that's not my intention to acquire any new clients with this session, okay? So for this session, I would like to ask you, first of all, to be open-minded. I'm going to be challenging you in many ways, and I'm not sharing with you any knowledge that you need to have. What I'm going to do is give you some input to think about it, go home, and probably give it 2 or 3 days and open some articles and get your own opinion about it. So this is not my main goal to do a class to give you some definitions, what it is, what it isn't. No, it's not my goal. My goal is to exercise a little bit of our minds, and I'll always be more than welcome to receive your questions, your comments during these 2 days. So, first big question. What is clinical simulation? Is it a strategy, a technique, a method, a methodology, a theory? To tell you the truth, I don't know. It's too difficult to know. Because my reality, when I see simulation as a methodology. But I had the opportunity to talk with some friends of mine that they have different levels of experience, and some of them, they see simulation as a method. Others, they see it's an educational strategy. And I have a few ones, they think that we are building a new theory in simulation. So this is very important. The way and the context, and especially what we build in simulation, brings to us the need to give a definition about what we're doing. And sometimes it's difficult too. So what I would like to give you now is the opportunity to think for you as a participant, as a student, or as a facilitator. What do you think? What is simulation for you? And try to organize and build your activities based on that. I think that under my perspective, and considering all the literature and everything that we've been doing through these years, I see at this moment simulation as a methodology. We have many methods that we can apply in simulation. We have many strategies as well, and I can see it as a method that probably in a few years will be a theory inside of nursing science, in many other science. So I will just give you this challenge to think about it. And this is a good article from 2 friends. It's friends of mine, Walter Epic and Gabe Reedy, and they talk about exactly this. And you have the QR code that will guide you through this article. They tell us the different perspectives of simulation through the many other words that we had in the previous slide. So if you would like, this could be a good way to support you and give you more information. So we keep on this role. What is clinical simulation? How do I see clinical simulation? Sometimes now we are reaching a stage that we need to be innovative. And clinical simulation, we are always thinking about a way to innovate. How can I be more creative? How can I create more impactful programs, better programs that can engage our students? How can I do the prepare my facilitators to have a different strategies to engage more students, and especially to develop the needs that we can find in our universities and hospitals. And we are now in the way that we can see extended reality and metaverse, the standardized patient with generative AI. We see industry that are trying to bring us solutions and technology and technology and technology. And in our minds, for some instance, is more important to innovate than educate. And that's what I would like to bring to you, that sometimes transformation is more important than innovation. Probably we are spending too much time on trying to innovate and discover the new will, but if we have the will, we can shape the will in different processes. We can give to the will a different design. We can give to the will new features that can improve the way we move. So if we transform and we try to be transformative, probably is a better way than trying to be always innovative. And afterwards, we will find through the transformation process that what we've done is innovative. So what I'm asking you is to do the other way around that we are thinking. First, we think about, I need to be innovative, and then I think, how can I transform? What I'm asking you is to probably think in the possibility to start finding ways to transform what we do daily to, at the end, we call it as an innovation. And this in simulation, our colleague Sharon Mary Weldon, she developed this strategy that we can find many T's, as you can see, to build on innovation through transformation. So this is a few steps that we can take on our programs, on our contexts where we work, and think about how can I improve, how can I do interventions, how can create more involvement, how can I identify and discover and recognize new needs, how can I be more inclusive, and how can I influence. And every single time we do this, we are transforming our own culture. Next big question, to continue what Jaydeep said. If I would ask you, is this high fidelity or low fidelity, what would you say? Who says low fidelity? Who says middle? Who says high? Everyone is scared about to answer. It's low. And what if I tell you that this can be whatever you want? As Jaydeep said, the fidelity is built on the context that we create around the simulation scenario. If I tell you that this is an orange, a syringe and a needle that I'm using to practice how to do an intramuscular injection, and I will do it repeatedly with the orange, this is low fidelity skills, as Jaydeep said to us. But if I think about this orange in an emergency room with a patient that is having a severe allergy to peanuts, with an actor, and our participants are assessing this patient, and they will do the procedure of pinching an EpiPen, do you know? The EpiPen for, anaphylactic shocks, And this actor has half of orange on her leg for them to try and see the strength that we can use the needle with clothes and they can do and pitch as in a real world they would do it, do you call it low fidelity or high fidelity? It's high. And we're still using an orange, a needle, and a syringe. So the low, the middle, and high fidelity, it's everything you would like to do. And sometimes we don't need so many resources to do this kind of scenarios. So why are we always trying to have the latest model of the simulator from the world, from the different companies of the world, when we can probably sometimes with lower resources do the same goals and reach the same objectives that we plan for our learning outcomes? What I'm trying to tell you is the future is based on this: low cost but high impact. Better things sometimes do not come from expensive resources. It depends the value that I give to it. If you think about a painting is something that we give a value, and it's not that expensive to paint. But the same paint I can give you for like $5, or the same painter, if it's famous and has a history of it, I can transform it as a 5,000, and they both use the same materials. It's the value we give to it. In our science, the value is based on the context, based on the methods, the strategies, and what we develop on our designs and implementations of the scenarios. So think about this. We can do more with less, and probably sometimes we just need to review this note. Think about low cost, think about high impact, and how can you improve and sometimes improve and give new solutions to your community. And this is one of the topics that are shared on this on this global consensus that I'm not sure if many of you knows about it. Did you know that we have a consensus about simulation, a global consensus? Who knew it? So last year, all the groups you can, and I'll explore with you later, many experts with different levels of knowledge in the simulation field came together and they built the global consensus statement on simulation-based practice. And they gave us a new reality about what we need in simulation at this moment to achieve in a near future better outcomes. And it was a project that was conducted by two societies, SSH, the Society for Simulation in Healthcare from USA, and SESAM, the Society for Simulation in Europe. And they came both together, two big societies that sometimes we think they need to be apart. No, they came together to build this global consensus, and I will leave you the webpage if you would like to see more about it. And they've built the opportunity to write this document that states all the needs that we have at the moment and how can you apply this global consensus locally. Actually, I see this global consensus statement as an opportunity for us to get into a political level. This global consensus states clearly the impact that simulation can have in our patient safety and quality of care. And this is something that we didn't have at the moment. An article where we can go to our CEOs, we can go to our nursing directors, we can go to our university deans and say, if we start to apply this kind of methodology, probably we will save lives. And this is a perfect way to justify and to give you the opportunity to say, it's not me saying this, it's the whole world that are committed to achieve this kind of objectives. So this statement, they build 9 of the major goals that we have and spaces that we need to work in the near future. And as you can see, One of them is equitable access to high-quality context, relevant simulation, and the other ones are all built across the needs that will explode from different parts of the world. And now you're thinking on the policymakers and leaders. When we use this global consensus, we can formally acknowledge and embrace the benefits of simulation, we can commit to sustain the support, and then we can mandate the application of simulation within education. And now I'll tell you, as soon as we launched this report, do you know who were the first ones to contact us? WHO. And they said, thank you. We didn't realize it was so important. So now we are building with the WHO the first recommendations about how to apply clinical simulation in not only the educational field, but also in the clinical field. And it's to be accessible. It doesn't mean that it needs to be only in Europe or USA. It's to be accessible, to be applied in any part of the world. So in the near future, we will have some news about it. As I said to you, the global consensus was built within 6 continents, more than 50 societies participate, and 67 countries were also included. And as you can see, India participated as well in this global consensus. So your context and your reality is mirrored as well in this paper. And every single one can endorse the global consensus. Everyone that believes that the global consensus is important, this is how we build the community and stay together, is to have the possibility to everyone agree about the importance of the global consensus, and importance especially of the clinical simulation, and how can we increase the number of people knowing the impact. Okay, and back to the topic, something that we know is we are under pressure. And I think that we realize that we are under pressure since COVID. COVID gave us the reality of when something happens, we need quick actions to change the way we work. And sometimes pressure doesn't mean quality. And it's difficult to be under pressure and give the same quality that we would do in normal conditions. So INACSL gives to us some standards that help us a lot about how to do this kind of scenarios. And I recommend you that every single time you think to do something under pressure, just pass some of the best practices points of INACSL, and that will give you the opportunity just to double check the quality of the work you've been doing. And these standards, they are not only we do not apply them only in the nursing field. We can apply it in the medical field as well, and we can apply it as also in situations that we do multi-professional programs. So it's a good idea to have these guidelines that help us, but also some tips. So now I'm going to give you some tips when we think about we are under pressure and we need to be able to create and generate our programs, and they need to be effective. I would like to share with you this. Probably we will recognize what it is, some of you. Rapid cycle deliberate practice. This is what it is. This is the way I see rapid cycle deliberate practice. As you know, a rapid cycle was one of the methods that were created in Johns Hopkins Hospital by Dr. Beth. And this is the way I see it. And this was the way I applied during COVID, when I needed to teach more than 3,000 nurses how to use their equipment, how they need to contact and assess their patients, and this was the best way. The best way is when we detect something that could be done in a different way, could be improved, or when we would detect that when the students do something on the right way and according to our goals, we also need to stop and say to them, are you conscious about what you've done? Are you conscious that you do it in the right way? Because the majority of our students, they are unconscious about the things they know. And we need to stop them to acknowledge as also what they're doing in the right way. And the rapid cycle is something that you can use, and when we reach the final stage, which is the final interrupted scenario, I can give and I can have the idea that now, when I finish this scenario and give to my students feedback, the majority of them, they have the knowledge that they need to have to be in the clinical practice. How many of you finished a scenario, you received the feedback from your teachers, and then you had the feeling like, if I had the possibility to do it again, probably I would do it better? Why do not to give to them the possibility to do it straight away after our feedback? Why can we not just do a pause, do some directions, give them the possibility to be critical about what they've done, and then resume and go backwards and give them the possibility to redo it, to make sure and to tell them that they are able to do it and they can practice until they achieve the correct technical and non-technical knowledge that they need to have. The other one, and this is for more complex situations, and when we think about zone 3 or zone 4, when we mix complex scenarios with clinical situations, with technical, cognitive, and social skills, this is the spiral simulation. This is something that, this is my invention. This is something I invented because with my students, because I used to do very complex scenarios, and I had the same feeling that when we finished, we had a 1 hour debriefing, and they would tell me, wow, if I could now go back and try to do and improve my communication skills, if I could do my leadership in another way, if I could take decisions and probably do the decision-making process in using the tools that you've just shared during the debriefing, now I would be able to recognize that I'm capable to do it as well. So think about, for more complex scenarios, to do the same. Give them the possibility to do the full scenario, do the debriefing, and let them go back and do a specific part of the debrief of the scenario to give them the possibility to ensure that they are capable to do it. My final message for today, it's this one. Be SIM accountable. We need to be accountable, each of us, about what we're doing, even if we are students, if we are participants, if you are facilitators. Be always accountable about what you do in simulation, and especially inspire and be inspired as well. Because it's the most important thing is to share our knowledge. When we share our knowledge and the things that we are producing, it gives the possibility to save lives. And simply transforming, you can create and you can be innovative, but you can be conscious about what transformation is and how innovation is for you and for your colleagues. So this afternoon and tomorrow I will share with you some topics as well, so you're more than welcome to come and participate. I can assure you the next topics are not so theoretical. This was a little bit theoretical because we need to create some foundation. So the other ones will be a little bit more practical. And I would like to invite you, if you are passing by Europe this summer, we have the European Simulation Congress in Valencia, so you're more than welcome to come and participate. And the next invitation is for the rest of your lives. If you ever going to be around Barcelona, you must text me and tell me, because I will be more than welcome to show you not only the hospital, but also the university and be in contact with you. Thank you very much.
Really, the key to effective simulation training is preparation, not fear. By exposing learners to realistic, yet controlled stressors, simulation helps them develop resilience, adaptability, and ability to think critically under pressure. Thank you so much, Mr. Pedro. Your expertise and valuable insights have truly enriched our understanding and provided us with key takeaways. All right, so once again, a big hand for our honorable speakers. So as we are done with all the topics of this track, it's time for questions and answer. Are you ready to fire some questions? Speakers, are you ready to take in the bullets? If you don't have a question, we can skip this part and we can have a post question and answer session after the lunch. All right? Okay, lastly, to honor our esteemed speakers, I would like to invite Mr. Vinod, Director of Nursing, Vidyanta, Gurgaon, to the stage for the facilitation of our respected speaker. Everybody, please join me in welcoming Mr. Vinod. Thank you, Mr. Vinod. As we come to the end of this insightful session, I want to sincerely thank our distinguished speakers for sharing their expertise and valuable perspectives. I hope this discussion has provided meaningful takeaways that you can apply in your work and beyond. Wishing you a productive and inspiring rest of the conference. Thank you. Over to you, Joshua.
Thank you so much, Nikhil. Okay, so now we move to, and the murmurs are also like the stomachs talking, something like that. But I guarantee you, we won't take long before we all head for lunch, okay? But before that, very important sponsor presentation we are going to have. And okay. Excellent. So we are moving to the panel discussions. And very quickly, I'd like to welcome our esteemed guests for the panel, our panelists. And first up is Mr. Vinod Krishnakutty. And he's a healthcare leader with advanced management training from ISB and expertise in nursing administration. Director of the Year 2023 by Icons of Asia. His contributions to patient safety and healthcare innovation have earned him multiple FICCI and Business World Awards. Next panelist that I want to invite is Captain Sandhya Shankar Pandey, a distinguished leader with 28 years in military and corporate nursing, holding multiple advanced degrees, including certifications from XLRI and NUS, recipient of the 2024 Healthcare Leadership Award and Army Chief's Commendation for Disaster Relief Work. Now our final panelist, Dr. Bimla Kapoor, a pioneering nursing educator with over 5 decades of experience, authored India's first psychiatric nursing textbook, President's Gold Medalist and recipient of the 2023 National Nursing Teacher Ratna Award. She shaped national nursing policies and education. Can we have a huge round of applause for our panelists? And now, I would hand over to Shilpa to take us through this panel discussion.
Thank you, Joshua. Good afternoon once again. I know most of you are hungry, but just we have a half hour, right? Okay, so as welcoming you all for this panel discussion, the topic for the panel discussion is From Classroom to Bedside, Aligning Nursing Education with Clinical Expectations. And I'm honored to be your moderator for this crucial conversation. As we all know, nursing is a profession which blends both knowledge with hands-on skill. Yet, we all know the graduate nurses face difficulties when they are transitioning from the academics to directly to the clinical settings, right? So we have a esteemed panel of experts who will be share their insights on bridging this gap. I hope you all are excited for this. Yes. Yeah. Okay, so we just want an encouraging discussion. So I would like to just ask our panelists, as the organizing team had given me only 20 minutes for this. So I'm just going to tell you that we have to state, like for one question, you have around 2 to 3 minutes. Thank you so much. Okay, so now I'm going to start, or I'm going to begin my discussion. So I would like to direct my first question to Captain Sandhya. Ma'am, as we all know, you have a very rich experience across the premier health institution. I am sure that you have encountered numerous fresh graduate nurses transitioning into the clinical practices. Ma'am, I would like to know what specific skills do you think nursing graduates often lack when they first enter to the clinical setting?
Brilliant question, and I think you have touched the painful nerve of every educator and a nursing head sitting here in this room, and the laughter and the response is self-explanatory. But friends, contrary to your expectations, I'm not going to list what they don't have or what are my pain points. Me and Vinod sail in the same boat, but certainly I'm going to talk a fact. When I started doing my groundwork, sorry to say, but I did not find much facts within India setup, but brilliant studies done in the last 5 years came up. Way to go, but these facts include a wonderful study touching our pain points on the skills which are possessed by the passing out nursing graduates. One of the states, and this is Uttarakhand, eminent nurse researchers who's the principal of one of the renowned colleges of India today, one of the aims, but what it concluded was very interesting. It said that basic nursing skills and advanced nursing skills, being surveyed for nearly more than 200 nurses of the state, what it said that in the basic nursing skills where the competency was almost 94% for vital parameters recording, it was only 63% who were confident of charting it in the TPR chart. The nurses, and so in the basic nursing skills category, while the competency was good, compliance was good, but it was quite low when it came on to its documentation or its demonstration. Similarly, on the advanced nursing skills, the confidence level of the nurses on assisting on a central line insertion was only 15%.
But you'll be surprised to know the lowest was awareness of colostomy and stoma care was only 1.2%. So friends, this tip of the iceberg is not about the size and the sample. Brilliant size, sample size was great. But this fact is probably the story of every hospital, primarily in the private sector, the 74% in the country, right? So I would say the skills is not only on the clinical skills, but then again coming on to the cognitive skills or the communication skills. On the communication skills, again the group was very good to talk to. It was 94% compliant on explaining the procedures. But when it came on to initial assessment and admission at the time of assessment at the time of admission for the patients, it was only 73%. It further dropped when it came on to the documenting of that assessment. Amazing, I would say, analysis and the outcomes. Why it caught my attention, and I landed up discussing and learning all these parameters from the nurse researcher and who's a leader as on today, because this was an amazing, I would say, a great work which was done to give us some facts, some, burning facts, which we are able to give shape and give numbers and give some logic when we talk about our pain points. So it's a way to go. Only I'll sum up with only last statement is when the hospitals assert on, extend their welcoming gestures to the nursing institutes in collaboration and vice versa. The nursing institutes, please do be open towards the hospital and they empower the hospital team to assess the student nurses, give them tasks and inclusion, work on an inclusion model. So much so, only one experience, because on the extended internship, when the nursing students were given some case studies to present, within 1 month, the nursing institute disconnected their association with us. So what I'm saying is, this collaboration is required to make the nurses more job ready, because it's all about the skills which our patients needs and to strengthen and keep the profession going on. Thank you.
Thank you so much, ma'am. Your insightful perspective really helped us. Like, it's clear that only skill development is not needed. We have to go for the cognitive, right? And it is just the base for the fresh graduate nurses to entering into the workforce. Thank you, ma'am. Building on to this, I would like to bring in Dr. Vimla Kapoor, ma'am. Ma'am, you have played a key role in shaping nursing education. So I would like to ask you, ma'am, what are the barriers and challenges we have faced in the curriculum that affect and that prevent the effective learning?
Thank you. I do not know where do I stand now, sitting amongst these two people who are hiring and do not have scope to fire because we have less nurses. I do not know how much blame an academician has to take on it, because the curriculum, the recent curriculum which is developed, or the earlier curriculum which was there, it has got a lot of innovative approaches. I think it depends upon, which I always repeat, it depends upon the College of Nursing faculty, the way they deliver the content, the way they incorporate the practical examples from the clinical area, That's what I find is lacking now in teaching. What could be the reasons? Reasons are that, please don't beat me outside when I go all the private hospitals. The private hospitals, they have the colleges of nursing, but they do not want to give the clinical experience to their students for their patients, because their patients are paid patients. So they send the students to the government hospitals, which is already loaded with the federal government colleges of nursing and schools of nursing, because they are not the paid patient, but they are not human beings. Aren't they human beings? Now, it's a question of debate. I don't want to get into those. But if you do not provide the clinical experience to your students of the colleges of nursing to your own clinical setting, how are they going to learn? See, the government hospitals, federal government hospitals are very different. They do not have those kind of facilities like the private hospitals. That is one. Because the competency-based curriculum is developed. There are value addition courses, there are technological advanced courses added, the teacher training programs are being encouraged, the pedagogical approaches which are to be used are being, prepared for, like the modules are prepared for the teachers also. My first question to the Honorable Prime Minister was that when you are trying to say that you will open 157 colleges of nursing, from where are you going to get the faculty? So I said, in my white paper, when they asked me to give the comments, my 1-point agenda was, please let us discuss the white paper or a concept paper to prepare the nursing faculty who are already there, but give them a 6 weeks or 2 weeks or 3 weeks, a sort of freshen up program so that they are able to meet the need of the private sector. Because get associated with the private sector past so many years, I can understand what they are feeling, and their comments are not wrong. But I'm not going to take it as well, because the academicians of the private sector need to really work hard. Why AFMC Pune is never given a bad name? Why RAK College of Nursing is not given a bad name? So that means the mentorship program is done very well. The teachers are there in the clinical area. In AFMC Pune and in RAK College of Nursing, no student works for 6 hours on their own. But if you go to the other colleges of nursing, they do not have the mentors, they do not have the teachers. So that's one thing. I'll just sum it up quickly, because I know it's a lunch time and everybody wants to have lunch, To answer your question, the curriculum is so heavy. Everything we want to teach to the nursing people, more than 70 courses, more than value addition courses. From where are we going to get time in the semester system, to go to the simulation training? So I was thinking aloud when 3 of the speakers, they spoke very well, and it caught my attention that what we can do as teachers, or the principals and deans, that we do the procedures, teach the procedures normally to the students. And it is my learned experience way back in 1972. Then we conduct a 10-day simulation program for first-year students to repeat all the procedures on simulators, whether mid-fidelity, high-fidelity, that depends upon the institution. And then we let them practice on that. We have the high fidelity, but we do not allow them to touch it, We do not allow them to practice. So we allow them to practice under the supervision of the mentors, and then they develop that skill and strengthen the skills, the procedures, what they have learned. Same with the second-year procedure, medical surgical procedure, third-year pediatric, psychiatric experience. So we need to have an intensive workshop on the simulators along with the regular procedures. You cannot leave the regular procedures. They cannot learn in 10 days, My request to all the private sector, to all the people sitting over here, please do not take it for granted that the students coming from an institutions is totally prepared, I was talking to Vinod, whispering to Vinod, I do not know whether he likes it or not, but when you do the induction, why do you do induction only on policy making? Survey has been done. I do not want to name the institute. Policy making, how to make bills, how to send the bills, how to indent, how to take over, how to give over. Oh my Lord, do the nursing procedures. Why are we getting away from the nursing procedures, This you can put a one day to talk about these things. But the nursing procedures are not taught. I don't believe. In Berkeley, when I worked after Tangam left, we found that from Gorakhpur, the students said, ma'am, the teacher never taught us the procedures. When I rang up to Lucknow, one of the centers, they said, ma'am, hold the procedure-oriented skills for the teachers, the simulation for teachers. I agree with you, skill development and simulation is very different, and that concept has to be clear to people. So the teachers have never, they said, we have never gone to the clinical area to learn the procedure. Teachers never taught us. Students never learned. So we went out of the way for these 28 students, and we took, instead of 10 days, 15 days classes to teach them. So I think the administrators, the top guns sitting over here in this room from the private sector need to take a call that you cannot expect in 4 years that they will learn those, they will develop those kind of efficiency in skills what you expect. Then you say, then why do they come to us for after training 4 years what they have learned? That's another question you ask from me all the time. I agree with you, but then you have to slowly induct them. First day itself, after this so-called induction, you put them and hand over the patients. Very difficult. Okay? So this is my answer. Thank you.
Thank you so much, ma'am. Thank you so much, ma'am. Your challenges and the barriers will really help us to find the ways to support the learning and clinical applications, right? Continuing to our discussion for the industry perspective, I would like to bring Mr. Vinod. Sir, as someone who actively recruits and manages a very large workforce, you interact with many fresh graduates, particularly the Gen Z nurses, right? So what positive attitude Gen Z nurses brings to the profession, and how can we better support and engage them to ensure their growth meeting the needs of the work expectations?
Vinod, before you say, Madam, I want to correct you for one thing.
Yes,
you
ma'am,
say
sure.
that nurses need to have cognitive skills. No. If you remember the first day diagram which was taught to every student, cognitive, affective and psychomotor.
Yes, we need all three. Yeah.
So, I don't have a choice because she was my teacher.
Thank you.
So, maybe before I answer the question on a lighter note, one side I envy the simulation and simulators today. The other side I curse. Because I was a simulator, when I started my nursing, because I was the only boy. And during those times, in my class. And during those times, you don't have simulators. So I was made to lie down, without dress for a sponge bath. So that's the reason I curse. And the other reason for envy, I told you, what it is. So, Gen Z, so when we talk about Gen Z, I have two sons, I look at my son. And especially my younger son, both the sons, have got almost 7 years of, difference. My younger son, so the kind of opportunity what they have, for learning things in this world. Some of those things, even what we don't know today, they know what we learnt at the age of 30 or 35. That's the kind of opportunity they have. And we will have to agree and then go with they don't have patience. They don't have time. They can't wait for anything. So these are some of those things. There's no point in crying. There's no point in telling, that during my, morning, Tangam madam was saying that during my time. There's no during my time. I think we'll have to go along with them. Because I don't know how many of you have played chess through a simulation, computer. So that's the simplest thing. And that's not something, which started yesterday. This has been there for a long time. So what happens is when you play, chess through a computer system, because you have only one player and the other player is the system. So you lose 2 or 3 games. What do you do next? You know what was the move, which was done, my previous 2 things. So you start the move in that way. And that's the way. And healthcare, at least in India, I can say that healthcare is the last industry to move towards technology. We lag behind, lot in technology. I'm not comparing the Western world or Europe. I think in India, if you see, healthcare is something, where we see the acceptance of technology is something, we are at the last when we compare with other industry. Like, for example, if you compare with automotive industry. Now, simulators. I think simulation, I always compare, healthcare to aviation industry. Now, if you ask a pilot to fly a plane with 300 passengers without a simulation training, how many of you would travel? But it is okay for us to make a nurse, to practice on a live patient. We all agree. Is that right? So that answers your question.
Thank you so much, sir. Thank you so much, sir. It really helps, and your perspective just put a shade light on the evolving needs of the healthcare workforce and how we have to do for that. Now coming back to Captain Sandhya, ma'am, we have well received the first one, the challenges, right? Earlier that you have mentioned. Now I just wanted to know what changes do you suggest in the current nursing education system so that the graduates can be truly day one patient ready when they step into the clinical practice?
Patient ready on day one. And now you think that after listening all that, I'll dare to answer.
No.
Sitting next to Dr. Bimla. Ma'am.
But still we want a few, ma'am.
All right. Okay. But yes, the suggestions which I would like to give. First and foremost, they belong to us and we are responsible. And this is one thing, ma'am, I want to tell you.
whether directly or indirectly, every head of nursing in every hospital owns and accepts, provided in the, in their own world of governance and other systems, whether they are able to implement and demonstrate, display in their actions or not. But we know that we own them. First thing. Second, but my suggestions would go like this. First and foremost, nursing institutes and the hospitals. The current hospitals, let's get more friendly, gets more thickly associated. I will certainly urge the nursing heads to get involved into the clinical rotation, that what the student nurse is doing, and set the expectations on day one. It's very important. Don't let loose that, okay, we are your platform for clinical rotation, come and spend your time and go. Number one is this. So there is only one word for everything. When you go out with one message, look on the productivity and look on the outcome. Outcome is something we have to shift our focus on implementing. We have to shift our focus on outcome. What are we achieving and where do we stand? First. Second is build the faculties. Invest on educators. Can you raise, how many of you are nurse trainers here? Educators, right? From, my God, plenty. I think more than 60-70% people sitting in this room are associated with nursing training or nurse educators in the hospitals. Faculties from the college is something which actually is one segment which is not so commonly present here. So, bridging the gap on developing the faculties. Hospitals, we can always accept and open this opportunity and window for the hospital faculties to be more exposed, because this is another thing which is lacking with the educational institutes. And third is if implementation of curriculum, because if you ask the nursing heads, you will see their strength of implementing the processes in the hospital and measuring the processes. Everyone who's sitting here dealing with it will agree. But more important is, are we in a similar manner implementing our curriculum of nursing? Because I make an effort to stay connected with academics, and I would like to admit it openly. I'm super proud of our nursing curriculum, which was recently rolled out, one of the best in the world. Superb, and with amazing combination, fusion of practical theory, simulation, or be it the overall development of the student nurses. But how far are we succeeding in its implementation? Probably we need to understand what we are expected, and not leaving everything towards the college faculties, nursing heads, educators, everybody. As a nurse, I'm responsible for myself. So let me please teach this to the nurses. They need to understand what their curriculum is all about and make an effort from their own side on what they can do, apart from the schools, colleges, and hospitals doing their responsibility. So these would be the top three, suggestions from my side. Thank you.
Thank you so much, ma'am. Thank you so much for this valuable insight. As we all know, yes, we have to first, you can say, they strengthen our team to just make the students strengthen for their first day when they will just enter into the job. Thank you so much, ma'am. Now I would like to turn to Mr. Vinod. Sir, with your rich experience, as you have just mentioned before also, right, to Thanka ma'am, that we have to just go, like we are not from that time or this time, right? You have just encountered multiple generations, right? So if you are a step into a role of a dean at a nursing college, what 2 key strategies would you implement to ensure the graduates are truly ready for their clinical setting or day one?
So, Priyanka, I'm not too old. She tells that I've seen multiple generations. So, I think, with the world moving and the new AI things and coming, and there are a lot of people, within the team there are a lot of people, when I talk also, they feel that, when the AI or technology takes part, your human touch or human space is going to go away. No. That is not going, till the world is there, that is not going to go away. Now let me give you an example, like for example, the AI systems, So we were just trying a system, where in a OPD, every hospital has got a OPD, every OPD has got OPD nurse. What does this OPD nurse do? Yes? Vital signs? Yes? And the next thing is basically the demographic data of a patient, whether you are a smoker, do you drink, take alcohol, did you have weight loss and all those things. These are some of those things that, which is a question, which can be filled self by a patient also. Yes? Now, if you put a system, in the OPD, where you have multiple systems right now, where you see, through the circulation of the forehead, it picks up the temperature, the vital signs. Why do you require a nurse? Now, you could use this nurse, somewhere in an area where she'd be more useful, rather than doing this routine mundane task of, checking the vital signs. Yes? Now, people understand, it wrong and then think, no, if you put, that system, your nurse is going to move and your nurse is going to lose her job. No. At least I can say that next 50 years, no nurse will go hungry. Whether in India or across the world also. So, this is something that if I become a dean, of course, if I become a dean, the first thing is that I think, we've been talking since last 2-3 days about the simulation. I think there has to be regulations coming, from the government side also, to ensure that this has to be part of the curriculum, and it has to be ensured that these things are included in the curriculum as a mandate, not that, okay, choice us. It has to be mandate. The second thing, even, doing a simulation, is not something that which has to be done very expensive ways of doing it. You can even do minor things, over a smaller hospital or a nursing home. You still want, that's even a life. As ma'am was talking about, a patient in the government hospital has also got a life. Not only a patient who is in the... So, patient safety and patient care, whether it is in Vidyanta or it is in a Safdarjung hospital, is same. Safety and care and experience is same. There is no difference. For a nurse, it's the same. So, I think we will have to find out, ways of doing it. I saw one of the slide in, I think in Pedro's slide. Low cost and high impact. I think that is what, we will have to work out. And there are industry players who will be partnering with us to do, these things, and then ensure that is the way we move forward, in the healthcare sector in India. We have huge opportunities, but we'll have to figure out those things and then move into that right angle and then ensure that our patients are safe. Thank you.
Thank you so much, sir. Thank you so much. Your insight will really help us to prepare our nurses from day one. Okay, again, with all these challenges and strategies, I just keeping in all these in my mind, the topic for today's panel discussion was from classroom to bedside and aligning nursing education with the clinical expectation. I again wanted to come to Dr. Vimla Kapoor. Ma'am, like this, with the given evolving needs of the clinical practice, as a facilitator mission, what 3 major strategies you implement to overcome these challenges and better preparing nursing students for the real world clinical practice?
Thank you. I think I go back to Patrick's slide where he had, I think, 7 squares. One of the square was mentioning about preparation of faculty and clinical immersion, The nurses have to be placed in the clinical area with good mentorship, good preceptors. And these preceptors have to be consistent. Because if you change, today you put the student, 9 students or 10 students, 1:10 ratio. If you put in the medical ward and tomorrow you say that, oh, surgical ward teacher hasn't come, let me transfer the teacher there. That means the continuity of learning from the preceptors to the students gets violated and they are not able to have the continuity of learning. So a consistent preceptor, and also he had mentioned in his slide about updating, faculty development. So preceptors and these mentors need to be given chance to update themselves, Though in clinical area you learn a lot. Believe me or not, when I wrote my first book, I gave the example of NIMHANS. Some of you friends are from NIMHANS because I had rich experience in NIMHANS for 1 month as a student. But otherwise I could not get that kind of experience in AIMS because, mental health was just coming up as, indoor beds. So the preceptors have to keep updating their knowledge and bring those live examples in the classroom teaching. So the first is the clinical placement with consistent preceptors, and those preceptors should have updating of their knowledge and skills, There should be structured placement of the students. Today there is a strike, so nurses are not there in emergency, so let us put all the students in emergency. No. We refused this to the Ministry of Health way back in, I think, 40 years back. We refused when there was a strike that students will not be placed. We told the teachers to go and work there, because students have their defined curriculum and we cannot take them out just so. Then we say, let us equate that experience to medical surgical. When they are not working in medical surgical, they are working in community health. How can you equate the experience of community health to medical surgical? So that consistent placement, structured placement with clear objectives of the learning experience is also very important. Then feedback and evaluation. Feedback and evaluation, the mentors are there to get the feedback and evaluation, but the feedback and evaluation should also be done by the clinical people who are there. Say we have the nursing officer, we used to call them as ward sisters, We have the nurse educators now. Now if the students are being posted in the clinical area where the nurse educator is there, or we have the team lead, or we have the senior clinical nursing staff, we have to take feedback from them also. It's not to improve the students in their clinical performance, but as teachers we also improve that where learning is not going right, So that's very important because the practice has to be very significant. Practice part has to be given emphasis. I do not know where it got diluted. So many of my friends and students are sitting over here. The clinical was always given importance, We left the hostel at 6:30. We were there in the ward at 7 o'clock. We came back at 12:30. We had our lunch and rushed to the classes for 3 hours. But 6 hours we were in the clinical area with our students, and we gave guidance to our students. We took the examples of clinical into the classroom. Believe me or not, case studies, case presentation, simulation. It was not simulation, it was skill-based, I agree with you, but we called them as simulators because we had little higher simulator in RAK College of Nursing because it was a Southeast Asia first college of nursing in the country. So we had little better dummies, you may call them, but we call them simulators. But those kind case presentation, real-time learning, we brought it to the classroom. The student, if you are teaching about nursing management of patient with myocardial infarction, we knew which student was in the medical nursing ward who is looking after the myocardial patient, infarction patient, and she gave the example. We asked her, necessarily does not mean that all the symptoms will be there, but at least they had real-time learning that was there in the clinical area, and that's what there is in the books, So that's very important. Of course, communication, they mentioned, is very significant. Believe me or not, way back in 1995, we had a discussion. The doctors never had the communication skills course. When we discussed with them, they started 30 hours on communication skills course. Whereas in nursing, we have communication skills course in first year, second year, third year, and fourth year. The question is how the teacher implements those strategies and tries to explain to the students, and try to involve the students from first year onwards, how to go and talk to the patient. Oh my Lord, we had all this demonstration of talking to the patient, what you do it in the high fidelity simulator and come back for debriefing. We used to have a teacher sitting in the classroom, the senior teacher sitting in the classroom to observe the junior teacher, how she is quoting the examples from the clinical, and then we would get the feedback from the senior teacher. Those were the strategies used to improve the, So these are three main things I would like to say. Students' placement in the effective areas and structured with objectives, with good mentorships, good communication skills and collaborative efforts so that they learn what is there as a team. Feedback not only from the teachers but from the clinical area, and we always practiced, some of us, you would remember that if the OT nurse was available, we will bring the OT nurse from the Safdarjung Hospital to RAK College of Nursing to take classes for the students, because OT nurse will be able to explain better than me not going through the OT and teaching about OT techniques. So I think I quite agree with you that clinical, how do we bridge the gap? Probably let us take through any OT, NAI this, how do we bridge the gap, so that the clinical from the hospitals also come as a guest faculty in College of Nursing. In internship, we do invite. In internship, the clinical people are invited to talk to the TNI is invited, many people are invited, but we invite the experts also to talk about what is expected out of you when you complete internship. Thank you so much.
Thank you so much, ma'am. Thank you so much. I hope these strategies will really help our delegates, because most of our delegates are from college background, like academicians, faculties, and the nurse educators, right? And also for the MSc students who are going to be educators, right? I hope you will include all these strategies which we are mentioned by our panelists. Thank you so much. Now the stage is open for question and answer session from the audience. So you can ask. Yes.
Hi, Srikanth here. So while we are talking about bridging the gap from classroom to the practice, there is other, what do you call a situation here where the interest for students joining the MSc course is gone almost. Almost every college other than the government colleges are struggling to fill MSc. When we go to the final year students and ask how many of you are going to pursue a higher education, not even 1% is raising hands. So, anybody, it can be anybody. So, might be like Captain Sandhya said, I think there will be a situation in the future where hospitals will have to help the colleges by providing faculty members. When you are talking about empowering faculty, what about the issues faced by the colleges where there's a shortage of faculty?
All right. If I've understood your question correctly, Mr. Srikanth, what is the challenges faced by the colleges as far as skilled and competent faculty is concerned? Isn't it? You said you had given a good context.
The future of the nursing colleges,
future of the nursing.
If they are not getting faculty, see, schools have a formal teacher education qualification to become a school teacher. Somebody has to do a B.Ed or M.Ed, they need to come. Okay. But here there is no MSc students itself in the future. How will a college survive?
Sorry, so I differ from your statement. First, and so I'm putting it into 3 sections. First one is, no, MSc is still sought after. Irrespective of its qualitative outcomes and productivity, MSc seats have increased phenomenally in last 10 years. Pull out the BCG paper which was published in 2023, September. And GAPIO and BCG has, I think Mab Thangam was again a part of it. And there were a couple of people, from nursing who have aggressively contributed research because it took 1 long year to get ready. And it's a white paper of reshaping and, regaining momentum for nurses in India. So first one is MSc nursing. Government has done its bit on increasing the seats, number 1. Number 2, enrollment of students. Yes, certainly. Now, as far as nurses, new nurses and younger nurses are concerned, that is Gen Z or millennials, it takes time. They get into profession for 2 to 3 years because they pay significant amount of fees for their graduation. After a couple of years, they realize that when the understanding is there for the growth and progress in the profession, certainly that's the time they go for MS post-graduation or even before that. It's clear, actually, the number is increasing. Now, next point is faculties, whether the MScs are going for faculty or not. So that's a different story, but more importantly, availability of skilled and competent faculties. And I would say appreciate our country and the changing norms in the society. It's thanks to the private sector, 70% in the country who's actually thinking a little differently, not waiting for us to come back in the evening. No. We have started to engage with our industry partners because the type of expertise, Mr. Vinod has already, elaborated upon it. The type of expertise and different type of knowledge, as well as, the perspective which is brought to us by the industry partners is phenomenal. And you yourself will realize that this, this importance, this association has strengthened in last few years, most probably. And if we say, to be specific, after COVID, after the pandemic, when the virtual and the digitization has actually gone in an accelerated mode.
So this is the second answer to your second point, is leveraging the strength of the industry partners. It's a different story whether to what level and what level of decisions are being taken in the organizations, in the healthcare organizations, but this value is certainly surfacing and displayed in a very, I would say it's a very commonly in today's healthcare. Third important point, yes ma'am, and third one is about the availability and partnerships. So probably it's all about people like us and you sitting here and aggressively working and converging towards the main goal on how do we shape it. It's too individual, too specific, but certainly I think enough tips have been shared about it, right?
I quite agree with you, Srikanth, because I have heard a lot. There is a mushrooming of colleges of nursing, mushrooming of non-attending MSc nursing courses. So regular colleges of nursing are not able to get their seats filled. Rampant number of increase of seats, without realizing that whether that particular geographical area requires so many MSc nursing. Like I am the chairperson by the Ministry of Health and Government of India to work on skewedness of colleges of nursing and nurse-patient ratio. 2 years have passed. It's all voluntary. Not a penny is being paid by the government. We have not got data from the government so far. But we know what you said is correct. So many colleges are getting closed because they are not able to fill the seats. Right in Delhi, talk to Holy Family, they get, but because they say the fees is high. So people are not able to get, even in the ILBS, the seats are not getting filled up. I'm talking of Delhi scenario and Karnataka and other places, because there are so many colleges of nursing. Nobody is giving importance to that because you are getting non-attending. You are not even attending any course. I, on the interview board of several selection committees, when I asked them what is your MSc nursing thesis topic, they said we don't know. Some of them honestly said, Madam, somebody did for me in an interview board, just because they think they can trust me. But this is an interview board. Where are you talking about it, They don't know. They've done PhD. Non-attending PhD without submitting thesis, they do not even know the topic of their thesis. So where are we? Where are we in terms of legislative bodies? What are we working at state level? It is, see, Indian Nursing Council is a national level. Now the commission will come. I hope we are able to strengthen more and more. But the State Nursing Council, they are encouraging these kind of things, So the number is decreasing because of non-attending. If the person can have a non-attending MSc degree, why would they come to your college and pay lakhs of rupees, So there are quite a number of issues, Dr. Sandhya, for this. So only thing, I really thank our private sector, because 85%, she said 75, I always quote 85%, 70% or 75%, they can give the designation. They can give, they are able to pick up the right kind of a person who has done MSc nursing and has a quality to give to the nurses and also improve the patient outcome. They are able to give the position. They don't have to wait for evening to get the order from somewhere, which is not true in the government sector or colleges of nursing. There are so many issues on this, but I quite agree the seats are not getting filled because there is a reason. We are encouraging mushrooming of colleges of nursing. But if you raise the point, nothing happens because it's all by the people who can influence. I hope the NNMC, we are looking forward for a month more. If it comes, it is not going to change overnight because regulations are to be made. Rules are made by the government, regulations are made by the nursing people, So regulations are to be made, notified, but at least some control will be there, in the transit period. So I can empathize with you, that's all at the moment.
Thank you so much, ma'am.
Yeah, maybe I have a slightly different view on what both of them said. You're right, absolutely right. And why does that happen? Now, if a nurse, has completed her GNM or BSc, you're putting money into her pocket. Do you expect her to work without money and go and sit in a classroom and then study for 2 years? How many of you would go? Not a single person. Even if you ask me, I will not do. Why can't our programs be, a residential program? A doctor who's doing a PG, he gets first year salary, he gets a second year salary, he gets a third year salary. Why can't a nurse get that? So the nurse going into the college, first year, yes, she does her clinical work, she does her education also, academic work also. Why don't we have programs like that? I still remember, madam is sitting, and thanks to her, for starting the post-BSc program, from IGNOU. This was a long term, long since pending, that. Otherwise, if you go back 20, 25 years back, and I was one of the person, who did the post-BSc, from. So if you see, you had never opportunity because you do a GNM program, then you go and again spend 2 years, in the college spending money without even a single penny in your pocket. Then you go for another 2 years for MSc. This is not going to work. This will not work. So that is the reason. Now, the colleges and the state nursing councils have made this as unofficial, official of non-attending. Why don't we regularize that? Why don't we regularize that? And then say that, okay, go do, non-attending, you are supposed to go and attend, the classes, and then do a practical session, and then do that, and then, so people also will earn their salary, they will also improve their education, seats also will get filled. The government, opened a NPCC program, right now. Now, we started the NPCC program at Vidyanta. We pay salary, to the nurses, they're working also, and they're doing a study also. So I'm sure that not a single nurse will move out of that, saying that, no, I'm not able to study and work. That's the time, they would be able to do hard work. So if we do these kind of changes, definitely you will see improving nursing standards in our country. We still go with 40, 50 years back, no, it has to be a regularized, it has to be a classroom program. Why should we have a classroom program? How did we do, nursing during COVID times? Still there. We still do our meetings, Zoom meeting, where people are sitting somewhere else and then we don't go to US and then do a meeting. So I think, these are some of those changes which has to come. I think NMMC, I am hopeful that these kind of changes would come. And then these are some of those things which will change the stature of nursing in our country.
Thank you so much. Thank you so much,
Excuse me.
panelists.
Excuse me. Here, this side. This side. Can I, with the audience permission, can I take 1 minute?
Ma'am, actually, really sorry, we are running late. Ma'am, we have a time limitation.
One word I want to tell them.
Okay,
See,
ma'am.
post-basic BSc nursing education program was miscommunicated by saying that there is no clinical work. There was defined clinical work where they did independently with proper guidelines for each clinical work, and also there was supervisory clinical experience. So it had a blend of both, but students did not have to leave their job and come. Thank you. Sorry.
Okay. Thank you so much, ma'am. Thank you to our esteemed panelists as well as our delegates. So let's continue working together to build a nursing workforce that is competent, confident, and ready to meet the challenges of the modern healthcare. Isn't it? Okay, so I would like to call Dr. Jack on the stage to felicitate our panelists. Thank you so much. We'll start with Bimla Kapoor, ma'am. Dr. Bimla Kapoor. अरे यार नाम तो बहुत बिगड़ कर रहे हो. Okay, thank you. Dr. Bimla Kapoor, ma'am. Captain Sandhya Sankar, ma'am. Thank you so much. Thank you so much. Thank you so much, team.
Can we have a final round of applause for the esteemed panelists? And we thank all the panelists for the grateful, very insightful discussions, and at times even heated observations. But this is what this wonderful conference is about. So now, very quickly, we will move to lunch, for lunch. But remember, let's focus on lunch so that we can come back here on time at 3:15 p.m. IST. So be mindful of the time, right? And time for photography you will get later. So concentrate on lunch, and then we'll be back here on time at 3:15. The next session. Time of the day in this third session. Okay. Request everyone to settle in and take their seats. Thank you very much. Now it is time for a very special sponsor presentation. And this sponsor presentation is going to be by NASCO Healthcare and KK. And for that, I'd like to call on stage Mr. Manan Kalia, who's the Global Sales Director, International Market at NASCO Healthcare. Can we give a good round of applause to Mr. Manan Kalia?
Thank you. Hello. Hello, everyone. Only 10 minutes? Okay. No. Coming. My laptop. Okay, yeah, this is the one, yeah. Since I was given only 10 minutes, I have made it as short as possible, okay? But if I go long, please bear with me, okay? So just to give you an idea about who I am, my name is Manan. I am born in Delhi, stayed in Delhi my entire life, and then I decided to move out. But I have grown up in these streets where I am today. So I am really happy to be back. And I thank Vidyanta for hosting this event to give me the opportunity to come back to where I was born. I look after the global operations for NASCO Healthcare. NASCO is an international company manufacturing simulators. So like previously, you guys were looking into how simulators work and everything. We are the ones who make them, and we thank you for buying our products as well. Just a small recap about the company. At NASCO Healthcare, our vision is to make the world with better patient outcomes and fewer lives lost. And we follow a motto of be ready. So be ready meaning like we are making the healthcare professionals to be ready for any kind of situation, wherever, whenever they are called on, to take a split-second decision, to deliver when it counts, and ready to save lives. So a small, like you can say, a motto that our company likes to follow, and that's what we do. We don't want to go into, the products and all these things. So we just want to focus on certain initiatives that our company has taken in order to enhance simulation in healthcare. So we love technology, okay? And we try to make that technology as affordable as possible, right? And we are also making that technology easy to use. So we don't want to give you too much things and then it's very difficult to use. So we do have a big team of developers who sit down and do all their things, and thus sales guys come out and sell it out. So I will not bore you with this, and just come to the main product that we have over here, just to give you a glimpse and showcase it to you. The product is called Alex, and it is using Gen AI, the latest. You all know about ChatGPT and all these tools which are there. So it is not using ChatGPT, it is using its own algorithm and own engine, using generative AI in collaboration with Google. So we are able to develop that communication skills which require for a nurse or a medical practitioner to communicate with someone. So it helps in reducing communication errors and enhancing patient outcomes. So what it does, it just offers you the realistic simulation. So you have a capability of performing a realistic simulation, how you will talk to a patient and how will you communicate with them, how will you behave in front of them. That's all is possible with this. It can understand all accents which are there. We all speak in a different way. We all have a different way of asking a question. So it has a capability to synthesize. 99% of the time, it gives you a positive response. Okay, 1% you can blame us. It gives you an instant feedback. So it's not only helping you communicate, but it also giving you a score of it, like how a communication is happening. So for an instructor, you don't have to be present in the same room when the student is performing a simulation session. You get the score. This can be used later on for their debriefing and evaluation purposes. Scenario customization. This is one of the key things which everybody requests, and how we can make it easy where you don't have to pay a lot of money to do it. So we have only made 7 points where you feed your information in, and then the scenario gets ready based on the situation that you are looking for. You can upload any data that you prefer into a particular scenario. And everything is data driven. So with the data, you are able to evaluate a student, how he gets better over a period of time. So my messages keep popping up. We will just show you a quick demo on the product, how it works, how the communication happens. And then if anyone has any questions, we can go more into the details of that particular feature. Everyone can hear me? Okay. So this is Alex. Right now I am using a scenario where a patient has chest pain, and I have loaded it before just to avoid any complications with the technology that can happen. So I have tried to do that before. So in this, a patient has walked into the ER and he is complaining about a chest pain. I am not a doctor or a nurse. I just have a few questions which I remember over the demos that I have done. But you have a capability to ask any questions that you would like to do. So I will just start my normal conversation with it. So maybe we can, just 1 minute. We can, this doesn't work. My laptop froze. What can I do? No, the mannequin is working. I'm trying to load the software so you can see it on the screen. No, this is... can he remove it from his... Yeah, no, it's okay. No, it's okay. Because it is showing over. No, it will show. Can you So this 2 minutes gets deducted, huh? So I don't count me on this 2 minutes. Hopefully it will work. It's Google Chrome is not displaying. It's okay, let it be now. Okay. Yeah, okay. So it's working now. So this is just an interface which we are using on Google Chrome. So no software designed by us or by anyone. You can just use your own phone, open a Chrome, and you can start using the software. So like more affordability and more ease of use is there. So I will just start a normal conversation with the patient and let's see how it goes. Good afternoon. What's your name?
My name is Alex Arkazian.
How are you today, Alex?
I'm not feeling too good. I'm having some chest pain.
I'm so sorry to hear that. Can you explain to me?
Thank you. I appreciate your concern.
Can you explain to me what's happening?
I'm not sure, but it seems like my chest is being squeezed and it's hard to breathe.
Can you describe the chest pain for me?
It's like a squeezing weight on my chest, with tightness all over.
Okay. Does the pain radiate to any other part of your body?
It's in both sides of my chest equally. The pain also radiates to my back, left shoulder blade, neck, and jaw.
On a scale of 1 to 10, can you rate your pain?
It's a 6 out of 10.
Okay. Does anyone in your family have a history of heart disease or chest failures, heart failures?
Yes, my father died of a sudden heart attack.
Okay. What about your mother?
I don't know anything about my mother's health.
Okay. Do you smoke?
No, I don't smoke.
Okay. Do you have any history of medical illness?
Yes, I have high cholesterol and high blood pressure.
Okay. Did you take any medications?
Yes, I take Crestor and lisinopril.
Okay. For the chest pain, did you take any medication before you came to the ER?
I didn't take any medication before I came here.
So similar to this, I can keep the communication going and I can get a score out of this particular session. So this software is able to recognize and give you a score on what went right, what was the right question asked. If something was not right, it will not give you a score. We don't have negative scoring because of the impact it has on the student, so we don't do negative scoring. But it can be done if it is requested by the institution. Similarly, this can be a female as well, a female voice, so you can perform female scenarios which are required for. Similar scenarios can be for a female, but if you have other scenarios that you would like to develop more decided on the local region, that can also be implemented. It has capability to speak Hindi at this point of time, but it is still in the, you can say, initial stages that it's being worked on, but in the next 2 months, it should be up and running smoothly. Additionally, it's just not a communication tool because you cannot just go and buy a mannequin which just talks, right? So you have a capability to do patient assessment on this as well. So from head to toe, you have a capability to do a patient assessment similar to, let's say, auscultation. Let's see if we can hear something. Huh? It's okay, it's okay. So we have a capability for like auscultation, heart sounds, lung sounds, bowel sounds. You have a capability for the pulse, blood pressure on both arms, IV, nasogastric tube feeding, catheterization. So that scenarios can also be performed. Intubation can be done. Okay, so it's decided to work now. So, so actually I didn't know where to keep it. So it just by luck it worked also sometimes, okay? So when you have the right product, luck supports you, right? So this is the situation, okay? So like, huh? So the product works through internet, so we always need an internet connection to make it work. It has a camera present in the eye, so you have an actual PO view of how a student is behaving in front of a student. You can record it, their way of behaving, the way of they dress up and everything can actually be taught to the student as well using this, okay? So I was asked if we can have like pain scenarios also, so we have certain sounds which are there, but it can be linked to the particular scenario as well for the pain as well. So I think I'm good, yeah? Okay, perfect. So we do have other products as well, but because of the time, and I don't want to bore you as a sales pitch over here, so that's the reason why I'm cutting it short. But please do come and meet us at our booth, and then we will be able to showcase those things to you. Okay, thank you. No, it is, we should switch it off. Thank you so much. Yes, you can rename him, yes. As anyone, not as a brand, it will stay the same, but like you can name it and to your own, when you are creating the scenario, you can name it as well. Not Manan, yes. We have a different product coming with my name. But it can look like me though.
Can we have a huge round of applause for Team KK and NASCO? Now, to felicitate our guests and our sponsors, I'd like to call Dr. Jack from Thailand to come and felicitate our sponsors.
Yes, I know in Thailand. With 4 them, right? Yeah. No, this. Okay, yes. Thank you.
This is also yours?
Yes, this is ours, yes.
Thank you.
This is ours as well. Thank you.
Thank you so much. Thank you so much, our sponsors. And we wonder many times what would we do without our sponsors. So thank you very much for this special presentation. And I'm sure you all enjoyed the performance of not just Manan, but also our dear friend Alex. Moving on, we are now entering track 3. Okay, it's one of the major sections that we have for today. And for track 3, which is called Integrating Simulation into Nursing Curriculum, first up, I want to talk about and introduce our speaker for this, that is Dr. Desiree A. Diaz. Now, Dr. Desiree A. Diaz is an endowed professor at UCF and immediate past president of INACSL. Dr. Desiree A. Diaz is a pioneer researcher in simulation pedagogy. Her work with hologram technology and focus on health equity has advanced nursing education globally. I now hand over to our moderator, Ms. Sonia, as we will listen in to Dr. Desiree.
A very good afternoon to everyone. My name is Sonia Herbert, and I have the honor to being your moderator for this session. Welcome to Track 3, where we will explore the integration of simulation into nursing education. Simulation has transformed nursing education, bridging the gap between theoretical learning and hands-on practice in a safe and controlled environment. We have an esteemed lineup of speakers today who will share their expertise on simulation-based learning, innovation, and best practice. Without further delay, let's dive right in. Our first speaker, Dr. Desiree, who is highly respected expert in healthcare simulation. She will be introducing the INACSL healthcare simulation standards of best practice, which serve as a foundation of high-quality simulation in nursing education. Although she is not physically present over here, as she has been deeply involved in this conference and has made the virtual present to share her insight on this essential topic. Please listen her carefully because it is very, very important session.
Hi, and welcome to SiMCON 2025, Understanding the Healthcare Simulation Standards of Best Practice. I'm Dr. Desiree Diaz, immediate past president of INACSL, or the International Association of Clinical Simulation and Learning. I am a professor and endowed Infamedia Scholar at the University of Central Florida College of Nursing in Orlando, Florida, in the United States. I have a couple disclosures. As I said, I work for the University of Central Florida, and I'm a family nurse practitioner seeing patients 1 day a week. I also have unspecified grant funding, and I serve on multiple accrediting and reviewing boards and bodies. The objective of today's talk is to review the history of healthcare simulation standards of best practice and distinguish criteria for program endorsement. So let's start by saying welcome. How exciting to be a part of this inaugural event in India. It's exciting to think about best practices and how great simulation continues to grow and develop with simulationists like you and me. So first things first, there is a QR code that takes you to free access and free sources for the healthcare simulation standards of best practice. I'm going to talk to you today about an overview of those standards and how you can demonstrate that you're doing best practice. So first, let's do a little brief history. In 2009, the INACSL Standards of Best Practice Simulation were started or formed. The first set of standards were published in 2011 and have been currently updated periodically. In 2023, 4 additional standards were added with systematic reviews. So all of the standards of best practice are evidence-based, and you can use those to support your work, whether you're presenting, publishing, but just at a basic level, knowing you're doing the best simulation possible. So there are 10 standards. We're going to go through each of them with a big overarching overview, okay? So professional development. There's certain criteria, and when you link on the standards, you're able to look and see each specific criteria. So the infographics that are here for you are also free for your download to utilize on the INACSL website. The criteria helps you meet the standard. So professional development looks at the educational needs of ongoing professional development, which supports a simulationist, whether it be a nurse, a doctor, a nurse anesthetist, a doula, anyone providing healthcare simulation. It helps advance the current practices. The practice of simulation-based education grows the professional development of the individual. It allows to stay current with new knowledge, provide high-quality simulation experiences, and meet the educational needs of your learners. It's also important to document what you do. This is a session that you can document as professional development. Simulation design is one of my favorite objectives, and thinking about how do you design simulations? Is it just because there's something bad that happens or a sentinel event and now you create a scenario? Or are you following steps and practices that allows you to design evidence-based simulation and being able to update it? So when you look at that, subject matter experts are needed, not just in simulation content, but the content in which you're delivering. Oftentimes, the simulations that I create might be out of my practice, providing care for a patient, but then I send it to someone who knows best practices in simulation, and then I'll also send it to somebody else that knows the content so that any biases are pulled out. Performing a needs assessment prior to administering or delivering a sim is important. In the clinical or hospital settings, oftentimes that's based on you notice a gap or poor patient safety or disparaging or disparities noted amongst different groups in the settings. Think of objectives that are measurable. Are they SMART? So they're succinct, they're measurable, they're attainable, are they timed? Are they reasonable? Can somebody really get through the sim? Looking at then, you have your objectives and picking the right modality or the mechanism in which you're delivering that sim to make sure you're able to meet the objectives of the sim. Designing a scenario provides that context for the learner to say, ooh, I read that, I saw that, and now I'm going to learn from it. Looking at different types of fidelity, so not everything has to have high technology to have high fidelity. So just because I have a mannequin that breathes, blinks, maybe reaches out at you, doesn't mean that that's what's needed. Can you have a high level of realism without having a mannequin that requires so much external resources? And the answer is yes, but you have to design the scenario based off of things that you have available, as well as, am I able to meet the objectives? Thinking about it from a learner-centered approach allows the learner to direct and guide the learning. Thinking also, when I'm creating the sim design, it's really from the nuts and bolts, the beginning to the end. I'm looking at the objectives, and then how am I going to evaluate that scenario? And last but not least, pilot test. When you pilot test the scenario, it doesn't put the learners at risk because you want to know that the scenario is measuring and delivering the information that you want. And the best way to do that is run it through one time with maybe it's the first group of learners and then adjust what worked, what didn't work, and then change it. Outcomes and objectives, that's also in sim design, right? So you'll see in sim design, it links to other standards where it really drills down to more specific. So educators, clinicians, and researchers utilize outcome measures to determine the impact. So what is the impact of that scenario? Objectives are guiding tools to facilitate achievement of those outcomes that you're looking for as the educator. You might wonder why outcomes are listed before objectives. This has to do with the principle in instruction and working backwards, starting with the student learner outcomes first. What do you want the student learner to do or to achieve? And then making sure your objectives match that. So consider things that are essential to learning. Outcomes are a measurable result of learners' progress towards meeting a set of objectives. Objectives are the blueprint for the simulation design and the guiding tool to facilitate the achievement of learning those outcomes. The standard encourages, as I said before, SMART objectives, and when you download the full standard, it gives you a list of resources as well. So specific, measurable, achievable, realistic, and time-phased appropriately for the learners within their curriculum. Is it where it needs to be? Are they having the pre-knowledge needed to be successful? Objectives should be written on that appropriate level going forward also. Evaluation and learning and performance, again, thinking about the end in mind, determine the method of which you're going to evaluate them. So is it formative? Is it summative? Is it a cumulative evaluation of performance? So I think of formative, it's forming learning. Summative is it's the summary of everything that they've done, like a big test. And then cumulative, it's everything all together and all in one. The goal of a cumulative assessment might be student achievement of program goals rather than something specific in a formative assessment, such as you need this simulation prior to understanding how to do this simulation, so sort of scaffolds or builds upon each other. Simulation enhanced interprofessional education, I believe this is being done a lot more than we take credit for. The standards ask us to use a theoretical and conceptual framework in creating interprofessional experiences. So although I'm a nurse and an advanced nurse provider, that doesn't mean that when I'm interacting with other professions such as social work, medicine, that all of my objectives are going to be the same as theirs. So when you're developing scenarios, best practice is really to have collaboration from all the faculty and all the learners have someone that is associated with their curriculum, because then they know where the learning should take place and are those objectives obtainable. Collaborating faculty should consider multiple scenarios and opportunities for the learners to meet the outcomes. There can be some barriers also with interprofessional education, such as timing, scheduling, lack of commitment, but also clash of domain of certain things. How I might manage a patient in pain might be very different than a doctor of medicine managing that patient in pain compared to someone in physical therapy. So thinking about coming together interprofessionally. Now, operations, I use this as my blueprint. It's the criteria for organizational requirements, strategic planning, but also short and long-term goals. Does your facility have the appropriate items, resources, pathways for your program to be successful? It includes budget and finance. I like to use the operation standards to support what I'm doing when I go to leadership and administration as providing the evidence in which I need to get the things I want and desire so that learners can obtain optimal outcomes. Now, those standards are all important and all needed for a complete loop of best practices. But then there's the cornerstones of best practices, what I say are the foundation. So if you're feeling overwhelmed now, focus in on these four, and I'm gonna go into depth with these four. The first one is pre-briefing, preparation, and briefing. According to the most current literature, pre-briefing is referred to as both of those. It's the purpose of pre-learning, or what happens prior to the start of the simulation, including the preparation learners are required prior to coming in. Deliberately designing preparation materials is important. It decreases cognitive load and stress related to, I don't know what's going on in this simulation, because they don't have information going into it. They don't have that time to prep. High-quality simulation requires simulationists and educators who are knowledgeable in the pedagogy, including that pre-brief phase. It helps learners succeed with a variety of activities because they have an understanding of what's going to be required prior to them getting there. Now, facilitation. This standard emphasizes what preparation a person needs to conduct simulations. It's important not just to throw anyone into a simulation and tell them, oh, go teach these learners with simulation. They need to have an understanding of what are the must-have skills in order to effectively reach your learners. Identify the approach based on the participants that have come in. So there's a little fluidity, there's a little bit of being able to understand the skills and knowledge that your learners need to obtain, but also how do you use your skills so that they are successful. Facilitation is also about predetermined cues. It's not giving all the hints. Oftentimes we forget that a beeping sound is a cue. Maybe I would have never thought to look at the respiratory saturations of oxygenation on someone's blood unless it's beep, beep, and then I turn and I look. But what happens if that cue wasn't there? Would they recognize patient deterioration? All of that has to be thought about before your learner comes to you, and that is why the facilitation standard is so important. It should be standardized across the board so that you and I can deliver the same content at different times, but the learners expect the same quality. Now, professional integrity, both the facilitators and the participants need professional integrity standard to feel safe about participating in simulation. Honoring the Healthcare Simulations Code of Ethics provided by Society for Simulation and Healthcare, and that's free on their website as well. Having clear statements about how those ethical principles are conducted and part of the standard. Creating a safe learning environment. It's safe for me and safe for you is what I tell my learners. Meaning, if I've made a mistake facilitating the sim or with the mannequins, I'm gonna let them know during or after the debrief. The same thing as them, they should be comfortable enough to say, I don't know, I don't really know what the next best action is, but I chose this action because. And it also requires a level of confidentiality. No one wants to think that their learning or their gaps of information is being broadcast to everybody. How comfortable are you when you don't know something? If I were to give you a test right now, didn't tell you ahead of time what the test was, how you're going to be evaluated, and then you did poorly on it, would you feel comfortable if I took your results to your boss and said, wow, look how this person performed? That's not really fair. That doesn't make me feel welcomed or willing to go to the learning environment. And last but not least, the debriefing process. This criteria is one of the most influential. It's considered by some the place where a majority of learning occurs. It's not actual participation in the scenario, but the ability to talk through what happened during and afterwards. It's peeling back the onion peel of someone's understanding of why actions took place or didn't take place. It allows the facilitator to step back and ask the right question so learners can explore their belief systems. Now, all 10 of those standards come together to form the Global Endorsement Program. And I'm not going to spend a lot of time on this because my time is coming to an end for this short introduction to the healthcare simulation standards of best practice. But global endorsement recognizes healthcare institutions that are using those 4 cornerstones of best simulation practice and recognize them for their quality simulation. So you say, how will I perform? How will I demonstrate excellence in simulation best practices? Well, of course, here it is. Here's a link to those cornerstones and those standards. By demonstrating those standards at the optimal level, you too can say you are using healthcare simulation standards of best practice and you are an endorsed program. So be sure to click on the QR code. Thank you for that whirlwind tour. Thank you for your time. Feel free to reach out on social media as well as via email, snail mail as I call it. It's been a pleasure to serve you as your immediate past president of INACSL, but also as a fellow simulationist in the field.
Thank you so much, Dr. Desiree, for that insightful presentation. Although Dr. Desiree is not physically present here, we extended our deep gratitude to her virtually for enlightening us with her expertise on INACSL healthcare simulation standards of best practice.
Sorry to interrupt, but the video which you have seen, these are the INACSL standards, right? So from the morning, we all are talking about that this is simulation, that is not simulation. But how to deliver the simulation, you need to have some standards, right? You cannot just go, because I said in the morning, the simulation is not just only strategy, and Pedro has taken the one presentation, and that the first question was, what is simulation? Whether it is strategy, methodology, method, whatever the different. So for any strategy, for any plan, for any methodology, for any methods, you need to have these standards. Right? So she just briefed that INACSL is having the standards. If you do not follow those standards, we cannot do the simulation properly. Otherwise, we will make our own simulation and we will come up with the end with no results. Okay? So these are the very important standards. Now you have listened. I know right after the lunch, this might be the, right, you know that, right? So, but now next onwards, you have already seen the standards. You already know in the beginning that what is simulation. Now you know the standards. Now let's see how to implement those standards. Now the interesting part has started. Now how to implement. So are you with me now? Yes, please be awake. Next video is going to show how to implement that, and in that video, this video is in the Indian context. With the use of those standards, we have created one video for you. So now you look how to use that standards. Are you awake? Yes, please.
Okay. Now let's move on to our next segment. Simulation is often described as a replication of reality, allowing learners to experience real-world clinically scenarios in control settings. To bring this concept to life, Ms. Rubia, an expert in healthcare simulation, will now present the simulation scenario. Ms. Rubia, over to you.
Thank you so much, ma'am. Good afternoon, everyone. It's an honor to be with an esteemed audience, that is the nurse academicians, nurse leaders, and the future nurse educators. We all share a common goal, that is to enhance the nursing education through evidence-based practice and innovative thinking. So since morning, you have gone through all the tracks, the sessions, which is giving us an example and reflecting our time when we were in the BSc Nursing or GNM, and we now think that there was a need of simulation. So before moving forward, I want to ask you two questions. The first question is, to run a simulation scenario, in the learner perspective, whether knowledge and skill should be clear or not? Yes. Without knowledge and skill practice, you cannot run a simulation scenario. And my second question is simulation effective in a group or an individual? Group, right? Why? Because this is most effective, because as working in a healthcare, we have to collaborate, we have to communicate with the other healthcare providers. Then only we could provide a quality patient care, right? So in the morning track 2, or I should say in the afternoon, you have learned about the structure of simulation-based learning. Do you remember that? Right? That is pre-briefing, simulation scenario, and debriefing. In the pre-briefing, which includes, that is preparation and briefing. Preparation means you need to prepare the learner. You need to, as a facilitator, also we need to prepare ourselves, and the environment also need to be prepared. So that comes under the preparation part, and the briefing is very important, because if the briefing will not go good, then your scenario will also not go well. Okay? So as in Desiree's presentation also, you have seen that what are the 10 INACSL standards of healthcare simulation standards of best practice. And by following that criteria, now I am going to show you a small video through which I am depicting the 2 phases for now, that is pre-briefing and scenario. Tomorrow we will continue with the same videos debriefing. Okay? So watch it carefully and see whether the pre-briefing criteria are met or not, psychological safe environment has been provided or not. So watch it very carefully.
You all can come inside, please. Good afternoon. Good afternoon. Good afternoon, everyone. Good afternoon, ma'am. My name is Shilpa, and I'm the facilitator today for this scenario. Yes, ma'am. I hope you all are excited. Yes. Okay, so I hope that you all remember what we have learned in the theory sessions. Yes, ma'am. Right. You all are safe here, right? Even if you will make any mistake, don't worry, you are not going to harm any patient, right? Yes, ma'am. And you are going to learn from your mistakes. Yes, isn't it wonderful? Yes. Yes. This is the beauty of simulation, that we are learning from our own mistakes, right? Yes, ma'am. So before we are going to start, I just want you all to introduce yourself. Can we start from you?
I'm Prerna Shetty. I'm Ambika. I'm Priyanka, and we are BSc Nursing 4th year intern.
Okay. Okay. So I just want you all to just get yourself familiar with the surrounding before we are starting. How this room look like?
Patient room.
It's just like patient room. Right. So in this scenario, we have a standardized patient with us. I just wanted you all to just do the suspended disbelief, and it will help you for their learning purpose, right? If you will do the suspended disbelief and do the correct judgment, it will always help for the learning. So standardized patient, you have to always take them as a real patient, right? You have to treat them as a real patient, and even if we are using any simulator with the patient, you have to take it as a just patient part.
Okay, ma'am.
Is this fine?
Yes.
Right. And I just want you all to just maintain the confidentiality, which whatever we will do here, that should be here only. Okay? Yes. Please don't discuss whatever you have done or whatever the decision you have taken over here with your classmates. Okay?
Yes, okay. Sure.
And also, because if you will do all these things, it will hamper their learning. So do we want that?
No.
Right? So please don't disclose whatever is happening over here.
Okay.
Okay? So let me just introduce with the standardized patient. So we have a standardized patient. His name is Mr. Nikhil Nathaniel. Okay? So he is a standardized patient and he is a real human being, right?
Yeah.
So you should know there are some pros and cons for that. Okay? So for standardized patients, yes, it is very beneficial for you that you are able to communicate, you are able to perform the assessment, everything, right?
Yeah.
But yes, you should know there are cons as well, that you are not supposed to be allowed to do any invasive procedure over this patient.
Okay.
Is this fine?
Yes.
Okay. But yes, you have to remember, whenever you are performing any procedures, any assessment on this patient, as you know, he is not a real patient, right? So the readings will not be assumed by you. Okay, so the findings will be given by the facilitator. It means I will be giving you the findings. Is this fine?
Yes.
Right? And you are not going to assume anything. You have to enact each and everything as you are doing it on your real patient.
Okay, sure.
Is this clear?
Yes, ma'am.
Okay. So in this scenario, I'm just going to tell you about the scenario, what is the patient condition. Okay, so Mr. Nikhil Nathaniel, he is 35-year-old male patient. He got admitted to the hospital with the complaint of shortness of breath and breathing difficulty, right? He got admitted to the hospital early in the morning around 8 o'clock, right? And at the time, the patient baseline vital parameters are BP is 130/90, pulse is 104 beats per minute, respiration is 10 breaths per minute, SpO2 is 85% on room air, and temperature is 98 degrees Fahrenheit. Is this clear?
Yes, ma'am.
Okay. So at the time of admission, the patient was cannulated with 22 gauge of cannula on his left hand, and after then the patient was nebulized.
Okay.
Is this fine?
Yes.
Okay. So I just want you all to orient yourself with this row. You have 1 minute for that, and then you have to come back to me. Is this fine?
Yes.
Anything else that you wanted to know, or anything was that you want to get?
No.
Everything is there?
We got it. Yes.
Okay. So for this scenario, we have two objectives. First objective is monitor patient status following nursing intervention. And the second objective is make clinical judgment and decision that are evidence-based. Okay. For this scenario, we have total 3 roles in which we have an assigned nurse, student nurse, and an observer, right? So would you like to give me the roles to you, or allocate the roles to you, or you are just voluntarily wanted to select your roles?
Ma'am, you can give us roles.
Sure?
Yes.
Okay. So we can start with you, Priyanka. I want you to be the assigned nurse.
Okay, ma'am.
Prerna, I want you to be the observer. And Ms. Ambika, I want you to be the student nurse.
Okay.
Is this clear?
Yes, ma'am.
Okay. So I just want you to just give a brief related to your roles individually. For that, I want the observer to be waiting outside. I want to just pre-brief the student nurse and the assigned nurse to be here. Okay. You can you please wait outside?
Sure.
Okay. So as you both, I'm just going to tell you about your patient conditions, and I will be providing you this SBAR format, right? So when you will be entering into your patient room, you are going with this free. Okay. So as you are the assigned nurse and you are the student nurse, so you should know about your patient. So here we have this bar format with us. Mr. Nikhil Nathaniel was performing activity of daily living. Suddenly he started facing difficulty in breathing. He has past medical history of asthma, and he has no food or medicine allergies. At the time of admission, he was cannulated with 22 gauge of cannula on his left hand, and on admission at the time of around 8:30 a.m. his baseline vital signs are BP is 130/90, temperature is 98 degree Fahrenheit, pulse is 104 beats per minute, respiration is 10 breaths per minute, and SpO2 is 85% on room air. Okay. After then, he was nebulized with Budicort and Duolin, 1 respule each. Afterward, he was put on oxygen 4 liter with the face mask. Okay. After again at the time of 9 a.m. the assessment was done, and patient vital parameters was temperature is again 98.2 degree Fahrenheit, pulse is 90 beats per minute, respiration is 14 breaths per minute, and the patient BP is 130/80 and SpO2 is 95% with oxygen saturation. Okay. Your patient general appearance, he is well groomed male patient. His cardiovascular system is completely normal. Patient is having a normal sinus rhythm, and patient respiration, there was a whizzing sound on when we will check at the breath sounds. Your patient GU is there is a normal urine output. Okay. Skin, it is warm and dry to touch, and there is no redness over there. Okay. And extremities, there is a normal range of motion is present. Neurological, your patient is oriented with the time, place, and person, and the patient Glasgow Coma scale is E4 V5 M6. Okay, and there's a recommendation for your patient. You have to assess the vital parameters every 4 hourly and record it as per the needs, right? And the second one is you have to just go for the patient safety. Okay.
Yes.
So this is your form that you have to keep it with you when you will even enter into the patient room.
Okay.
Right? Is this clear? Do you want to ask me anything?
No. No.
Is this clear everything?
Yes, ma'am.
Right. So I just want you to keep this paper with you, and I just want you to please send the observer here, and please don't discuss in between. Okay?
Okay.
Please wait outside. I will call you back.
Okay. Thank you, ma'am.
Just send the observer. Yes, you can come. Hi Prerna. So as you are the observer in this scenario, so you have a responsibility. This is your observer checklist. On the basis of patient safety and communication, you have to observe the whole scenario, and you have to observe all the 2 participants, those who are in the scenario, right, individually. And please don't only focus on the negatives, you have to check on for the positives as well.
Okay, sure.
Right? Okay, so this is your observer checklist that you have to keep it with you when you will enter into the patient room.
Okay, fine.
Is this fine?
Yes.
Okay. Can you please call both of them in?
Sure.
Can you please stand here? Yeah, this side. Okay. I hope you all are clear with your roles?
Yes.
Okay. So I just wanted to tell you, during the whole scenario, there will be a recording going on. Is this okay for you?
Yes. Yes.
Don't worry, we are not going to use these videos for any kind of assessment or judgment. It is only for the learning purpose.
Okay.
Okay? Okay. So the scenario will be started with this knock knock sound. Okay? And the scenario will be stopped with this signage.
Okay.
Is this clear?
Yes. Yes.
Anything you want to ask?
No. No.
Okay. So now we will start with the scenario. You all 3 can just go outside, then we will start.
Okay.
Okay? Yeah.
Thank you.
Good afternoon, Mr. Nikhil. How are you?
I'm not good.
What happened?
I can't breathe properly.
Okay, okay. We'll see what we can do.
Hello, sir.
Can I check your ID?
Yes.
I'm Ambika, I'm the intern here.
No.
Are you feeling alright, sir?
No.
Don't worry, sir, we are here.
Can you tell me something about yourself?
My name is Nikhil. I'm 35 years old and I work in private sector.
Okay. From how long you are having difficulty in breathing?
Since last night.
Okay, before that you have any episodes of this breathlessness?
Yes. Early in the morning I was having so much difficulty in breathing.
Okay.
Sir, I'm checking the temperature. Can you keep your hand like this, straight?
Oh. Mr. Nikhil, I have to check for your respiratory sounds. Will that be fine?
Yes, please.
Breathing sound is present.
Sir, wait, I'm checking the
Temperature 98.3 degree Fahrenheit.
I also have to assess for your abdominal sound. Can you put your hand like this?
Sir, I'm checking your blood pressure.
Normal vowel sound is present.
Everything is fine. Just relax. I will be raising head end of your bed. Maybe you will feel better.
Please don't do that. Can't you see I can't breathe?
This will be, you will be feeling relaxed.
140/90.
In the morning, when I got admitted, they placed some kind of mask. It really helped me in breathing.
Okay.
Can you please place that again?
Okay, I'll just look for that.
Pulse 114 beats per minute.
I think SpO2 is low, so I have to start. We have to start with the oxygenation.
Please make it fast.
Yes, yes. You just have to place the marks.
It is very difficult to put tubings.
Start it at 2 liter. Just relax. You will be feeling better in few time.
Relaxer. Stop.
Okay, please replace all the articles and don't discuss anything here. Okay, we will be discussing over the whole scenario in the debriefing. Okay.
Okay, so we are done with the video. That is the two phases we have shown you, that is pre-briefing and scenario. I was listening, so many of you were telling to each other, maybe due to the scenario only, कि ये गलत हुआ, वो गलत हुआ, maybe like that. Yes, right? So everyone was judging over here, right? Everyone was the observer over here, okay? So like every hospital has their own protocols. So this was the perspective we are showing about the nursing student, right? Whatever they know, we have seen these type of situation in the simulation scenario which we have depicted over here, right? Tomorrow in the debriefing session, we will show you how you need to facilitate over all these things and how you can extend this debriefing after that using the same scenario itself, right? So through this video, you have got a guidance to the who are new to the simulation and also to the experts over here to get reinforcement. Hence, through this video, you have seen that how structured the simulation pre-briefing should be there, because pre-briefing isn't just a formality, it sets the foundation for a smooth scenario and a powerful learning experience during debriefing. Tomorrow, we will take this further. We will focus on debriefing, the most crucial phase where the reflection, critical thinking, decision making, all these things comes up in a group. Is it clear? Okay, thank you so much.
Thank you so much, Ms. Subia, for that engaging session.
Thank you. It was really nice, the presentation. And for me, as a neutral, I was very happy to see some familiar faces doing an very good, very realistic, and I found, although I may not have the acumen to find out the faults in it, but I wish I had an instructor like that, while I was studying my communication. Okay, moving on. We have a special sponsor presentation from Gaumard, and I would like to call upon on stage Dr. Carlos. And Dr. Carlos serves as a consultant for Gaumard's Scientific and Simulead Consultancy. He completed his MD and MBA in 2007, and in 2010, he was selected as a consultant for Gaumard Scientific, specializing in regional business development and simulation education for the MEA region. We are very glad to have you here, and I would also like to call on stage Dr. Judy from Oman to felicitate Dr. Carlos. Okay, we'll go with the sponsor presentation first, and then we'll go for the felicitation. Over to you, sir.
So do I connect the HDMI? Okay. So, good afternoon, everyone. Thanks for being here. Excuse my voice. It was a long travel, and it seems... Yes. Perfect. So, Gaumard Scientific, it's been a company that is developing for so many years. As you see here, we started in 1946 with mother and child health. This was our main focus in the beginning, and then of course we developed to higher and higher fidelity. Our mission and vision is to help healthcare providers to learn more away from the patient, gain those skills. Like every other industry, like every other manufacturer in the industry, we have the same mission and vision, but we decided to do it with more and more innovation. Everybody knows our products. They are very realistic when it comes to our innovation part. We try to be super realistic, so all those scenarios that happen in real life, all those human features that you see, human physiology, pathology, it helps with the immersiveness. This generation of younger learners, they want high fidelity, they want more and more realism, so they immerse, and when they immerse, they learn much more. You know, and we used to play with the Atari, you know, as, you know, old video games. We used to be very happy with the Sega. I mean, now this generation, not even, you know, the PlayStation, they need also the VR, they need the chair that moves, you know, so it's a generational thing. The demand for education, for high fidelity in education is not from us. I have the experience, most of you teachers here have the experience, but when we had this vision of higher and higher and ultra high fidelity, which we will see shortly, it comes from the learners. It comes from this generation that is different. They learn differently compared to how we learn. And also the patient nowadays has, you know, more rules, more respect, and we cannot really jeopardize any of the patient rights and rules. So our company also has a very wide spectrum of products. We cover all specialties from premature, neonatal, pediatric, adult, you name it, nursing, trauma, and of course critical care. You name it, we got it. Our famous, you know, Victoria is here. We insist on having people use one software with no hardware limitations. So we're not here trying to sell you updates or sell you scenarios. It's one software available online. You put it on any of the computers and have it work. This is a flagship we have now, so I'm showing it to everyone. For the sake of time, I'm gonna be really quick. Try to select, this a link. I hope it works. So I'm gonna exit, I think, and then have it. Yeah. Oh, now it should work. I thought it would be easier, but fine. So this is our flagship product. It's called HAL 5301. It's a simulator that is AI powered. So it's not about only the conversation here, it's about being able to move. So imagine you're doing a neurological assessment for a stroke patient and you ask the patient to move the head to the right, to the left, see if they're oriented or not. So this is the HAL 5301. This is the advantage. No audio needed, it's okay. So it's not coming.
Hi, my name's Anna. I'm going to be your nurse today.
I don't know if you can listen.
Give me your name.
So that you need it, right?
How can you please move your head to the right?
Oh, please wait.
Can you please
Okay, so she's asking the simulator to move the head to the right, to the left. You can clearly see the facial features of a patient with stroke. You can see the hand movement. It could squeeze, it could not. You can see so many other details like, you know, capillary refill and the stimuli, different stimuli to assess glaucoma scale like trapezius, squeeze, with a guarding reaction. So this is really, you know, next level. And of course, when it comes to critical care anesthesia, we have those more stimuli. This is a sternal rub, and then you can have a supraorbital notch stimulation. Okay, so many features. Even we have the train of 4. I'm not going to show the whole video, it takes a while. So you can stimulate the ulnar nerve and have the simulator twitch. Look at those seizure features, tonic, clonic. Okay, so this simulator also has all kinds of facial expressions, being surprised, amazed, lethargic, and all the stroke features. I'm gonna skip this, and of course you can go for the actual physical examination where you can ask the simulator to track and trace your hand movements, and you can have it in nystagmus, you can have the abnormal movements also. So of course this is the nystagmus. We have this, simulator can sweat to simulate diaphoresis, emit tears. And then we come to the trauma features, integrated ultrasound system. So what you have now is the ultrasound being democratized. Everybody's learning about ultrasound. We've integrated it, especially the FAST and EFAST protocols, the life-saving findings in ultrasound. It's integrated in this simulator. More trauma comes with surgical airway, amputated arms, amputated legs. So you can do a lot of trauma procedures, and I think every country has the need to train for trauma. CPR life support is always there. We never let go these features, of course, and you can tell also the other trauma features with the intraosseous, humeral, and tibial. Real monitoring, this is where I'm jumping next. Most of our simulators, from medium to high to ultra high, we use 100% real equipment. You can still use the virtual vital signs monitors, but we insist when your nurses go higher and higher, before they get employed, before they meet the hospital setup for the first time, have them try those machines in your sim center, and then they get better acquaintance with these technologies. Okay, so last but not least for me is the ventilator features. So we can simulate all kinds of human lung functionalities, being the normal ones, abnormal ones, and you can it's a built-in first. It's not like some other manufacturers. You have to have a device on the side. We have the built-in lung simulator. It has a diaphragm, so you can control that diaphragm during the weaning process, and also you can control lung airway resistance on both sides. And you can control also the compliance. So if you are simulating diseases like COVID or any other pneumonias, you can do that. Flagship simulators also, Victoria. Now all of our simulators come with augmented mixed reality. So students would see the inside of the simulator while enjoying the haptics and the team communication. I see how much you pay attention to team communication. With mixed and augmented reality, you can still do that. Pediatric simulator, you can see it in our stall outside. Our pediatric simulators cry and have facial expressions, and they move, and they're super realistic. And every one of our simulators has the ultrasound, but also the lung simulator built in. So you can use it from communication skills up to critical care. Hook them up on a real ventilator, real monitor, and they would deliver a great training. Trauma, nursing, emergency. So a really, really wide range from high, ultra high, high, mid, and our famous skill trainers. A lot of skill trainers and even standalone monitors. So for those using SPs, doctor here showed us a great SP experience. You can use our, if you have an SP, you can use our standalone virtual monitor. So instead of saying the vital signs orally, you can be showing them on a computer screen with an instructor tablet that would allow you to change the vitals. Okay, a lot, CPR, obstetrics, gynecology, blood pressure, neonatal, all kinds of skill trainers. Thank you so much for your attention. I would love to welcome you to the stall and talk later about your educational needs. Thank you. Thank you.
I would now like to call Dr. Judy from Oman to come and felicitate Dr. Carlos. Thank you. Okay, thank you very much for that sponsor presentation. Moving on, we will be going to our final panel discussion for the day. And yes, this will be the final presentation, final discussion, and it'll be my honor to introduce and say some words for our speakers. So, for this session, we have first up Dr. Anu Gauba, who is a Chancellor's Gold Medalist for Best PhD, Thesis and Research Excellence Award recipient. A prolific author and educator, she has designed innovative community programs and received multiple Teaching Excellence Awards. Next, we have Lieutenant Colonel Sandhya V. Nair, a healthcare administrator with 29 years experience, recognized for creating India's longest green corridor, presidential citation recipient from the Society of Neurocritical Care, and Asia Pacific Excellence Award winner. I would also like to welcome Dr. Jyoti Sareen, who is Dean of College of Nursing and President of Indian Association of Neonatal Nurses. A President's Gold Medalist, she authored influential pediatric nursing textbooks and contributed to WHO's quality assurance methods. And also, finally, I would also like to call upon Priscilla Fernandez, a seasoned nursing leader with 30 years of experience across prestigious institutions, including Wockhardt, Medanta, and Kokilaben Dhirubhai Ambani Hospital. Expert in hospital commissioning and nursing administration. I would now like to hand over the reins to Ms. Tankam to oversee this panel discussion. Can we give a round of applause for our 4 panelists and also Ms. Tankam.
Good evening.
Good evening.
What an evening.
Yes.
Yes?
Yes.
What a heavyweight, panel sitting here. But, Nah, as such. Okay, I thought before I get into the, discussion with our esteemed panelist, I have to tell you a story. What's the theme of the panel? Oh, it's here. That was your testing. Yes. Okay. Should simulation training focus more on technical skills or critical thinking and decision making? So the story I'm going to tell is probably related to the theme. The story comes from Pedro's presentation because he showed an orange with a syringe. The story goes like this. I don't know whether it's real. Patient going home on insulin, the doctor tells the nurse, "Sister, make sure he learns how to give insulin, self-administer insulin." And he tells the patient, "Please make sure you learn from sister how to take your insulin." So after 2 days or 3 days, he's getting discharged. So doctor says, "Okay, you're all set to go. So you know how to take the insulin?" And he said, "Yes, sister, you finished?" So she said, yes, sir. So he went home. And after 1 week, he comes back to the OPD with a blood sugar of 400. And he is sick. So doctor wonders, how come that his sugar went up so much? So he asked the patient, didn't you take insulin when we sent home? So he said, I'm so sorry, where I stay, I don't get oranges. Can you relate it to this? Yes? So, with that, everybody is awake? Yes. Okay. Even I had to wake myself up. Late lunch, so hyper. What's that? Postprandial? Hypo. Okay. So good evening, everyone, and I'm very honored to be, taking you through this panel discussion, so you know the topic. So I'm going to start with the recipients of the students, okay? Please pardon me, academicians. I'm a fully service person, so I have a bias towards the service. So I'm going to ask the service people that, what do you think? The simulation training, wherever that we are doing, simulation-based learning, should that focus more on technical skills or critical thinking and decision-making? What has been your experience? You can be as candid as possible. There are no guns here, so nobody will shoot you. So no worries. Okay.
Thank you, ma'am. I think so the topic which is written, it is also complex for us. As we all know, in the nursing, foundation of nursing is very important. So simulation-based technical skills to develop, it is the foundation, and it is a higher priority takes that it is required. There is no denial that simulation training should not have technical skills, because that is our foundation that is taught to us in fundamental of nursing by giving example for all the procedure which we require techniques without giving for giving an injection or for inserting a cannula or fixing the Foley's, we required a skill. So simulation definitely required skills to be developed. But when, as a director nursing, when we go through day-to-day basis, we observe and we had lot of challenges that because of critical thinking beyond that level and the decision making is very, very poor right now. So because of that, patient decisions are delayed. So simulation also needs to back up with the critical thinking. Day to day, we see every day there are a lot of scenarios are happening that patients are getting lines and tubes are out. There is every day there is a problem that patients are unconscious and people are not able to make the decisions. We are not able to think critically why patient is unconscious. There are complex situations and scenarios are happening day to day. So I think so it's very, very important that simulation should also focus on the critical thinking. And as because critical thinking, they are not able to endure, decisions are delayed. So I think so three of them goes together, that when we focused more on simulation, that currently technical skills are very important, so simulation goes with the skills. But if you ask me, definitely there are 70–80% patients, complex scenarios where critical thinking and also the decision making is very, very important. So that's how I elaborate on the topic.
Okay. Thank you, Priscilla. It looks like that you are saying that more focus should be on decision and decision making and critical thinking. You know, technical skills are also important. What's your take, Sandhya?
Thank you, ma'am. Actually, this topic, this hearing should not be like, it should not be a debate. Right amount of technicality, right amount of, actually it will be synonymous for critical critical thinking and decision making. For instance, a person, a massive trauma comes into a ER, that you may be, however, technically you are well defined, but you need to know which is your priority, which patient has to be triaged first. The same amount, you're a very skillful IV nurse, but I'm a renal nurse, that's why. you should be knowing that you should not prick an AV fistula. That is, so that you may be but you cannot go. So I think the right amount of technical skills with right amount of critical thinking will actually enhance a very good decision.
Dil mange more. We are asking for magic. So let's ask the academicians. You know, morning we heard something from Dr. Bimla also. 4 years you have the students with you. So what do you focus? I mean, do you focus on technical skills? Do you focus on critical thinking or decision making? What kind of approach were you taking few years ago? Has it changed now, post-COVID? What's your opinion on it?
Thank you so much, ma'am. I think the best simulation training is when you will integrate technical skills, decision making and critical thinking together. This is the only way when you create a well-rounded professional. This is according to me. Because simulation is what? Simulation means when you are giving safe environment to the students so that they can do well, they can perform well, they can do a lot of mistakes, and from their mistakes only they will learn. So this is my point of view. So we have to club together. Everything has to club together so that we can enhance the capability, practical as well as knowledge skills together.
What a consensus, sir. They are all voting for simulation with everything inbuilt, you know. So let me just move over to Dr. Serene. Ma'am, you tell me from your long-standing experience, how do we manage all this? And especially we are focusing on simulation training. When we are designing simulation training, your faculty, they should focus more on technical skills, or they should focus on decision making, critical thinking?
Okay, thanks. It's a practical question, and I would like to share my experience. How do we go about at Maharishi Markandeshwar deemed to be university? We have collaboration with 2 universities in Norway, that isVid University and Lovisenberg. It was essential first to get ourselves sensitized as faculty, as administrator, how and the simulation should be planned and how it should be effectively implemented. Then, after having the sensitization, we came and shared the same experience with the faculty at MMU, because 3 of the representatives could only go to Norway for learning there. And then we came and shared with the entire faculty. It is not one. Even if it is 70 faculty, we had to share our learning with each one of them. Then, what we did, we developed the case-based scenarios, and these case-based scenarios were developed from the case sheets and the real patients in our parent hospital. Because it cannot be hypothetically, you cannot be creating the scenarios, it has to be as close as real to the real patients. And I endorse the statement of my previous speakers that there has to be a balance between the technical skills, critical decision making, and the critical thinking. And if we recall our circle of learning, that also says the same. First step is cognitive or the knowledge acquisition. Then we proceed on to the skill proficiency and decision making, and then to simulation so that we can combine all these, and then we go towards translation into action in the clinical area. So, and then we also took up certain researches, which I will share it later. I know because of time constraints, but I endorse the statement of my speakers that there has to be a balance.
So there has to be a balance. So I am referring back to somebody's in the morning that we have so many students. How do we put everyone through simulation? It's very time consuming. So let's discuss a little smartly. See that whether is it possible, because somewhere today there was also discussion. You also mentioned in this circle of learning, you give them the knowledge and the skills first. For that you necessarily need not have simulation. So from task trainers, they can learn all about IV cannulation. And when you get into a simulation scenario, I mean, maybe it's not required to look at the skill, whether they know how to put the, cannula at that particular time. And this is the way I look at it. So, do you think that in the academics, I'm going to ask the service people, so when you interview a nurse, what are you trying to look at that nurse? Now, forget about the experienced nurses. Let's look at the novice nurses who come to us. So what is that you expect when you interview a nurse?
At least, I think so when we interview the nurse currently because of the shortage or people are not there and whatever, we still would like to know that at least they can access the cannula. Can they able to put IM injection? I always ask them in my interview that what is the route of injection insulin? So a simple thing that we required from day one that nurse should know at least. And at least they will able to practice that if they have little bit knowledge about that. And some scenario that what you think about the code blue or what you define as the unconsciousness of the patient. Because these are the scenario we have every day in the hospital. And I always believe that technique is definitely, once you train them, at least they know. But the scenario, the 70-80% of the time of them goes to manage the scenario. Hospital like corporates and all, there are not only scenario which is only a patient-centric. There are scenario which is even though beyond that, social media is there, there are a lot of things. So we have lot of questions around them that at least 5-6 questions if they answer us, then we'll know that there is some skills are there. There are certain critical thinking goes in, and we can back them whatever is required more, and we'll able to manage them.
Sandhya, what do you think?
Ma'am, like to add on to it, we have a very defined recruitment protocol. Like we have defined questions for the 0 to 6 months, because that questions we cannot ask like from 6 to 1 and 1 to 2. And like you said that, even not the experience, but I feel experienced person really required simulation, because the old generation, like we all did with skill state, actually people actually confused with skill stations, demonstration room and simulation. So that we need to sensitize our own in charges, the supervisors, then only actually the sensitization comes with the new joiners. And in our hospital, we have a very defined thing, like we have a recruitment. What is main is that the logic to come and should know a minimum, she should be primed with the minimum knowledge. Like, of course, and what we actually choose which institute they come. That is a mandatory, because you know a specific institute who have a thorough learning process, you have a well-defined simulation trainings or whatever, in the skills, even the demonstration, a good amount of clinical practices they have undergone in this 3 or 4 years. So you know that at least some amount of exposure to a clinical scenario they have. And then you go with the question. So you know, and I am sure that 100% you cannot assess a person on one interview. And then we come to a well-defined induction process. However, you have trained them all, there should be, as the earlier speakers in the morning told, should have a defined induction process of your own setup, your own, all those which include, and thanks to Jaideep, we have a well-defined 10 days of induction with simulation trainings which happen also. And they go for an OSCE.
Okay. You all are sitting from very esteemed and lucky organization, both of you, right?
Grass is greener on the other side.
Thanks to Jaideep, we have well structured. So now going to the academicians, your students can go anywhere, right? And they may get patients in any hospital. It doesn't matter which hospital they go. So do you have a process of ensuring bare minimum? This is what our students will exit with. It's like outcome-based education, not the exam or the ranking or whatever, because I have enough experience to say I will take all those numbers with a bucket of salt, not even a pinch. So how would you, what are your thought process on that?
Ma'am, actually, our students, like I'm working with Amity University, so our students, they goes to various hospitals for the trainings, so that they can develop basic skills. So whenever the recruiters come for the recruiting, like ma'am's the hospital is also coming for the recruitment. So whenever the hospitals, they are coming for the recruitment, so they should know what are the basics things. So for that purpose only, we basically focuses on the basic skills. For example, like in Amity, we are having labs and all. So we create scenarios, we create simulation scenarios for the students so that they can able to answer their questions when the recruiters comes for that. So for that we are having, comes to your question only, so for that we are having basic, a checklist with us. So whenever the students completing their 4 years, when they complete their degree, so they should have all those skills, capable to do all these skills in the hospitals. So we have checklist with us.
Okay,
Yes.
thank you.
And second thing is the scenarios, even the teachers also, our teachers, they usually goes to simulation centers for the training. So when they came back after the training, they will also, pass on these things, the messages, the training, whatever they discuss with that at that particular place. They communicate everything to the rest of the teachers, so that they will also aware what is simulation, how to create the scenarios. And because every teacher who whether they are from any specialty, whether they are OBG, whether they are secretary, whether they are community, whatever their specialty is, they should know actually what is simulation, what is the importance of simulation, and how to create simulation scenario for the students, so that when they pass out, then they clear their degree, when they complete the 4 years degree, the student should also aware regarding that. So we are doing that in Amity actually, ma'am.
Dr. Serene, have you changed any modality or methodology of your training methodology of these nurses in the past 3-4 years?
Yes.
I mean, related to the past education that we were giving to our nurses. And also I would like you to reflect on outcome-based education. So what are your thoughts on that?
Definitely, we keep ourselves updated and we keep challenging ourselves, our existing teaching learning strategies, so we have a path to move ahead. In the past 3-4 years, as the revised curriculum is there, which has specified simulated hours and the lab hours. So we comply to in totality. Plus, they have said that 17% of clinical hours can be substituted by the simulation.
Okay.
So we are doing 15 to 30% depending upon the speciality, what simulations we need to plan and how do we implement. We are substituting 15 to 30% of clinical hours as simulation lab hours. And as we are attached to a parent hospital and we have a very well set up simulation lab where we have products of Ladle, products of Gomad are there, and we have access to that lab, and students rotation is prepared of visiting and what they will be doing there. It is not only going, it is we have a structured simulation program for medical surgical, which simulations will be done, for OBG what will be done, and for pediatric what will be done. Even we have gone a step ahead for psychiatry as well. Okay. And we did a research where we have, the findings have revealed that 15% of the clinical hours of clinical hours can be replaced by simulation by having equally effective learning outcomes. So because the revised curriculum is competency based, is outcome based. So we have to identify what are the learning outcomes we are trying to achieve or what we are looking for. And based on the learning outcomes, what we are planning for our students, we devise the modality of simulation, we devise the modality of learning as well. So at the end of each semester, we have a feedback of the faculty, of the students, to identify the gaps, what we were not able to do good, so that we can take remedial measures for the subsequent semester. So it's the constant feedback is very, very essential, which as an administrator, as a faculty, as a stakeholder of students, we need to do. And as Dr. Gaba has said, we have a set of competitive series, which we have it for our students who are going to pass out, or the exit competitive series are there. And in the revised curriculum, INC also has prescribed that on exit we have to have OSCE, which will be done by 5 evaluators, 3 will be internal and 2 will be external. I think that will really improve upon our, and we need to have collaboration, and I am a person who is very
I'm already
open to
smiling. I'm already smiling.
Yeah.
I said, when you have these 5 evaluators, will you be willing to invite people from services to come
Why
and
not?
evaluate?
Why not? Why not?
Why not? Okay, I'm going to ask the audience sitting here now.
Even, ma'am, we are actually in Amity, we usually did practical through OSCE only as per the INC curriculum, because it was mentioned there we have to perform OSCE. So whenever we conduct any practical exam, we involve service people only, so that the students should also learn like what exactly they have to do when they are creating
I
the
would
scenarios
definitely
for
love
that.
to come and interview your students and then experience the difference now I am seeing after 12 years.
You are most welcome to MMU.
So, my question is to the audience here. What's your, let me first ask the educators who are sitting here. Can you raise your hands, please? Nursing educators, okay. Okay. So, if you have to say that, you know, through simulation training, what would you like to improve? Is it technical skills? Then you raise your right hand. And if you think the weightage has to be more on critical thinking and decision making, then raise your left hand. I'm especially looking at the experts. So, Marian already lifted her left hand.
Yes.
And other 2 experts are raising both the hands. I think they're playing it safe, huh? Yes. So, all right. So, me with my experience, I will tell my weightage will always go for critical thinking and decision making, because my patient problems were almost all of them were related to that, because my nurse could not decide simple thing that I have to escalate, or she did not know that I should not run out, but I should do something with my patient, because technically she knows I have to take the blood sugar. She took the blood sugar, she got a reading, then she ran out to call the doctor, and she spent 2-3 minutes. By the time she comes back, the worst thing has already happened. So these kind of events for me is very challenging as a nursing administrator. I don't want to harm my patient. So I will not say technical skills is not important. It has to be imparted. Obviously the knowledge, the technical skills will get imparted. Then simulation is where you bring all together, and without wasting too much time on the technical skills per se, they know that I have to do this intervention.
Very right.
But we would like to see that whether they are deciding the right thing. So there are different ways to do that. I am pretty impressed with what Dr. Marian shared on Saturday, you know, not very expensive, but very, very easy way of training many nurses to think critically. And I always think if we collaborate, the service and the, you know, academicians collaborate, maybe the service people can tell what you already have a curriculum, so you will definitely impart what is there. But what are those scenarios that they would like to give you so that you can use it in first year, second year? It's not that everything happens finally and then it's like a big, you know, Mahabharat that is happening at the end of it. So the children who are studying, they are very easily eased out into the system of, you know, gaining the knowledge, then of course having the technical skills, and then able to think. So when they come, when I interview nurses, I first look at, can they understand me, what I'm asking. It's like, even if I tell 1 gram of ampicillin, you have 10 ml of, saline, when you dilute, I want to give 150 milligram, how much will you give? This is my very famous question, and believe me, I will get at least 8 answers, either wrong or it takes a long time. But if I tell them, okay, forget the ampicillin, you have 100 rupees. Instead of 1 gram, if I convert that into money and tell them, they will get the answer quickly. So my take from my own experience is that the faculties or the trainers or the educators need to be very creative in their thinking, so that they can translate what you are trying to teach in a language that they can understand. Do you agree?
Very right.
Yes?
Very right.
Go ahead. This is now your final round. Time up.
I'll add on Madam's statement that it's definitely critical thinking, and it's required, because most of the time in our practices, we have seen the nurses are wasting their time in thinking that what we should do. Fixing the cannula, they'll fix. After the rest of the life, they're thinking, what can I do if the patient is unconscious? And I still remember in 2010, I think so, Jaideep, and we have created at least 15 to 20 scenario, which happens every day in the hospital. And I was just talking to him in the morning that why can't we start that again? Because that scenario makes us very easily, that nurses will understand. There are a lot of unconscious patients, they don't know what is hypoglycemia, if the patient has got hypoglycemia or code blue situation or synchrony attacks. So there are 3 more situations for front of them, and if they quickly don't decide, then they will not able to take decision. So I 100% sure, and I agree with you, ma'am, ki 100% scenario based simulation is required currently in our country at least. So that is my thought process on this also.
Thank you. Dr. Sareen, so can we think about, creating bridges?
Morning, I am looking forward for the mutual collaboration, and I am also looking forward for the interdisciplinary collaborations as well. And if you have already this work done, let's not waste the time, and we can, through hybrid mode or through online mode, you can share those, and we can have an evaluative sessions of the students as well using those modalities.
More than 20 to 50 scenarios, at least in Vidyanta, Lucknow, and I hope that we have in Gurgaon itself. So that after their induction and skill has been done, we also take the scenario-based training, so they'll quickly recap. Whenever the incident happens, we do the root cause through scenario-based. That why it happened, how can we provide, and again there is a bunch of people who get trained, so that helps us a lot. Because even the patient is in the lift and he collapses, what to do? RRT, code blue, or take it to the emergency? So there is a problem with that. So every scenario they get stuck into, and they ask somebody and they'll waste their time. So 100% technique is required, but most of the 70–80% of time, critical thinking and decision making, and when it comes to the corporate hospital, I think so even the social media, how to handle, everything simulation-based training is required currently. Thank you.
Simulation-based training is all over the place now. Now we have to somewhere agree, where do we start? So I think since Sandhya is sitting in between Amity and MMU, and you take, students from both, right? So you are sitting in a place where you can collaborate with both and probably kind of discuss and create a system where first year, second year, third year, based on the technical skills and knowledge that they have already acquired, even the communication module, if it is not scenario based, then they will only learn there is a sender, there is a receiver, and there is a message in between. And these answers I have actually got from nurses, but that's not the case when you talk to patients, right? So do you think now we are looking at some action? So she said she'll give some scenarios. You are going to do research with both of them?
Yeah, we have with Abiti, and we also have Jasmine sitting over here with SGT also.
Okay. So I think you all can collaborate and then probably come up with a research to see that if we do this set of interventions, and when the nurse students come, do their behavior and the patient outcomes and events, are they getting offset? You know, we really need some evidence from our country so that even other colleges can then emulate and say, okay, this worked, so we can also take the same. Okay. Is it possible?
Yes, we can
I am getting my
collaborate.
little
Yes, very
bird
true.
at the side saying, ma'am, oh, that's our Mr. Joshua, not a little bird, huh? So I would say that we are kind of agreeing that technical skills are critical, but in simulation training, the more focus can be on decision making and critical thinking. Am I right? Do you all agree? Yes? I have a complaint for Pedro. He was telling for the master students, he will first teach them the A and say, go back and learn, and then they come back for simulation. Then when I asked the question, he raised both his hands. No, I understand. I'm just
want to
making
ask
everyone
one
laugh.
question, right?
Yes, please.
We have a question.
Please ask, please.
Question, comment, all welcome. One. Finally, somebody is standing in front of the mic. So please give her a big clap. I can't see you. कौन है? Oh, is that Dr. Sheila? Oh, okay. Yes, Dr. Sheila.
No.
But we can hear you. I think for nursing education, simulation is still in its infancy because we have only now incorporated it into our curriculum. And the best thing about the audience here is that we are all Indians and we are nurses. So we are going to improvise. So in the next 5 years, what I envision is that we will have our nurse educators who, let's say, a pediatric, posting. What they would do is, the first week that the students come in, they would focus on technical skills. Okay? And it should be situation based. And when the students have completed about 2 to 3 weeks into the posting, are sure of their technical skills, then the focus would be on critical thinking and decision making.
Thank you. You summed it up very well. I think the knowledge and skills, give them first and then bring them. It's bringing all the separate video clippings together and then making the movie finally, right? So thank you so much, Dr. Sheila, for summing it up. Thank you very much to all the esteemed panelists, and obviously we can go like this on, and we had been going like this for on and on from morning. And thank you very much, audience, for still being here and clapping so lively.
Thank you so much.
She's telling they are happy because we finished. See you but tomorrow. There is more fun tomorrow, okay? On time. Okay.
Thank you so much, Ms. Tankam. And we want to felicitate our panelists, and for that we want to call Dr. Pedro to come up on the stage. It is only fitting that Dr. Pedro is called up to felicitate our 4 panelists.
Make sure all of you look at all of us, not only Dr. Pedro.
Dr. Anu. Can we move a little ahead?
In the center.
Colonel Sandhya. Next we have Dr. Jyoti. And next, we have Miss Priscilla. Can we have another round of applause for our dignitaries and experts? Yeah. Okay, so request all of our guests to move ahead for a group photo. Thank you to all the guests. Now that we have heard a lot of thought-provoking and eye-opening statements and citations, I request our guests to take their seats. Thank you. And definitely the conversations will carry on. But now we want to give some time to our audience, and we'll have a couple of chances. We all have seen, we've all have inculcated, we have all internalized the talk, the expertise that has been given from here, the opinions and thoughts from varied leaders of their fields. There is something that would have provoked us. There's something that has definitely hit us. There's definitely a takeaway that we've taken. There's definitely a learning that we have taken in as an educator, as an academician. And now is that chance. I would ask if any of you has that one thing, if you have a thought that you took away from today's session, one thought that hit you, one thought that came into your mind, this is something I did not know about, and this is something that I'm really gathering for the first time, I'm learning for the first time, thanks to this conference. It's time that we want to give you a couple of minutes time to come and express what you learnt majorly. Just one thing, pinpoint to that one thought, one learning, one teaching that you gathered from this networking event, from this conference. It's now, chance has been given to you. So we'll take a couple of people who'll have 2 minutes time to talk about anything that they learned for the first time. Oh, we're shy, is it? Thought-provoking. We said thought-provoking so many times. No thoughts being provoked, is it? Your chance. Yes, please, ma'am. Yes. Thank you.
नमस्कार, मेरा नाम फरहा नाज है और मैं छत्तीसगढ़ से आई हूँ। मैंने एक पॉइंट नोट किया जो मुझे बहुत ज़्यादा टच किया है, एंड सम टाइम ट्रांसफॉर्मेशन इज़ मोर इम्पोर्टेंट दैन इनोवेशन। जयदीप सर का पॉइंट था, और मैं इस पॉइंट से बहुत ज़्यादा मतलब मोटिवेट हुई हूँ, क्योंकि हम लोग इस प्लेटफॉर्म में हैं जो हम लोग को इतना अच्छा लर्निंग का मौका दे रहा है, हम बहुत सारी चीज़ें सीख पा रहे हैं। और मैं छत्तीसगढ़ से आई हूँ, सो मैं तो बहुत खुश हूँ सुबह से ये मतलब आप लोग का प्रोग्राम कॉन्फ्रेंस अटेंड किया, इतनी अच्छी अपॉर्चुनिटी मिली मुझे। थैंक यू सो मच। आप लोग ऐसा प्लेटफॉर्म प्लीज़ और लाइए, तो हम जैसे बच्चे जो है मेरे छत्तीसगढ़ से जो आए हैं उन लोग बहुत ज़्यादा एंथुजियाज्म हो गए सब देख के बहुत खुश हैं और बहुत सारे पॉइंट हैं जो हम लोग सीख पाए हैं, तो थैंक यू सो मच। थैंक यू सो मच सर।
Yes, please.
Good evening, everybody. Thank you, Jaideep sir. This is like simulation we have seen just with Jaideep sir earlier, but now we have learned deeply, like with all the international experts, sir, ma'am, and like how to create moulage, how to create sessions, how to do briefings, and all the national and international experts. So we came to know that how simulation is important, and we learn how it is very important as a patient-centric. So as we are working in a health sector, no matter we are academics or we are working as an educator or a nurse practitioner in a or preceptors in any organization. So our main focus that should be a patient-centric, that we have learned here. And after all, we only here for patient. So in this conference, we have learned about how simulation can create a great impact on patient care and how we can treat the patient well and how we can teach our staff nurses or our nurses or ourselves and how we can boost our confidence in teaching and how we can improve our knowledge or skill and critical thinking and finally decision making in our organization, and we can improve in organization. Thank you. Thank you, Jaideep sir, once again.
Thank you so much, and we really appreciate the comments and the learnings that you've internalized. And we have one more person, and after that we'll go for the day's recap.
So once again, good evening to all present over here. I am Professor Dorvin Das from St. Francis College of Nursing, Indore, and since morning we are listening, and in that two more points I want to talk about that. Still that we are not clear about the skill learning and the simulation. So it touched to me that how it can be differentiated between the skill learning and the simulation, and also that we have to just balance between the services and the education. How we can manage these two things that it can be help or going to help to the students. So it's our responsibility that how we can manage, and still we are moving and going to do this. So this is my learning of today's. Thank you.
It is so important that these testimonials, they show us that there is a basic learning, there's a basic multiplication of information that we've received, and some of our basic concepts of simulation, of simulation-based learnings have been cleared, and we've gained more confidence in our education stream as well. Now, for getting into the recap of the day, I would like to call our dear moderator Ambika to take us through till the end of the day.
Good evening, everyone. Firstly, I want to thank you each and every person here for being a wonderful audience. As we wrap up day one of our session, let's take a moment to reflect on the highlights and key takeaway from today. We have covered a lot of grounds, and it's important to review what we have learned so far. Through engaging discussion and expert insights, we delved into the INACSL standards of best practice, guiding on us how to integrate simulation systematically and meaningfully. A powerful video structured process of learning a simulation, making the concept come alive. Our focus today was on the first two critical components of simulation, that is pre-briefing and scenario presentation. Our esteemed panelists shared their vision and strategies to bridge the gap between theoretical knowledge and hands-on competence, that is transforming brain power into hand power. But the journey doesn't end here. Tomorrow, we dive into the most crucial phase, that is debriefing, where deep learning and reflection take place. Be sure to join us on time as we continue to unlock the full potential of simulation in nursing education. So enjoy your evening, recharge, and get ready. We can't wait to see you all back here bright and early. Before leaving, let's have a glimpse of day one. So in the end, I just want to say thank you, everyone, and tomorrow we'll wait for you.
Yes, there is tea outside, so on your way out of here, please do take tea, have tea, and definitely enjoy the networking opportunities. Do speak to the mentors and the teachers. They're bringing a lot of experience with them.